everybody. Welcome to Magic Day 2, 2022. We're excited to have you joining us this morning. We have a wonderful day ahead of some spectacular lectures as well as live cases, and we are looking forward to a wonderful day.
I'd like to first thank the course organizers of the MAGIC Conference and Castle Biosciences for the opportunity to speak to you today. It's an exciting time in the world of Barrett's esophagus and esophageal cancer. And today we're going to review some updates in screening and surveillance for Barrett's esophagus in 2022. This first slide is a real patient who had a screening or surveillance endoscopy prior to COVID, and this was a very innocuous-looking non-dysplastic Barrett's who subsequently got scoped a little bit delayed, but not out of the interval of a 3 to 5 year surveillance, and was found to have this nodular adenocarcinoma. And this will highlight some of the things we're going to touch on around risk stratification, and could something have been done for this patient despite a diagnosis of just non-dysplastic Barrett's that might have stratified the patient's risk to develop an aggressive cancer like this in a short term. We're all very familiar with endoscopic eradication therapy, and we're not going to talk about the details of this today, but this slide has a purpose. We become excellent at treating Barrett's esophagus and Barrett's-related neoplasia, whether it's EMR, RFA, cryotherapy, and the bottom line here is that we can achieve 90% complete eradication of disease with a very low recurrence. And this is a piece of information I want to use to set the table for why we need to really focus on some of these updates in screening and surveillance, because it's going to come down to a denominator that we need to increase to bring to this table where we can eradicate this disease. So why can't we find the needle in the haystack? What are the goals for screening and surveillance when we talk about Barrett's esophagus? We want early and accurate detection of dysplasia. We need to identify visible lesions which may harbor neoplasia, and risk stratification, and that's really going to be a crux of what we're going to talk about today, is how do we take that pool of non-dysplastic Barrett's and identify patients who will develop high-grade dysplasia or cancer, or may have a prevalent high-grade dysplasia or cancer. As we know, our sampling techniques are not optimal. Dysplasia detection remains endoscopist and pathologist dependent, and our continued requirement for GERD as a prerequisite for screening, which is something that will change, is our largest limitation. So we may actually have created a situation where innovation and evidence for therapy of a disease has far surpassed our ability to diagnose it. And so the depressing part is, while that we become very effective in endoscopic eradication therapy for Barrett's neoplasia, we've made no significant impact on the incidence of esophageal cancer. So this is a long paradigm, but a very standard paradigm that highlights some of the questions that we need to raise in 2022. As we march down from screening and surveillance into some of our best practices and our high-quality exam, high-definition white light, targeted sampling of visible lesions, Seattle protocol, pathology interpretation, and then diagnosis. A lot of the questions on the right are things that I will address, but include things like the use of NBI or optical chromoendoscopy in improving our exam. And so the top part of this is really, how do we improve amongst the patients that we already see and do surveillance on? This isn't about increasing the screening paradigm, but it's actually about how do we do a better exam? And then how do our endoscopists and pathologists improve their diagnostic capabilities? As we get to the bottom, we have sort of different degrees of dysplasia or types of Barrett's that we see. And some of this are very straightforward. When we identify high-grade dysplasia or cancer, we send them for endoscopic therapy. With low-grade dysplasia and indefinite for dysplasia, these are some patients that sometimes need a little more information, and we're going to talk a little bit about the impact of TissueCypher in this role to really provide a pure low-grade dysplasia that we can confidently send for endoscopic therapy. And then sort of the biggest elephant in the room is our patients with non-dysplastic Barrett's over here. And that's where we need risk stratification. And we're going to talk about why the data behind a technology such as TissueCypher is going to allow us to identify that and in a more important way, increase that denominator of patients we can treat. So why is all this important? What's the issue? I never have an issue with my patients. And so one of the things to keep in mind when the denominator of patients we're looking at in terms of surveillance and screening is low, you're going to have practitioners who feel like they never see their Barrett's progress. But there is an issue, and this is one study that highlights this concept of a neoplastic detection rate or neoplasia detection rate. And this is something similar to what we might think of as an ADR adenoma detection rate. And this was in multiple centers in Minnesota, and it identified that 13% of patients had missed dysplasia. So what this highlights is our standard endoscopy, our standard biopsies, our standard protocol, as I outlined, is not without significant errors, right? And so we know that, but this is some data finally identifying this 13% number is very critical in terms of missed neoplasia. This was further emphasized by the idea of PEAK, or post-endoscopy esophageal adenocarcinoma, and this was a study published in 2021 in CGH, which looked at a large Medicare database. And again, the long and short of it, they identified this post-esophageal detection. So basically what we're talking about are missed cancers or missed neoplasia, and that again was at 13.7%. So what are we talking about? We're talking about the existing ability that we have with endoscopy, despite what would be perceived as high-quality exams, is still not enough for us to make accurate diagnoses, and we need some help from adjunct tools. So when we get into a high-quality exam, time is everything. This was some data out of the ESGE guidelines. There's been a few studies in the U.S. looking at Barrett's inspection time, so how much time we spend in the esophagus identifying neoplasia. And again, visible lesions are the critical piece here. And they identified that greater than 1 minute per centimeter is ideal for this. And this is difficult. And as all of you as endoscopists know, spending a minute looking at every interval in the esophagus is very tricky. And so can we look at different adjuncts, and we're going to touch on some of these tools that may obviate the need for this. So this is a sort of laundry list, but identifies that high-quality exam. I bring this into your vision, and not to review everything on here, but this is something you'll find not only in the recent AACG guidelines, but also in the very recent AGA Barrett's esophagus screening and surveillance clinical practice update that highlights some of the things we look at as a high-quality exam, some of the things that might be looked at as quality metrics in the future, and a lot of the things that are used by our machine and our colleagues in the artificial intelligence field who are going to identify how we develop AI algorithms when we're talking about machine learning. This is just a typical example of what we see with visible lesions. Very difficult here. The key piece and what has been highlighted by the clinical practice update in the AGA document is the use of NBI becoming standard of care. This is also highlighted in the ACG guidelines. And as you can see here, narrowband imaging on these subtle lesions provides a much better visualization of a neoplastic lesion in Barrett's. So as we move forward out of this, you know, what should we be doing in practice, right? We talk about high definition white light. Now narrowband imaging is standard of care, should be utilized by everyone in all stages of diagnosis and screening and surveillance. Some of these other tools are still in early adoption and research only in terms of confocal endomicroscopy. AI is the sort of the buzzword, and it's probably the buzzword of this meeting for this conference. And we are in the process of developing these algorithms for the machines to understand how they can help us. But ultimately, this is going to be augmented intelligence and not artificial intelligence. This is going to be physicians and our tools and innovation that are going to help us identify neoplasia. But as I said, there's more innovation that's going to be a part of our decision tree. And before we get into that, one of the most important points here is this slide. When we looked at, and this is two different studies that looked at prevalent esophageal cancer, so patients who had diagnosis of esophageal cancer presented to a surgeon, they went back and said, how many of these patients actually had known Barrett's? And as you can see, the patients in blue never had a precedent diagnosis of Barrett's esophagus. Why is that a problem? Because if patients don't come to us now with GERD or swallowing difficulties, we're not going to identify that big piece of the puzzle. Again, I spoke to the denominator. We have to increase the number of patients we screen, and we have to increase the number of patients who have non-dysplastic Barrett's we treat. And so those are the two key pivotal points that we're going to focus on. And so understanding that the patients we are talking about today that we're dealing with is a very small piece of the pie in red here, is a critical piece of that. So this is the most recent document that I'm alluding to, and this is the 2022 AGA Clinical Practice Update. And it addresses those two buckets of increasing the denominator. First of all, screening with standard upper endoscopy may not be considered in individuals with at least 3 established risk factors for Barrett's or esophageal cancer. This includes male gender, non-Hispanic white race, age greater than 50 years, history of smoking, chronic reflux, obesity, or a family history of Barrett's or esophageal cancer. The key piece here is that GERD has now become just another piece of the risk factor pool and not a prerequisite of itself. And I think that's going to be critical, and I'll touch on that in a second. We talked about this one. I'm going to skip over this. White light endoscopy and chromoendoscopy are essential. Non-endoscopic cell collection devices, so things such as cytosponge, things such as EsoCheck, all these different devices that are tethered capsules or non-invasive, non-endoscopic cell collection devices can be considered. And these are things that we still need more data before we go mainstream and things that are going to be critical as we increase that screening pool. And perhaps the biggest piece on the other side of this denominator is risk stratification. And so the tissue systems pathology-based prediction assay, or TissueCypher, is going to be essential. And the data is now ripe at fruition in terms of demonstrating this tool being critical for us in practice to look at that pool of non-dysplastic Barrett's. So while the other 3 points on here help us identify more patients who have Barrett's, we're also going to increase the pool of non-dysplastic Barrett's. And not every non-dysplastic Barrett's patient is alike. And I think that's where this critical implementation of TissueCypher is going to help us understand who we can take from a surveillance pool and treat, and then perhaps even who we can take from a surveillance pool and increase or reduce their surveillance interval because their scoring on the TissueCypher assay is so low that their risk may be much less than a standard patient. So where do we stand in 2022 with this? We need to increase the denominator of patients with Barrett's and Barrett's-associated neoplasia. How do we do this? Number one, we talked about screening patients without reflux. We need to start looking at patients who don't have the typical symptoms of GERD, who have put us in the window where we just don't make an impact on the larger population of that pie chart I showed you. And then finally, the risk stratification of non-dysplastic Barrett's, which we're going to focus on in the last part of this talk, is how do we use this assay specifically to risk stratify patients? When we talk about screening, I want to shift gears here, and we're going to just touch a little bit about the screening paradigms available and then go right into the risk stratification piece. So this is just a summary of some data presented by Joel Rubinstein around clinical risk stratification. And perhaps the most important thing here is what these curves here show you, these sensitivity and specificity curves really highlight, is that these clinical risk stratification scores, and the one here that was looked at as the Kunzman score, significantly improved prediction for Barrett's-associated neoplasia over the presence of GERD symptoms alone. So no longer, and we looked at multiple studies that have been published out of this group, have demonstrated that the odds ratio of GERD alone is extremely low compared to using a larger clinical risk stratification tool. And ultimately, all that's pointing out is that reflux symptoms alone are not enough as a screening tool to decide who needs endoscopic evaluation for Barrett's esophagus. Ultimately resulted in a study that ideally helps us reduce the number of needles in our hay. So this was looking at 663 patients with esophageal cancer, and what they basically found is using the current societal guidelines around screening prior to this clinical practice update, that 54% of patients would not have been detected. And so that, again, highlights why that pie is so big. This chart just sort of depicts many of those non-invasive tools that are available or coming available. I'm not going to go through this laundry list, but these are things that are evolving. Research is evolving. We're discovering how to use them in clinical practice. And the update allows us to start looking at these inpatients as a non-invasive tool in our clinics. One of the biggest advances in innovation for us, and it's reflected in the clinical practice update, is this tissue systems pathology assay, or TissueCypher. And so what is it? It really allows us to combine tools and combine different forms of science to make an objective assay for Barrett's risk stratification. The first part focuses on the use of a large panel of biomarkers and the idea of spatial biology. And Barrett's is a spatial disease, and some of the studies in the TissueCypher world have demonstrated not only the improvement of prediction of disease along the length of Barrett's, but also through time. As you know, Barrett's is a disease we sample over time, and we can determine progression that way. But this uses molecular biomarkers to detect changes in the context of the spatial tissue structure prior to some of those morphologic changes we see with standard pathology. Then the idea of digital microscopy, so this taken back, and vision systems that are used objectively and reproduce and analyze and interpret different tissue structures based on these biomarkers and features that are predictive of progression. Then, of course, the concept of AI, and where does AI fit here? Ultimately, you got to use these large data sets to train a computer, to train a system to recognize what is a progressor and what is a non-progressor. And that's where TissueCypher uses artificial intelligence to use on our system, on our tissue samples that have gone through what I've pointed out here from a biomarker assay, and then give us the idea of who is a progressor and non-progressor that we can translate into clinical practice and again, increase our denominator for therapy. And finally, one of the reasons we're talking about this and why this is a part of our clinical practice update is all about clinical validation. And TissueCypher has been through many rigorous studies that you're familiar with. There are 5 pivotal studies in terms of peer-reviewed publications that have launched this into prime time and really allows us to bring this tool to our clinicians in all practices to risk stratify patients with non-dysplastic Barrett's esophagus. So some of that data is presented here, and this was in the American Journal of Gastroenterology, and really looks at Barrett's patients. This was a blinded independent validation study looking at patient progressors and non-progressors with baseline non-dysplastic, indefinite for dysplasia, and low grade. And what you can see from here is that TissueCypher identified a subset of patients with non-dysplastic Barrett's that progressed to high-grade or esophageal cancer at a higher rate than even confirmed or vetted low-grade dysplasia by a standard pathologist or an expert pathologist. So the idea is that high-risk scores in patients with non-dysplastic Barrett's can support their early use of endoscopic therapy. So TissueCypher becomes actionable. So we can take some of the limitations we talked about that can actually lead to some of the peak or missed cancers and use them earlier in our patients with non-dysplastic Barrett's and create actionable paradigms for us in clinical practice. So this is the most recent TissueCypher pooled analysis performed by the Mayo Group. This was 552 patients, and basically looked at the risk of progression to high-grade dysplasia or esophageal adenocarcinoma, again, inclusive of non-dysplastic progressors, indefinite, and low-grade dysplasia. And so one of the first things you see here without TissueCypher is that 5.8 for a higher odds ratio by an expert pathologist of low-grade dysplasia or vetted low-grade dysplasia versus non-dysplastic Barrett's. But then when we come over to this graph and we look at the addition of TissueCypher, what you see is an attenuation of that odds ratio, and basically that it's identifying that the use of this assay is giving you that purified or more vetted population. So it's even a better tool to find that population of patients with indefinite or low-grade dysplasia that we want to then put through endoscopic eradication therapy. The final piece of this, which is even the most important from my perspective, is look at the prediction of TissueCypher in this predominant group of non-dysplastic Barrett's as a predictor of progression and an odds ratio of 6. So we've reached a point where multiple studies have demonstrated that this assay, again, allows us to take our pool of patients, whether non-dysplastic or those confusing indefinite patients, and bring them to a much more definitive diagnosis and, again, an actionable treatment plan, whether that's surveillance, therapy, or extension of surveillance interval. In the last couple slides, I want to just talk about where does this all bring us to? And so we have a slide here that highlights a Barrett's care pathway. Everything we do is based on quality. Everything we do in medicine now is treatment paradigms in terms of these care pathways. And so some of the new things that will be changing as we move into the next sort of year here is this first box. Again, we will all need to work together to increase the denominator with screening. And so this idea that GERD now becomes one of the clinical risk factors that we're dealing with is something that we're going to further assess and study and identify. How do we effectively work with our primary care colleagues to find these factors and how many of these risk factors are critical? And I think what it's going to allow us to do is bring more people into the center of this pathway, into our clinics, to look at them from a risk stratification standpoint clinically, use non-endoscopic measures, some of these non-endoscopic tools for screening, and create a more comprehensive care pathway for screening. And then ultimately, as we were talking about here, is what do we do after we bring them through endoscopy, and how do we risk stratify this much larger pool of non-dysplastics that we find, and how do we better care for some of our indefinite and low-grade patients? And the use of TissueCypher here, again, as we highlighted before with some data and how mechanistically this looks at all these different hits that we take molecularly, but in a much more robust fashion is going to give us a risk score that we can action. We can take action as clinicians, identify the right population of patients we can now treat with non-dysplastic Barrett's. For the last 20 years, guidelines have been confusing around non-dysplastic Barrett's because we haven't incorporated a paradigm like TissueCypher that helps us objectively and not subjectively make decisions for our patients. So I want to end with a slide. This is bringing it all together. This is all about where we stand in 2022, which is so different than where we were in the last 10 years. We have many best practices in terms of screening and surveillance that are highlighted in this, again, most recent clinical practice update, whether it's preparation and some of the things we do with the endoscope, to inspection, the use of chromoendoscopy, speaking the same language in terms of landmark identification, adequate Barrett's inspection time. These are all things we can do, again, to identify the visible neoplastic lesions. But again, we're still hindered by some of the, the limitations of human intelligence, for lack of a better word here, and our sampling protocols, which include Seattle Protocol for, 4-quadrant sampling. So ultimately, we need to move forward and use the tools we've talked about today. And specifically, the breakthrough here has been in risk stratification and the use of TissueCypher, again, to objectively identify our patients and overcome a lot of the limitations I showed you in that algorithm and identify these patients that we can now bring into a treatment paradigm and, again, reduce ultimately that risk of esophageal adenocarcinoma as we move forward. Thank you very much. And as we outlined, we will stop now and take some questions from the audience.
Hello, everyone. I'm Prasad Iyer from the Mayo Clinic in Rochester, Minnesota. And it is my pleasure to present this lecture on cryoballoon ablation for Barrett's esophagus, recent evidence. I would like to thank the organizers for their kind invitation. The cryoballoon ablation system consists of several components. These include a handheld controller, which controls balloon inflation and activation of the nitrous oxide spray. A second component is a catheter, which advances through the biopsy channel of a therapeutic scope or on the outside of a diagnostic scope with an adapter. This catheter delivers the nitrous oxide, which is the primary agent for freezing the mucosa, and also contains a rotating diffuser. The third component is a foot pedal, which allows rotation of the diffuser as well as longitudinal movement of the diffuser away from the endoscopist or towards the endoscopist. The final component is the nitrous oxide cartridge, which allows up to 5 treatments along with test doses. 2 types of treatment catheters are available at this time commercially: a focal, approximately 3 centimeter long balloon catheter and a pear-shaped balloon catheter, which helps treatment across the GE junction in case there are anatomic abnormalities. So how is cryoballoon ablation performed? This is a small video. As you can see, I'm inside the esophagus with the balloon catheter in the center. The balloon is inflated, and there is Barrett's mucosa. This is a narrowband imaging, and I'm delivering some test doses to see if the spray is aligned with where I want the treatment to be. And once I am convinced that I am in the right spot, I can then activate the treatment, which is typically a single treatment of 8 seconds and leads to this focal ablation zone. I then can rotate the diffuser clockwise or counterclockwise to then come to the 4 to 5 o'clock position and treat that island as well. So again, as you can see, this is fairly intuitive and allows excellent visualization through the balloon, looking at the mucosa, and only a single treatment is required without any freeze-thaw cycles. So what are some of the results of cryoballoon ablation? There are several smaller studies that have recently been published in the literature, but I'm going to focus on the largest trial, which was a prospective multi-center cohort study called Coldplay 3. This was published in the American Journal of Gastroenterology in 2020 and consisted of patients recruited at 11 centers, 9 academic centers, and two private practice centers. Primary outcomes were complete eradication of dysplasia at 12 months and treatment-related serious adverse events. Secondary outcomes were complete remission of intestinal metaplasia at 12 months. A total of 120 patients were enrolled. The mean Prague classification was C1M3, of which about 46% had prior EMR. And this is essentially because of a substantial number of patients who had intramucosal cancer or high-grade dysplasia, a total of 76%, and the remaining 24% had baseline low-grade dysplasia. So how did these patients do? So at the completion of the trial, 92 patients were fully evaluable. That is, they had endoscopy and histologic outcomes that were available. And in this bar chart, you can see results of complete eradication of dysplasia as well as complete eradication of all intestinal metaplasia. The blue bars represent the best case scenario, wherein 10 patients who were not evaluable were presumed to have responded, whereas the orange bars are basically the worst case scenario, wherein the 10 patients who were not evaluable were thought to be non-responders. So you can see even in the worst case scenario, the response rates were fairly impressive. Complete eradication of dysplasia, 89%, complete eradication of intestinal metaplasia of 82%. One of the main advantages of any kind of cryotherapy is that patients tend to experience less pain. And again, you can see the pain scores. And these were ranging from about a 2 on immediately after procedure, and then steadily decreasing down to 0 by almost day 4, day 5, and definitely by day 7. In terms of adverse events, stricture rate was 12.5%, serious adverse event of 1%, of which this consisted of 1 perforation, which actually happened during a dilation, not during treatment, 1 GI bleed, and 1 hospitalization. So what are some of the limitations of this technique? At this time, there is no circumferential treatment balloon. Unlike radiofrequency ablation that is commercially available, there are some ongoing trials in Europe. This leads us to preferentially use this in shorter Barrett segments. And as I alluded to before, a larger surface area device called the 180 catheter is currently in development. Of course, we cannot ignore the stricture rate, which at least in this paper that I presented is somewhat higher than was seen in the RFA trial, and might be influenced by the fact that a substantial number of these patients underwent resection, given the higher percentage of patients with intramucosal cancer and high-grade dysplasia, and may need some modification in dosimetry. How about, and of course, we cannot ignore the fact that we still do not have any randomized control trial evidence, which, as you know, does exist for radiofrequency ablation, both in high-grade dysplasia, published about 13 years ago now, wherein administration of radiofrequency ablation did reduce the risk of progression to cancer or any progression, as well as in low-grade dysplasia, published in JAMA in 2014. So taking this into account, we published a manuscript which focused on comparative outcomes of radiofrequency ablation and cryoballoon ablation in dysplastic Barrett's esophagus. This was, of course, a non-randomized study, but these were the other highlights. So this was essentially patients treated over about a 6-year duration at Mayo Clinic Rochester, as well as Northwell University. And the decision of administering either radiofrequency ablation or cryoballoon ablation was basically made by a shared decision-making approach between the treating endoscopist and the patient. Cryoballoon ablation was essentially restricted to those with a maximal Barrett segment of about 6 centimeters, given the challenges of treating longer segments with a focal balloon ablation catheter. So the outcomes for our paper were rates and predictors of complete remission of intestinal metaplasia. And we defined this as 2 negative endoscopy and histology results. Secondary outcomes were rates and predictors of complete remission of dysplasia, as well as the rates of adverse events, typically being perforation, bleeding, and strictures. So let's look at the baseline characteristics here. This is essentially table 1 of the manuscript, and we had a total of 226 patients who underwent radiofrequency ablation compared to about 85 patients who had cryoballoon ablation. And as you can see, the baseline characteristics were largely similar. I'm going to highlight some differences. Again, this is fairly obvious that patients who underwent RFA had slightly longer Barrett segments. One should also note that the proportion of patients who underwent resection was fairly high in both of these groups. It did not meet statistical significance, but at least numerically, the rate was higher in the cryoballoon ablation group. Patients undergoing RFA had a higher BMI and also had a slightly higher sized diaphragmatic hiatus. A hiatal hernia. Let's look at outcomes. And as we said, our primary outcomes were complete remission of intestinal metaplasia. And again, remember, this is without adjusting for any of the baseline variables. And at least numerically, the rate of achieving CRIM at 1 and 2 years was higher in the cryoballoon group, and this had a trend to statistical significance. There was no difference in the rate of complete remission of dysplasia at 1 or 2 years. And in terms of adverse events, it should be noted that patients undergoing cryoablation did have a slightly higher stricture rate of 10.6% and compared to 4.4% in the RFA group, with the p-value being significant. Now let's look at predictors of complete remission of intestinal metaplasia. And remember, this was the sort of the primary objective of this paper in terms of comparing the predictors as well as the rates of getting to CRIM, which is our objective in treating patients with dysplastic Barrett's. And when you adjust for some of these other factors, such as age, gender, body mass index, maximal Barrett segment length, prior endoscopic resection, and baseline histology, there was the modality of ablation that was used was not a significant predictor of response. In fact, reassuringly, some of the more conventional factors, such as the maximum Barrett segment length, which was a predictor of decreased response. So again, this makes sense. The longer the Barrett segment length, the lesser the likelihood of reaching complete remission of intestinal metaplasia. And undergoing prior endoscopic resection actually predicted favorably reaching CRIM, which also makes sense. We also did a subset analysis of patients who only had segment lengths of up to 6 centimeters. This reduced our sample size to 235, and the results were by and large very similar. So remember, we also talked about doing something called a propensity score matched analysis, and this is another way of essentially balancing out the variables which we think would affect response. And when we perform propensity score match, we had 85 patients in the radiofrequency ablation group and 85 patients in the cryoballoon ablation group. And again, you can see the love plot here, wherein you have the variables which were adjusted for on the y-axis and the standardized mean difference between the two groups on the x-axis. And the blue observations are those which were before the propensity score match, and the red observations are those which are after the propensity score match. And as you can see, when we match with a propensity score, we are actually reducing the difference between the groups in terms of these variables. So BMI went from being outside the standardized mean difference window to within, and similarly, these other variables are now much closer to a standardized mean difference of 0. So when we perform this propensity score analysis and we adjusted for all of these variables, again, the probability of achieving CRIM, which was the primary variable, was similar between the two groups, with no statistically significant difference between the groups treated with RFA or cryoballoon ablation. And again, similar to the previous analysis, we repeated this analysis in a cohort of patients with a Barrett segment of up to 6 centimeters, with, again, a decent sample size of 77 in both groups, and the results were very similar. So in conclusion, in this non-randomized propensity score matched analysis, the medium-term histologic outcomes after radiofrequency ablation and cryoballoon ablation for dysplastic Barrett's were comparable, both on multivariable conventional analysis as well as a propensity score matched analysis. One should note that the stricture rate was somewhat higher in the cryoballoon ablation arm, and this may have something to do with the higher rates of endoscopic resection in the cryoballoon group, perhaps a learning curve with the cryoballoon ablation. Again, it is important, given the focal nature of the cryoballoon application at this time, that overlap has to be minimized. However, of note, these strictures were endoscopically manageable, with a median need for dilation being about 1 to 2. And of course, given that this was a retrospective study, we were not able to assess the outcome of pain and compare this between the two groups. So again, thank you for this opportunity, and best wishes for an excellent course.
Pancreagen Pancreatic Cancer Risk Classifier and PanDNA Pancreatic Cyst Molecular Classifier can increase confidence when used with EUS FNA and ERCP procedures and other first-line tests to look below the surface.
Good morning, and I bring greetings from India. At the outset, I would like to thank Dr. Kahela and his team for this kind invitation to be part of this fantastic MAGIC conference and course. Let me begin by sharing my slides. Today, I will be discussing a few points about endoscopic fundoplication over the next few minutes. No relevant disclosures. We all know that there are several unmet goals in the treatment of gastroesophageal reflux disease. Up to 40% patients may be non-responsive to proton pump inhibitors. They are less effective to treat extraesophageal symptoms or regurgitation. And there are safety concerns in long-term usage as well as cost issues. Refractory reflux was traditionally treated using anti-reflux surgery, and over the last 2 decades or more, endoscopic anti-reflux modalities have come into work. Currently, several endoscopic anti-reflux modalities are available, including the radiofrequency ablation or the stretta, or we have several device-assisted fundoplication devices, the Isofix, Muse, Gardex. Mucosal resection techniques have also been described, like the anti-reflux mucosectomy or ablation, ARMS or ARMA. Or in the last few years, there is a lot of discussion about endoscopic fundoplication or POEM plus fundoplication or per oral endoscopic fundoplication. Today we will be discussing about endoscopic fundoplication. Therefore, we all know that Professor Haru Inouye described the first human POEM procedure more than a decade ago. In the last decade or more, POEM has become a highly popular procedure. It has shown excellent short, medium, and long-term outcomes in patients of achalasia. It is highly effective for all achalasia subtypes, and it is effective in the treatment of prior treatment failures as well. POEM involves creating a submucosal tunnel starting at the mid-esophagus and going across the gastroesophageal junction. And once this tunnel has been established, a full thickness or a selective circular myotomy is performed starting distal to the point of mucosal incision and going across the gastroesophageal junction for about 2 centimeters. The mucosal incision is thereafter closed using clips or sutures, and this gives long-lasting relief of dysphagia. POEM has shown fantastic results in most clinical studies. However, in the last few years, there has been an increasing concern about gastroesophageal reflux following the POEM procedure. The incidence of reflux after POEM has been estimated to be between 30 to 60%. Post-POEM reflux has emerged as a growing concern, and there have been chronic consequences reported, although they are quite infrequent. Strictures as well as Barrett's has been described in a few patients. Surgeons have always debated that during the laparoscopic hilar myotomy, an anti-reflux procedure is conventionally added. Their argument is that during POEM, an anti-reflux procedure is not added, and therefore this causes significant post-procedure reflux. We need to understand whether this argument is valid, and also we need to think as to whether something can be done to address this issue and whether we can make POEM as comparable to the laparoscopic hilar myotomy. Treatment of post-POEM reflux presently, the standard recommendation is administration of proton pump inhibitors for 24 months after the POEM procedure and on demand thereafter. Patients have been recommended to undergo lifelong surveillance for esophagitis or for Barrett's. Anti-reflux surgery has been occasionally been reported, as well as endoscopic anti-reflux procedures, either the POEM plus transoral incisionless fundoplication as a concomitant or a subsequent procedure, or POEM plus endoscopic fundoplication or peroral endoscopic fundoplication have all been reported. So let us see what these procedures are. Harvey Noy, about 3 years ago, described the peroral endoscopic myotomy plus fundoplication as a novel NOTES procedure. The principle is based on a partial fundoplication like the Dower fundoplication after laparoscopic hilar myotomy, and it involves creation of an anterior partial fundoplication endoscopically after the POEM procedure. The POEM procedure is performed anteriorly, and after an anterior POEM, the peritoneum overlying the myotomy on the gastric side is opened and the endoscope is introduced into the peritoneal cavity. The fundus of the stomach is grasped and an endoloop is fixed onto the fundus of the using several endoclips, and the proximal end of the loop is fixed within the tunnel. Once the endoloop is tightened, this creates a partial anterior fundoplication, and this is how it has been described. So how do we prepare these patients, and what is the equipment required? Well, the workup is standard as for POEM procedure. Of course, these patients may be subjected to pH studies prior to the POEM procedure for optimal follow-up thereafter. Standard equipment that is required for POEM is used. However, we need one more endoscopist with a transnasal ultrasim endoscope that needs to be introduced concomitantly alongside the regular gastroscope. We need, in addition, an insulated tip knife. We need several more clips, and we need an endoloop plus an applicator and an endoloop cutter or endoscopic scissors, and we need equipment for abdominal paracentesis. So this is how the procedure is performed. This is an achalasia with a dilated esophagus. POEM is performed anteriorly using the standard technique. A submucosal bleb is elevated by submucosal injection of methylene blue stained normal saline. The submucosal tunneling is performed going across the gastroesophageal junction. We can see over here, we are crossing the cardia over here. Thereafter, a full thickness myotomy is performed, again extending beyond the gastroesophageal junction onto the gastric side. Once the full thickness myotomy has been performed, the diaphragm is very nicely visible over here. A transnasal endoscope is now passed concomitantly into the gastric fundus and is positioned in the gastric fundus in retroflexion. Transillumination is performed using the scope within the tunnel to confirm the position of the scope on the gastric side. The peritoneal opening, the peritoneum overlying the gastric side of myotomy is gradually opened using a coagulation forceps. Care should be taken over here to confirm hemostasis and have optimal hemostasis, because bleeding can occur and it can be intraperitoneal. The left lobe of the liver is now visualized. We can see over here the left lobe of the liver behind the peritoneal fold. And now the peritoneum is opened using diathermy. A small opening is created. An insulated tip knife is now passed through this hole and the peritoneal opening is widened. The endoscope is now passed into the peritoneal cavity and turned upwards and leftwards. Using a strong grasping forceps, the fundus of the stomach on the lateral aspect close to the splenic hilum is grasped. On the transnasal endoscopy, the stomach should be deflated at this point to get a good grasp onto the fundus, and we need to hold on to the muscle. A wrap is simulated to confirm that it is optimal. The fundus is pulled back into the tunnel, and this is how the wrap is going to look later on once it has been completed. The fundus is now released back into the peritoneal cavity, and this point is marked using a triangular tip knife and some coagulation. Endoscope is now withdrawn and is reintroduced, holding an endoloop within an endoclip, and it is passed through the submucosal tunnel onto the gastric side and then through the peritoneal opening into the peritoneal cavity. The mark which we had made earlier is identified, and the endoloop is fixed to the serosal aspect of the fundus using strong clips. Several clips are used, typically about 3 or 4, to distribute the tension on the wrap. That's the third clip. Now the scope is withdrawn into the tunnel, and the proximal end of the endoloop is now fixed to the right lip of the myotomy, again using several clips, typically 3 or 4. Once the endoloop is secured using these clips, it is tightened gradually. Here we can see that the endoloop is being gradually tightened. And once the endoloop is tightened, it is released. We can see the wrap. The endoloop tail is trimmed, and now the plastic sheath of the endoloop is turned and pushed towards the peritoneal cavity to avoid any mucosal injury. And once that has been done, hemostasis is confirmed and the scope is withdrawn after closing the myotomy. And this is how the final wrap looks. It looks quite secure. So Professor Inouye in his original paper reported POEM F having been performed in 21 patients with a 100% success rate. Operating time was about 120 minutes. Fundoplication time was 51 minutes. There were no adverse events, and the wrap maintained at a 3-month follow-up in 95% patients. So the conclusion was that POEM F was safe and feasible. Thereafter, our group reported a 1-year follow-up study on 25 patients who underwent POEM plus fundoplication at our center over a period of nearly 1 year. Post-procedure follow-up was done using endoscopy, PS studies, and GERD-Q scores. Technical success of POEM was 100%. However, POEM plus fundoplication failed in two patients because of technical failures. The mean total procedure time was 115 minutes. However, using a moving average graph, we realized that there was a learning curve involved, and the initial 5 cases took much longer as compared to the subsequent cases. The mean additional time for fundoplication was about 46 minutes, and there were no major adverse events. There were minor delayed adverse events in three patients. During follow-up, we can see that majority of patients had good symptom relief of reflux. The RAP was maintained intact in 83% patients at 1 year follow-up, and PS studies revealed that only 2 out of 18 patients, or 11%, had reflux, whereas all other patients did not have reflux. So that is very important as compared to the conventional reflux incidence after POEM, which is around 25 to 30%. 2 patients we can see over here. In those patients where we found reflux, the RAP had loosened in one patient. However, it was adequate in the other patient. And there were 4 other patients who had minimal grade A esophagitis. However, their GERD-Q scores as well as acid exposure scores were quite normal. Therefore, using the Lyon consensus, we could see that conclusive post-POEM reflux was seen in about 11% patients. Therefore, the study conclusions were that POEM-F was feasible and safe, and there was a low incidence of post-POEM plus fundoplication reflux, which was acceptable and comparable to that after laparoscopic hendeheller myotomy plus fundoplication, although we do recommend that longer-term follow-up and comparative data is warranted. Subsequently, this year at DDW, we presented our abstract on 39 patients who have undergone now follow-up up to 2 years, and 2-year follow-up has been completed for 29 patients, and we can see that the reflux incidence is 10.3%, or in 3 patients out of 29 had required PPIs. However, most others were off PPIs. Another abstract from which was a comparative study between the Rutgers group and our group, where we compared results of POEM plus endoscopic fundoplication with anti-reflux mucosectomy for post-POEM reflux, demonstrated that the procedure time and post-procedure length of stay was longer for the POEM plus fundoplication group. However, need for repeat interventions was higher for the ARMS group, and no repeat interventions were required in the POEM plus endoscopic fundoplication group. Therefore, the incidence of reflux was comparable in both groups. However, each technique had some pros as well as cons. 2 years ago, we also presented our video at the DDW, where we demonstrated certain technical nuances and challenges, and we made some improvisations in the technique of performing POEM plus endoscopic fundoplication as compared to the original technique described by Professor Inouye, which we believe adds to simplifying this procedure further. So the moot question is, should fundoplication be added to every POEM procedure? Well, the factors in favor of this argument is that POEM plus endoscopic fundoplication replicates the laparoscopic Heller myotomy plus fundoplication. The preliminary results as well as 2-year results are quite promising. It is a feasible and safe technique. It is reproducible. It has a short learning curve of about 5 procedures, and it is relatively inexpensive as compared to most device-assisted fundoplications. The points against a routine fundoplication is that post-POEM reflux is mild and it is PPI responsive. The procedure could be considered as technically challenging, but we believe that the learning curve, once beyond the learning curve, it becomes easier and easier. One does require additional resources like the double endoscope technique, which involves one more endoscopist. The procedure is still evolving, where endoloop plus clip or suturing both have been described. The long-term RAP integrity and outcomes in many other studies is also a little bit of a doubtful thing. People are still not very convinced about it. And whether we should perform the procedure at the same session or a second stage is still a debatable point. However, we need to remember that the need for fundoplication after myotomy, and this debate has been raging for more than 60 years now, because there have been proponents against doing a routine fundoplication after a regular hilar myotomy as well in earlier times. However, Haru Inouye's group has also published this fantastic video wherein they performed an peroral endoscopic fundoplication or a POF procedure in a patient who had undergone an earlier posterior POEM. They created an anterior tunnel with a short myotomy distal to the gastroesophageal junction to enter into the peritoneal cavity, and they also used a novel needle holder with a needle which was used to suture a pledget through the fundic wall and tighten to create the wrap. The loop and clip can also alternatively be used, but then probably the suture could be more secure. Therefore, currently, friends, what we can say about POEM plus fundoplication or peroral endoscopic fundoplication is that it is feasible and safe. The outcomes at 12 and 24 months are impressive. The technique is still evolving and modifications have been described. What do we need? What is needed? Well, we need long-term prospective and comparative data. Comparisons also need to be made between alternative endoscopic anti-reflux methods and with laparoscopic fundoplication, and the optimal timing, concomitant versus subsequent fundoplication, needs to be answered. For this question to be answered, we need to understand that we need to identify which are the patients who are likely to develop post-POEM reflux. If we can identify them before under subjecting them to POEM, we can answer this question better. And the other important question that we need to discuss is possibly, can peroral endoscopic fundoplication be used as a standalone technique for treatment of refractory reflux? Although this procedure was developed for post-POEM reflux, it could also be considered for patients with refractory reflux. However, I think at the present moment, optimal patient selection remains the key. And with that, if we have the optimal patient selection, the outcomes can be very gratifying. Thank you so much. Thank you for a patient hearing.
Hi, good morning, everyone. Nikhil Kumta here with Prashant Kadia. Welcome everyone back for day 2 of MAGIC. We just heard 3 very exciting lectures, and we're now going to move on to a video case-based portion of the program this morning. So Prashant, why don't you start off with the first case, please?
Okay, so thank you, Nikhil. That was a fantastic first couple of lectures, and we're going to do some cases as we talked about. The first case that we're going to present is a new kind of utility of myotomy, a newer indication for it at least. This was a 25-year-old female who presented for the evaluation of severe PPI-dependent GERD after a laparoscopic sleeve gastrectomy. So sorry, not stenosis, but gastrectomy. But she did develop a stenosis here. So her laparoscopic sleeve was performed about 8 months prior to presentation to us, and she had lost 110 pounds in that time, was unable to slow down her weight loss, and her BMI had gone down to about 19.9. So getting to be in an unhealthy range for her. She was on 40 milligrams twice daily of omeprazole, still having significant reflux with intake of liquids or solids to levels having some degree of PO intolerance. An upper GI series and an endoscopy were ordered for her. So this was her upper GI series. Nikhil, when you see something like this, what are you concerned about with these patients?
Yeah, I mean, this is a very concerning upper GI series. You can see that there's a very, very profound stenosis there around the incisura. This is usually a location where when the surgeons staple down too far, you can create a very high pressure zone. And so you can see that there's already a consequence of that with more proximal dilation of the stomach. And in some cases, that's where a leak will occur in the proximal stomach. So usually for post-sleeve stenoses like these, our therapy needs to be aimed at reducing that high pressure zone at the incisura.
Yeah, exactly. So this is an interesting pathophysiology, as you mentioned. When these sleeves are created, surgeons usually will do them over bougies or whatnot to try to protect the size of the lumen. However, in some cases with the stapling and potential fibrosis after the surgical intervention, there's two reasons a stenosis can occur. One is just scarring that leads to submucosal scarring of the gastric tissue, and then there's a physical obstruction. And then the other one is an axial deviation, and it happens where the stomach is angulated at the incisura because of the axis of how the wrap kind of turns out. And it's hard to tell that from these upper GI series, but those are two things that you have to consider. The other interesting thing in this upper GI series is that there is a kind of a diverticulum forming here in the top half of the fundus. And so this patient is having a reservoir effect from this stenosis that is really probably driving a lot of her reflux symptoms because they're not passing through, and she's constantly having this regurgitation effect. And so this was concerning, and we thought about what we can do. So, in our lab, and I think a lot of places, standard treatments to try to consider, endoscopic dilation for these procedures. Have you done that for these types of cases, Nikhil?
Yeah, it's a great question. I think that it depends on the timing from the sleeve gastrectomy. If they're in the acute setting, oftentimes we will not go up with a big balloon. We don't disrupt the staple line. But if they've been out a few weeks, then we will use a pneumatic balloon dilator, usually up to 30 or sometimes 35 to really try to expand that potentially stenotic or fibrotic area and try to improve the outflow from the stomach.
Right. Yeah. So that's all pretty standard. You can increase the size of these balloons. Generally, what we're looking for is if any ischemia develops around the balloon before it is inflated, that's when you need to be a little bit careful about whether you're going to tear through or cause some significant damage. But if you don't see that, then you can continue to do these procedures. There have been some case series using esophageal stents as well. But the overall efficacy of these balloons is reasonably good, but not perfect. So we did do that for this patient, 30 millimeters up to 60 seconds, and we did not improve her symptoms at all, which made me think that this is probably more of an axial issue as opposed to necessarily a scar.
Yeah, one of the things that also has been described is utilization of stents, as you mentioned. But what I tend to find with stents is that there's the distal end of the stent oftentimes will get impacted into the stomach wall, and you'll sort of create an ulceration there. You also have to be mindful about migration. So oftentimes I try to have the stent extend up into the esophagus and then perform stent fixation either with endoscopic suturing or another modality.
Yeah, all great points. So because the dilation didn't work, we had a long discussion with the patient, and a decision was made to proceed with the modified gastric pearl endoscopic myotomy with septotomy for sleeve release. So this is the video here. going into just past the GE junction. You can see the septum actually in the fundus from the high pressure zone. And when you try to travel down the sleeve, you can see retained fluid in the proximal sleeve and then a very high pressure zone here, trying to cross across the infusora to get into the antrum. So this was a clear physical evidence of what is really causing her problems here. And right after you get past the stenosis, it opens right up into the antrum. So we knew what we need to achieve for this patient. So we actually kind of started this case similar to a Z-POEM, where we started pretty close to the septum itself and created a submucosal injection using a multifunctional knife here that injects and cuts, and just started to advance ourselves into the submucosal space of the stomach. This was very similar to, kind of what we do with a combination of Z-POEM and the G-POEM technique. So we kind of enter ourselves into this space and we start kind of dissecting on either side of that septum initially. So you can actually see the septum here visualized, and we start dissecting the fibers on either side to start exposing it. In the stomach, as you know, there are lots of large vessels, penetrating vessels from left gastric and whatnot. And these have to be dealt with very carefully because they can cause significant bleeding. You need to be ready with coagulation grapsers or whatnot in different knife settings to prevent those as you're going through the tunnel. It can extend your procedure significantly and also cause mucosal damage if you're not careful. So here we're on the proximal side of that diverticulum, and then here we start moving towards the gastric or distal side to create that tunnel. As you can see, the wispy fibers of the submucosa are there. Here's some very large penetrating vessels here on the right. And we have to use coagulation graspers for many of these. There are some settings on the new VIO3 that allow us to deal with some of these larger vessels, which are quite nice. Helps save some time and not switch to different devices. But it's important to try to get this under control before it actually opens up. So here we're working our way down the length of the sleeve, and you can see that we're kind of feel that we're always constantly checking our direction too, just like how we do in a G-POEM. I'm kind of looking at that submucosal bulge, making sure that we're heading in the right spot. Now you can kind of see what the end of that stenosis looks like, and looks familiar to regular POEM, like in the esophagus, where you kind of go down and you can see a tightness at the LES. We see the similar kind of thing here in the middle of the sleeve, right just at the antrum, like a tightness here. And once you kind of dissect across it, you will see some of the space in this tunnel open up. So after we've opened it up, we start actually doing a myotomy over the septum initially, just to try to take those fibers down because there's some retention of fluid just because of the septum itself. And we start doing our myotomy similar to that of a regular POEM. So now the septum has been kind of taken care of, and you can see serosal fibers kind of there. And now we start working our way down the length of the stomach here. Interestingly here, we know this is our first case of doing something like this. So landmarks are a little bit different in the stomach. So I guess I'll ask Nikhil in the middle of the video here, how do you, when you're doing G-POEM and working in the stomach, what landmarks do you use when you're doing your myotomy? It's a good question, Prashant.
It's a great question, Prashant. If you can just mute, because I think there's an echo. So with G-POEM, the landmark is going to be the, Prashant, do you mind muting? Yeah, sorry for the echo. With G-POEM, there's a couple of landmarks. So I think we'll actually review a G-POEM case next, and I'll talk through some of this. But the main thing I find is that the stomach is much more expansive than obviously the esophagus when you're doing any sort of tunneled procedure. And so I think it's important, for example, with the G-POEM, that you start with fairly close proximity to the pylorus, so usually about 3 centimeters or so. And then as you're tunneling, you come out of the tunnel a lot more frequently in the stomach than you do in the esophagus to check and make sure that you're heading in the right direction towards the pylorus. Once you reach the pylorus, then it's pretty straightforward in terms of exposure and performing your myotomy. But with procedures in the stomach, you don't have as much of the visual confirmation that you're heading in the right direction. So it does require having to come out of the tunnel we use a semicoastal injectate that has a colored dye. And so even from the mucosal side, you can see and make sure that you're tunneling the right direction. But in cases like this, you don't really have a pylorus per se. You're probably having to come in and out of the tunnel more frequently, I would imagine, to ensure that you're staying along the correct plane and not deviating or spiraling.
Absolutely, Nikhil. And, when we're doing this myotomy, the myotomy itself is also for me, was a little nerve-wracking because we don't have the same landmarks with myotomy in the esophagus, the circular and longitudinal. The gastric fibers, per se, they don't really fall that way. They're kind of a little bit less organized and whatnot, but there is a thicker serosal layer here. So our goal was to try to cut through as much muscle without penetrating the serosal layer so that we're not dealing with peritoneal insufflation. And luckily, we were able to do that. We did have a fluorescent needle on hand ready to go in case there was any significant intraperitoneal insufflation to maintain hemodynamics. But luckily, we didn't have to run into that. So you can see this myotomy being performed lengthwise down the length of this sleeve. And we continue to the level of where we start running into that stenosis here. And here we do the entire procedure with this multifunctional T-knife. At the stenosis itself, we actually change the way we cut. We actually pull back on it just to create a little bit of room. This is something we'll do with the LES and regular palm as well. And then here you can see the entire myotomy here, all the way back up to the length. We then close our incision at the suturing. We generally tend to do that we generally tend to use suturing in the stomach just because it's a little bit thicker, although you can use clips here as well. But suturing is a little faster for us. And here's the septum closed. And so, next thing here. So the following day, next morning, she had an upper GI series. And here's what that image looked like here. You can already see that the entire shape of the fundus has changed, right? That diverticulum is much less pronounced. The shape of the stomach and retention is different, and there's a widening at the angularis here. So that axial deviation is still there, but it's open, and now contrast is traveling into that distal antrum, into the small bowel. So this was encouraging for us as it looked quite different. She was actually discharged one day after the procedure on a full liquid diet for 5 days and a daily antacid. And 2 weeks post-operative, she was able to tolerate a full diet without any significant heartburn, nausea, vomiting, and abdominal pain. Her weight was up to 2 pounds at that point, which she was very happy about. So, in general, gastric sleeve stenosis occurs in about up to 4% of cases in the literature. And serial pneumatic dilation is successful in about 75% of cases in large series. But this modified G-palm with sleeve release is a minimally invasive, safe option for revision in this setting, and potentially helps avoid revisional surgery because in these settings, many patients are being converted to a Roux-en-Y gastric bypass, correct? And this patient was already malnourished, already had a BMI less than 20. And so there's going to be a lot of questions with this technique. It's interesting now we're using myotomy techniques, not just for primary motility disorders, but now for secondary or iatrogenic issues with outflow. And the question will be over time is, are we going to be removing stables? Are we going to be causing weight gain in these patients? Is the myotomy too aggressive, or what's the length of these things? How are these patients going to be doing long term? So I think a lot of further study is needed, but definitely provides a new option that may help avoid revisional surgery, which many of these patients do not want to have. I don't know if Nikhil, you have any other comments on that?
Yeah, I think that's a great case to help improve this patient's symptoms. Before comments, I would also just remind everyone that we do have the live chat going in the YouTube channel or by WhatsApp. I already see that we have people logged on from Bangladesh, Argentina, Brazil, Louisiana. So welcome to all that are watching. One question I have for you, Prashant, with respect to this case is, she had a pretty striking change in her upper GI series, even on the post-op day 1. how do you attribute that, that striking change? And I think, with sleeve gastrectomy, you have reflux rates as high as 20%. If they do have a high pressure zone such as this, do you think you'll be offering this more in the future to try to avoid those revisional surgeries that you talked about?
Yes, those are all great points. So, that is a known complication of laparoscopic sleeve, very high rates of significant acid reflux in these patients that often end up going for revision to room-wide gastric bypass. This is a not uncommon procedure performed by bariatric surgeons. And as endoscopists, a lot of our role is endoscopically, evaluating, medically managing these patients with diet and medications. And often, after all those things are done, we kind of hand them back to the surgeon to see what else to do. This is definitely a potential option that could potentially change the algorithm of how we change these patients. More data is needed for sure. I think we need to have some empiric data on how to measure when someone has a sleeve stenosis or a high pressure zone. Can endoflip be useful in these scenarios to predict who would respond to some type of sleeve release? And yes, I think that we need to start collaborating with our bariatric surgeons to educate them that these options exist. And so this was presented actually at one of our surgical conferences at our hospital to inform that this is something that has been done and this is something that's available. So when we get these patients, there's this has to be a round table about what we can do for them. I think that surgeons will often inherit patients also from other surgeons, right? Bariatric surgeons, sometimes after 12 months or so, they release the patients, they move, they develop these complications years later, and they don't know what to do, and they don't want to necessarily reoperate. So this is an option that could change the algorithm for these complicated patients that have a high need for healthcare. So more to come.
Yeah, it's also surprising to me. In some ways, this patient was lucky because with that degree of stenosis, they're very high risk for a leak in this setting. So I think they were, they were about 10 weeks out from the surgery. They clearly had sequelae of that high pressure zone with the diverticulum, but they're lucky they didn't develop a proximal leak here. That's one of the complications of bariatric surgery that we can also manage endoscopically. But when those proximal leaks do occur, what is your treatment approach? Obviously, you need to deal with the leak itself, but you also have to deal with the cause, which is usually the stenosis at the incisura. What's your approach with leaks post sleeve gastrectomy?
Yeah, that is a loaded question. These are very, very challenging patients. Often require a lot of inpatient care and hospitalizations depending on their status. These can be very, very morbid complications for these patients. So you're right. It's very important to understand the pathophysiology of what's going on, right? A leak isn't a leak in itself. This leak is caused by something else. And it's almost always, as you mentioned, a high pressure zone. And so in these patients that are sent to us when they're pretty fresh from the procedure, if it happens relatively close to the surgery, we are definitely looking to do a primary closure for these patients to try to see if we can close that leak. But often this is at the GE junction and very high up in the fundus and difficult spots to see. So it can be challenging to identify those areas of closure or of leakage. And we, at the same time, we are looking for stenosis to see if there's any way to gently dilate these patients, in the acute setting after the procedure to see if we can open things up for them. That may or may not work for all of these patients. If it's a leak that occurs later on, then potentially there's these fistulas or these sinus tracts are much more difficult to close, and these can be much more long, elongated kind of courses for these patients. Again, opening up the stenosis is important, but at the same time, different mechanisms, because closing them primarily is not necessarily the easiest thing. This is where sometimes endovac has become more utilized and has had improved outcomes in these settings because they need chronic kind of suctioning and debridement of that area while the leak and the stenosis are treated. We do actually even put sometimes percutaneous drains of these collections. The surgeons will put those things, and then we're kind of like gradually pulling things back together. So it's kind of a dance that's individualized for these patients, but very challenging. And many of them actually end up going on TPN for some time as well to manage these things to prevent them from needing a
approach here. You've got to address the high pressure zone. If you can just mute Prashana here and echo. There's it's a twofold approach here. If I can achieve a primary closure, I'm happy to do that, whether it's with an over-the-scope clip or endoscopic suturing. But you have to perform some release of the high pressure zone. Otherwise, you're only treating the sequelae of that and not the underlying cause. So whether that's a pneumatic balloon dilation or some other measurement, if we don't think that the leak is treatable in the initial setting with a primary closure, then we start to think about secondary therapies, either covering it with a fully covered metal stent or some of the other options you mentioned, like endovac. But I will say that endovac is, while it works and the data is actually pretty good, it's quite tedious. You have to bring these patients back, a couple times a week to the endoscopy lab. For those that are not as familiar with endovac, you basically put a nasogastric tube into the nose, you pull it out through the mouth, and then you cut a wound vac sponge, very similar to what the surgeons utilize to approximate the size of the defect. And then you can tie an air knot at the tip of the tube and then drag it down. And by utilizing negative pressure, you're sort of removing bacterial contamination from a leak site, and you're inducing granulation tissue and increasing the vascularity in the area to help with healing. But these are very difficult procedures to do on a 2 or 3 times a week basis. It does require frequent sponge changes, like the surgeons do for their wound vac. So I think the other important point here with the leaks is that the time post-surgery is also very important. We can get more aggressive with addressing a more chronic scarred down incisura stenosis as opposed to a fresh staple line. Because again, we don't want to make things worse and cause a suture line dehiscence or a problem by using a 30 or 35 millimeter balloon so soon after surgery. We do have a question I see in the WhatsApp chat, Prashant, of 2 things. One on would EndoFlip have been helpful here in this patient, and 2, what's the downside to doing a full thickness cut here and going through the serosa as well, since you have a tunneled approach?
Great. So I think EndoFlip here would have been interesting. I'm not sure if it would have changed our management. We knew that there was a high pressure zone that needed to be released. It might have been academic in the sense that it would have given us some pre and post measures to start collecting data on what we think is tight and what is not tight, what's normal and not normal in a sleeve. And that's what we've been doing with EPOM, and many people are actually starting to do this with GPOM as well across the pylora. So I think that over time, if this becomes a technique that more and more people are doing, yes, I think that EndoFlip would be useful to understand pre and post myotomy values in terms of just the sensibility indexes and diameters and in the sleeve stenosis. That way we know, is this something we should be addressing? Is this definitely from stenosis or not? When we do a myotomy, what type of numbers are we trying to reach, or what's the average that people are doing? And so we didn't actually employ it in this case, although it's something we could have done. Maybe in the future we'll start doing that to collect data. So that's a good question. I think that in terms of the myotomy, the goal here, we actually did do basically a full thickness myotomy. There was actually almost no fibers of muscle left. My concern is that whenever we're doing full thickness myotomies or full thickness cuts, there is a chance for air insufflation that can be released from the organ and into the peritoneum. And in this case, this lady was actually quite small, a BMI of 19. Even spending 20, 30 minutes with full air insufflation. So it's CO2, of course. We use CO2 for every single myotomy case, so that's a very important point. When I say air, I mean CO2, because it's much lighter and much easier to be resorbed by the body. So anytime you're considering doing really any third space procedure, you should be considering that. But even with CO2, there is a ability for capnum peritoneum, capnum thoraxes, and whatnot. And we have a Barrett's needle on hand in all cases, because if there is leakage and increased intraperitoneal pressures, this can affect hemodynamics. And so we just don't want those types of things to happen, affect the length of the procedure or ability to continue performing it. So in that case, because this is kind of a long myotomy, usually our G-pome myotomies are no more than 3 or 4 centimeters in the tunnel and whatnot. And this was probably more about 10 to 12 centimeters, more like a E-pome. And so for that reason, we're a bit cautious. We wanted to make sure that we didn't cause that issue. And that turned out to be okay for us. But I think over time, we're going to have to see how this procedure evolves.
Great. So I think we'll, I don't think there are any additional questions. There's a really great case here to help this patient out using a modified G-pome technique. I think we'll now transition to the more standard G-pome technique. So I'll share my screen. Okay, so that should be viewable now. So this was a patient that was referred to our center with gastroparesis, and we can talk about it in the discussion aspect, but obviously there's a number of different etiologies. It's a more sort of heterogeneous pathophysiology as well in terms of gastroparesis, and we ultimately decided to offer this patient a gastric poem. So we'll go through the video and then we can chat about sort of patient selection, which I think is probably very, very key and very important for this particular procedure in and of itself. So as with most gastroparesis patients, even when they're on a liquid diet leading up to the procedure, you can oftentimes see a lot of retained food in the stomach. Here's the pylorus, which is tight and spastic, you can see there. And I think patients that have underlying pylorospasm as their main modality of pathophysiology for gastroparesis often will have a very good response to this release of the pylorus with the pyloromyotomy. So similar to the video that you showed, we do a submucosal injection. We use an injectate of normal saline with methylene blue, and then we're using a multi-purpose hybrid knife here. So we're able to inject, and then we're creating in this case, a transverse mucosal incision that enables us to gain access to the submucosal space in the stomach. And in the stomach, there are much larger vessels. You can see we're about a few centimeters proximal to the pylorus, and we frequently will come in and out of the tunnel to make sure that we're tunneling towards the pylorus. And there you can see now we have exposed the pylorus, so it's a pyloric ring. And you have to be very careful, particularly right when you cross the ring, because you don't want to have a mucosal perforation on the duodenal side. So we're checking here to make sure that we've gone far enough. You can see the nice blue hue that tells us that we've been tunneling in the right direction, to your question earlier. And now we're ready to start our myotomy. Now for G-pome, we will often start with going from a distal to proximal direction, and we've changed knives here to an insulated tip knife so that white ceramic ball does not transmit electrocautery. Again, we want to be very careful that we're not having an injury of the duodenal mucosa. Those are very, very difficult to close just because of the anatomic location. There is some recent literature that has come up on double pyloromyotomy versus single. So double would be cutting in 2 different access planes. So if you think of the pyloric ring that we've exposed as a clock face, and here we're going full thickness. But this is a very, very short myotomy that we have to perform. And often these procedures are fairly quick, usually 45 minutes or less. Once you've cut the pyloric ring and maybe an extra 1 or 2 centimeters, you're pretty much done. And then in this case, because of the thicker gastric mucosa, I do like to close with endoscopic suturing. I find it to be it helps me sleep better at night, so to say, compared to through the scope clips. So we're utilizing the over the scope suturing method here. Now there is a new novel through the scope suturing device that was approved within the last year and a half, and that potentially could also be used for these cases. But this is the standard over the scope suturing based device that we utilize to using 1 stitch perform closure of the of the mucosotomy so that there's no potential for any ingested food to get into our tunnel and then get out, beyond the gastric lumen itself. So go back to the scope, regular scope, once we've closed our mucosotomy and the pylorus ended up being nice and open, and this patient actually did quite well post-procedure. So I want to ask you, Prashant, I know that you do GPOM as well. Can you talk a little bit about your approach to patient selection? I think my personal bias with this disease process is that it's a very difficult disease process to treat. You have multiple different etiologies, whether it's diabetic, whether it's idiopathic, whether it's post-surgical. I think there's a lot of confounders with use of concomitant medications, in particular narcotics, which can certainly worsen their not only gastric motility, but you can have sort of esophageal dysmotility, small bowel gut dysmotility. What's your approach to patient selection for when a patient is sent to you for gastroparesis for consideration of a GPOM?
That is an excellent question, probably the million-dollar question for this disorder and this technique. As you stated, gastroparesis is a very complex disorder. None of these patients are straightforward, right? It's not like your achalasia patients or your Sankers patients. They have so much more going on, so much surgical, pharmacologic history, even psychiatric history. And these are younger patients, often female, with a lot of different things that are driving their symptoms. And gastroparesis is a full organ disorder with multiple different pathophysiologies that are driving dysmotility, right? It's not necessarily just dysmotility of the body. There may be pylorospasm up to a third. Patients may have a significant degree of pylorospasm, which is why GPOM may work in those patients, right? But there's a certain sector of patients where this may not be useful. It may not respond. And if you look at the literature, the meta-analyses that are published, 60 to 80%, depending on the study that you look at, of some type of response in these patients, but not everyone. And there is a standardized GCSI score, or gastric cardinal symptom index score, that we use pre-op to try to gauge their symptoms. And we look more at outflow obstruction symptoms, really the bloating symptoms, the vomiting symptoms. Patients that have a more pain-oriented disorder are probably not good candidates for GPOM. This is not a pain-relieving procedure. It may make the stomach and belly feel more comfortable and higher quality of life because of the lack of distension and whatnot. But if somebody is coming to me with significant pain from gastroparesis, I'm very hesitant to do the procedure in those cases. The limited studies out there on GPOM looking at who would be responders, have negative responders. Negative predictors may be diabetes. And for sure, anecdotally, I think that narcotics are almost an absolute contraindication in my practice. That if anybody's on a significant narcotic dose, I tell them that we need to wean those things. We need to optimize your diet. We need to optimize your A1C. I'll often get referrals for GPOM in patients that really have not been medically optimized at all, medically managed for their gastroparesis, have not tried a pro-motility agent or whatnot. And often, we're just giving them some tips before we even offer something like this. We say, hey, get your sugars under control, start this low residue diet, start some Reglan, and those patients actually do just fine. And so there's a lot of teasing out of these patients about who should be considered for it. One thing unique thing that I think we've started doing in our practice is for patients who I think are reasonably good candidates, I will actually do a pre-procedure Botox injection. And this is also controversial because the data on Botox has been hit or miss. Randomized controlled trials sometimes show that there's no response or whatnot. Personally, I do believe that the technique of how you deliver the Botox in the pylorus matters a lot. And you can do a Botox injection that works and doesn't work just based on your technique. So when we do it in 4 quadrants around the LES, we are looking for a full 360 submucosal cushion around the pylorus to make sure that our Botox injection has been adequate. And if we don't see that, we don't consider that an adequate injection. And so all patients that seem like reasonable candidates end up getting a Botox injection, and we will see a significant improvement in their GCSI within 2 or 3 weeks after a Botox injection. Those patients will come back to clinic I feel better now than I did in the last year or two. And those are kind of very positive predictors for us that they're going to respond to GPOM. So we're putting together data to kind of look at that as a predictor for responders. But it's not perfect, right? Because some of these patients may not respond to Botox and they still want the procedure. They kind of have a good pre-op probability. So we have a hard conversation about that. And say, look, you have to be honest with these patients. You know, I'm not sure if this is going to fix all your problems. I'm not sure it's going to make a significant dent. It just depends on the patient, and you didn't respond to Botox. So I think it's a complicated question, but we're kind of sort of teasing it out. We definitely need more data on this. It looks like there's a question from the audience here. GPOM, where to start proximally and how to identify the endpoint of the myotomy. Do these patients need a post-GPOM PPI therapy? So Nikhil, how do you kind of identify those areas where you start and finish?
So with GPOM, the first question that I'll address is where to start proximally. Usually, if you look at a literature, they say 3 to 5 centimeters. I personally like to start about the closer, about 3 centimeters. You don't need a long myotomy. For these, you're really just tunneling to the pylorus, cutting the pylorus and maybe extending back 1 to 2 centimeters. So I typically will start about 3 centimeters proximal to the pylorus. How to identify the endpoint of the myotomy? So in this case, you're working in a distal to proximal fashion. So the pyloric ring is a very, I would say, easy structure to identify when you're doing submucosal tunneling. And once you reach the pylorus, it's a fairly obvious ring that stands out. And that we can cut through without any issues. What I do to assess my sort of endpoint is I will come in and out of my tunnel, sort of try to put a little coagulum dot where I want to stop as I'm pulling my scope back and pulling my knife back. And once I see that marking point that I've left, I know that I want to stop there, because you don't want to pull your myotomy or extend your myotomy too far proximally where you then potentially may have an area where it's overlapping with your mucosotomy, and then you've got a sort of a full thickness perforation there. So again, these are very, very short tunnels, very short myotomy, and I will often use my electrosurgical knife to sort of map out where exactly I want to stop. There's another good question here in the chat about what investigations are essential to correctly diagnose a gastroparesis case. So Prashant, do you want to take that question?
Sure, absolutely. So my threshold for performing this procedure is relatively high, meaning that I'm very selective on who I perform it on, and I want to make sure that the outcomes are good. So I do require all patients to have a gastric emptying study of narcotics within their pre-procedure evaluation. We're also doing a very thorough history on these patients and looking for comorbidities. Any other pharmacologic therapy that might be affecting them in their A1C levels. So I'm checking A1C levels on all of these patients and getting a gastric empty. If they have not had an endoscopy before, sometimes we're even considering doing those things, because I do like to see what a prior endoscopy shows in terms of food retention. That does make me feel that they have a higher pretest probability. If an initial outpatient endoscopy at another center showed that there was retained food or fluid in the stomach and their symptoms correlate with gastroparesis, that is kind of a increased help for us to understand that these patients may benefit. So it's difficult, because sometimes you'll get patients that have negative gastric emptying studies, right? And the data on gastric emptying studies is not consistent across the board, especially if they're performed as inpatients. They're highly inaccurate. And so you have to kind of take that with a grain of salt and see whether you need to repeat them. But I am repeating a lot of these patients' imaging studies and taking very thorough histories from them. There are centers now across the U.S. I know that are starting to use endoflip as well as a potential predictor for these patients, and doing a large endoflip, 50 milliliter inflation across the pylorus to try to predict pyloric spasticity. So that's also something that can be added into the algorithm. Upper GI series are something that I'm not generally doing, but there are some other centers that are using upper GI series to look for slower motility. I don't know, Nikhil, if you have any other thoughts on that one.
Yeah, I think a thorough evaluation. I agree with you. My standard for GPOM is high, and we have to make sure that these patients are going to have an adequate response. I think looking at their symptoms, as you alluded to earlier, the patients that are predominantly pain as their symptom will oftentimes not have a good response to this procedure. The nausea and vomiting patients do tend to respond with GPOM. Looking at the underlying cause, whether it's diabetic, post-surgical, idiopathic, there was actually a study that was published in Gut earlier this year, a few months back, that was actually a prospective randomized sham-controlled study looking at GPOM in patients with severe gastroparesis. They actually had to stop enrollment early by the DSMB. They initially, I think, had planned to enroll somewhere in the range of 80 or 85 patients, and they had to stop at 41. The reason is that there was a significant difference between the two arms. So the treatment success rate in patients that had GPOM was about 70 to 75% versus only about 20% in the sham. Specifically, I think in this case they had to cross over patients to the GPOM group because the sham success rate was so low, and so it was a pilot study that was done, but it was a randomized sham control study. So this was in Gut a few months back. I can't underscore the importance of the narcotics as a confounder in these patients. So I agree with you. I try to get them off of the medication and then repeat their testing when they're off of the narcotics. I'll also try to evaluate their small bowel motility. So there's a smart pill that can be done to look at any small intestinal dysmotility. If that's present, then oftentimes doing a GPOM may not be as helpful. And I do see a question here in the chat about concern for fibrosis after Botox making GPOM difficult. So there is a camp in GPOM of using pyloric-directed therapies as a measure of will the patient respond to GPOM. So the two that are done would be Botox injection, and then some people are also doing transpyloric stenting for a brief period of time, only 1 to 2 weeks, and assessing the patient's response to therapy. And if they have a response either with Botox with dilation, it may improve their candidacy to do a GPOM. Much like with esophageal Botox, I have not found a significant concern with fibrosis making GPOM difficult. So in some patients that are on the border, I'm not sure if they're going to have a good response or not. I will oftentimes inject Botox and assess their response. I do not generally have a concern for fibrosis that can impact my GPOM. One question that has also come up in the WhatsApp, Prashant, is...
if I chime in on that one too. So for the Botox question, that is a great question. We actually looked at our data for this in achalasia a few years ago and presented at DDW at patients who had any form of prior therapy prior to performing a POEM, and did that therapy affect the outcomes of our POEM procedure. And we found that prior Botox injections, pneumatic dilations, did not change the timing, the time to completion, success rates, or adverse events. And so it really had no effect on our procedure in achalasia. For the stomach, I think agree the same thing. If there is any mild effect that's occurring from this Botox injection, it's so minimal now with the improvement of some of our energy settings and our newer knives and are injected that it's not a obstacle that we cannot overcome. And the predictive value for me personally that I feel that it gives us is outweighs maybe some of those small potential hurdles that it puts in our way. But yeah, it's not a concern for us. Even though we do recommend in the community, don't treat your patients with Botox. Currently this is not a good option if it's a Band-Aid or whatnot. I think as a diagnostic tool, I'm not hesitant to use it.
Great. Let's move on to from the stomach down to the colon for our next case. Okay, so this was a colon lesion that was previously resected, it was referred to us for an incomplete resection, and we tried initial techniques with submucosal injection to see if we can get a lift. This was in the right colon, and it was a sort of a smaller residual amount, maybe only about 18 to 20 millimeters, and we couldn't achieve conventional resection techniques like EMR, so we ended up performing a full thickness resection on this patient with the Ovesco FTRD device. So what this procedure entails is using a marking probe to put coagulation marks around the periphery of the lesion, much in the same way that we do marking after an ESD. And then we advance the scope with the device mounted to the tip of it to the lesion. Now, I'll try to walk you through the anatomy of this device. So the extension of the cap from the distal end of the scope is generally about a little over 2 centimeters in length, and it is coned down. So this can make it quite challenging sometimes to advance the scope to the right colon or to the cecum, particularly if the patient has a lot of diverticuli or has an angulated or tortuous sigmoid or left colon. At the tip of the cap, there's actually a snare that's embedded in. You can kind of see the wire here a little bit. And then on the outside of the cap is a nitinol clip. This is an over-the-scope clip, and it's on the outside. So you do have to be careful with introduction of this device because the clip does have teeth, and sometimes that can cause trauma to the colon wall as you're introducing it. And then there's a white band that lets you know when the clip has been deployed. So the approach in this case is that we grab the lesion, in this case, a non-lifting adenoma. We pull that lesion within the cap using a grasping forceps. And then while maintaining traction on the grasping forceps, we deploy the over-the-scope clip. And then we close the snare that's within the tip of the cap, and that allows us to resect the specimen on block. And this is a little bit of a different paradigm from what we're used to doing with endoscopic resections that are full thickness, where if we're using an electrosurgical knife, we'll cut through full thickness and then we'll close the defect. In this case, we're actually achieving closure because the clip gets closed first before we do any resection. So a little bit of a different paradigm here in terms of thought. So let me play the clip.
And you play it for a second. Can you, Nikhil, can you tell the audience how you choose lesions for this device in terms of shape and size, and what are the recommendations for what this device is able to handle in terms of resection?
Yeah, that's a good question. So, in my opinion, with this device, it's mainly helpful for non-lifting adenomas, really scarred refractory lesions. Because of the cap, there are some size limitations. You can generally get a lesion up to about 25 or 30 millimeters into the cap. Depends on the degree of scarring and fibrosis. You can't go significantly bigger than that just because of the amount of room within the cap to get tissue there. If I can do conventional EMR or ESD, that is my preference, though. This device is a little bit cumbersome to use, and as I mentioned, there are some technical challenges. Sometimes just getting the scope to the lesion itself can be, as difficult as the removal when it's in the right colon or in the cecum. There also is utility in utilizing this device for lesions that are at the appendiceal orifice. The one caveat that you have to be aware of, and you have to discuss this with patients, is that there is a risk of potential appendicitis if you'd use this device at the appendix. And so typically that risk in the literature has been reported anywhere from 10 to 20%. So it's not zero. And so we have a conversation with these patients when we're doing an FTRD at the appendiceal orifice to make sure that they are aware of the risk of appendicitis and they know the signs and symptoms to look out for. So what I'll show here is the lesion. Now, if you're familiar with use of the over-the-scope clip in the upper GI tract, you know that you can utilize suction to get the lesion within the cap, or you can use ancillary devices like grasping forceps or twin grasper forceps, or an anchor catheter to pull the lesion into the device, and you can utilize suction as well. In the colon, you want to be a little bit more careful and utilize primarily just these grasping forceps to get the lesion within the cap. If you start to utilize suction to try to augment your tissue capture, that's when you can run into the problem of serosa from surrounding small intestine or colon getting entrapped as well. And then you can have a big problem if you close your clip and you have serosa from adjacent bowel that's entrapped within your clip. So very careful here from a procedural and technical standpoint that you want to really only utilize the grasping forceps to pull and not suction the lesion in the cap. These lesions can be quite tough because they're scarred down and fibrotic. And you can see we're deploying the clip here, that white ring and the clip moved. And then we close the snare without moving our scope and then apply electrocautery. And you can see that, that we can get a nice resection. In some cases, you're getting full thickness. Serosa can be seen on the resection specimen. And this is a good modality to try to help our patients that have, non-lifting adenomas that can be challenging to remove with more conventional techniques. Prashant, what's been your experience using the FTRD device? With respect to patient selection, we have a lot of devices on the market now that can be used for that application. Where does FTRD fit into your algorithm? Who do you feel really benefits from use of this device?
Great question. I think that you kind of hit it on the head earlier when you said it's something that's not going to lift properly. My first and foremost is still to consider third space endoscopy for most lesions that we're trying to remove. And that's my tried and true, because I think we have it feels like we have a little bit more control. But for, fuller thickness lesions, potentially benign lesions, say that there's a GIST tumor, smaller GIST in the stomach or whatnot that's arising from layer 4, and it's smaller than 2 centimeters, could potentially fit into those caps. That's something to consider. Or a lesion like this where you're not getting any lift, that's something to consider. But the location of the lesion also is a challenge because of how large this device is, how wide the diameter of that cap is. Even just getting it through the oropharynx can be challenging in some cases. So I think that you have to take all of those things into consideration. But the nice thing is that this saves some time, right? This is a nice device that does your cutting and closure all at once. So in those lesions where maybe you're going to be spending a significant amount of time doing a third space case, that may be more easily achieved through something like this. I think that you have to kind of weigh those risks and benefits, and you make it a better margin with this device because you are going full thickness. And so sometimes when you get that cautery effect or whatnot, you're only a millimeter or two from the margin. I think that's something to consider for these types of indications. So there is a question from the audience here, Nikhil. Do you recommend ESD or FTR for T1B plus SM2 lesions? So you're talking about lesions that have a little bit of submucosal involvement, potential for lymphatic spread. That would be a concern here.
Yeah, that's a very good question. That's a case that we would present in our multidisciplinary tumor board. I think the concern here, if you have a T1B lesion, is that there's submucosal involvement. SM1, SM2, SM3 describe the depth of involvement within the submucosa. The more superficial involvement would be in SM1. You're looking at depth in terms of microns, so that really needs to be assessed on a pathological specimen here. In a case where it's a T1B SM2 lesion, or that's the concern, you need to get cross-sectional imaging to see if there is any concerning lymphadenopathy. But I think in most cases here, you can do a resection of the local lesion. However, we're limited endoscopically in our ability to assess the lymph nodes. And when you have depth of invasion with SM2, there is non-insignificant risk of lymph node involvement. So at our institution, when we've had cases like this that have come up, we've actually had that patient go for surgery because they need to have lymph node dissection to adequately know, what their proper stage is. Any T1A lesion, though, where you have a very, very low risk of any lymph node involvement, those are ones that fall more within the endoscopic realm. But I think that it underscores the importance that these cases be presented in a multidisciplinary fashion at a tumor board, before getting any procedure scheduled. We also have another.
Mind if I jump in on that one before we go to the next one, Mikhail? So I think that's a very loaded question because staging preoperatively is challenging in these procedures, right? Like you're doing an EUS on a lesion in the rectum or whatnot. It's very hard to tell whether something is truly SM2 or T1B versus T1A. And the data, as we all know, EUS fine staging of these layers is not completely accurate all the time. So often we don't find out some of these pathologies until the path specimen has already been submitted. Like for example, we had done a rectal ESD on a patient some time ago, and the biopsies were all tubular adenoma. But when we removed the entire lesion, there was a focus of carcinoma in situ with lymphovascular invasion, very small focus of lymphovascular invasion, and invasion to SM2. So this is one of those cases where post-procedurally we find out pathology. The lesion has technically an RO resection from a morphologic standpoint, but again, has to be presented at our tumor board with our oncologist to consider whether this is the type of patient that would get adjuvant radiation or chemotherapy. And so I think that it's really hard to predict early whether this is something that is going to be removed, but I think for the most part, it's still something that we would consider removing because it potentially is organ sparing and still their risk of lymph node invasion and metastasis is on the lower side for some of these lesions. And oncologists are, at least in our institution, they still would like us to do this as opposed to sending the patient for a surgery. There's another question here. Is there any risk of incorporating extraluminal adherent structure during FTR? I think we kind of are looking at how to assess it. So I guess that's a good question because there's some tips on how to prevent and assess whether there's any extraluminal unwanted tissue in your cap before you do this.
Yeah, so I also see that there's another question on how do you make sure that the complete lesion is inside the cap before clipping. So I can answer both of these in the same answer. So the first is how do you make sure the complete lesion is inside the cap for clipping? So what you want to do before you even advance with the device there is very important to do soft coagulation markings around the periphery of the lesion, around the circumference of the lesion. And then when you're using your grasping device, you want to make sure that it's ideally centered in that lesion and so that you can follow as you start to pull a tissue in, the soft coagulation markings, you should be able to see them sort of concentrically come towards your cap or within your cap. So I think marking certainly will help to ensure that you've got the lesion completely inside the cap before clipping. What we will also do to avoid the extraluminal structures coming into the FRD, as I mentioned, is do not utilize suction here. It's really suctioning that can cause a problem. So it's very important to utilize the grasping forceps to pull the lesion in without the utilization of suction, and then you really should not have any problems with grabbing it serosa from another loop of bowel within the cap before deployment. You really want to just invert the lesion into the cap. I will say I have had some times with particularly scar down or fibrotic lesion that the grasping forceps kind of just rips the tissue, or I can't really pull it in very well. I have used this actually in a couple of instances as my accessory device, a tissue helix that we traditionally use for our suturing, and that's a helical device that essentially has like a corkscrew at the tip of the catheter, and you can actually rotate that helical device into the center of the lesion to get a little bit more tissue captures to be able to pull that scarred fibrotic lesion into the cap. So very mindful of how many rotations your staff is doing with the helix, that you don't perforate through the lesion. But That's another ancillary device that I like to get good capture of tissue to pull within the cap prior to deployment. Really, the main way to avoid any extraluminal structure coming in, though, is do not utilize suction with FTRD. That can certainly be a higher risk.
So I have a comment on this case and then another discussion point, because this is not uncommon, right? We as advanced endoscopists, we referred these large polyp cases from outside hospitals, which prior intervention has been done. They have been scarred, and it's a challenging entity for us because we're no longer in the distal colon. We're no longer in the stomach. We're in the right colon, ascending colon cecum, and the position of our scopes is challenging. There are some over-the-scope devices that allow us to stabilize our scopes and try to get in positions where we can perform third space procedures. One technique that I have found useful for these kind of scarred down polyps is a hybrid ESD technique. I don't know if you've used this, but where we will actually mark around the lesion as if we're performing an ESD, and then we perform a circumferential incision around that lesion, just like how you were dealing with this one. We would do that circumferential cut and just do basically a millimeter or so of dissection into that submucosal space, and then subsequently use a snare, because often the snare is always slipping over the lesion when you try to do a conventional EMR. But if you create that lip underneath the mucosa with a dissection, that allows for you to actually grab underneath the tissue and actually do a very quick EMR after doing a circumferential cut. And the other technique that, or at least the other device out there that is now being touted as potentially an option for this is kind of the endorotor, tissue removal device, where you're kind of scraping and morcellating the tissue to remove it for these very, very scarred lesions. And Nikhil, what's been your experience, when you're not doing a full-on, full-thickness resection, how are you approaching these lesions? What are some of your other techniques that you address with?
Great question. These are, first off, preface it by, these are very, very challenging cases. Sometimes we're sort of handcuffed by our referring doctors if they do an incomplete resection. And so, I would first sort of highlight the importance of, proper technique when you're doing the initial colonoscopy. If you see a lesion that you're not prepared to take out on the initial colonoscopy, don't take part of it off, because that leads to significant scarring and fibrosis. The other key teaching point is to not tattoo underneath the lesion. The tattoo will spread underneath the lesion, and it will sort of lock in into the submucosal layer and really reduce our ability to perform even a conventional EMR or even an ESD. So you want to make sure that if you do find a high risk lesion, in some cases you don't even need to necessarily take a biopsy. You can just refer that patient if you're not comfortable doing the resection yourself. And if you are going to put a tattoo, make sure that it's away from the lesion and on an opposite wall, so that there's no extension of tattoo underneath the lesion that could compromise the resection. If we can't do conventional techniques, either EMR or even more standard third space ESD for these difficult lesions, for my algorithm, I do think about use of FTRD if the patient's anatomy is suited for that, if the lesion size is appropriate. I have also utilized the endorotor device. We saw that yesterday in a live case utilized for necrosectomy. There are a couple of challenges, I would say, with the endorotor in the setting of a scarred down colon polyp. Number one, it can be a little bit messy in terms of the morselain blades leading to sort of a bloody field. This can be mitigated somewhat. I tend to inject epi right into the lesion to try to get not only tamponade, but also local vasoconstriction there. And then with the FTRD, you kind of want to move the device, the catheter, almost like a brush kind of sweeping across. In the more scarred or fibrotic areas, you do have to increase the suction pressure. So you can increase the amount of PSI, or sort of force that's the pressure that's utilized by the device to pull that tissue within the spinning blades. And you just have to be careful that if you go to very high levels of pressure, maybe 400 and above, that's when you'd be concerned that you might then be able to suction up potentially some muscle into the spinning blades and that can lead to a perforation. So I think that it does have a potential role, but you have to be very careful with utilization of endorotor in the colon. If the pressure is too low that you're using for suctioning, you may have a very superficial resection, and if it's too high, you may have a perforation. The tissue that is suctioned up and cut with the morcellating blades, it is collected in a trap, so you actually can send that out to your pathologist to assess. However, it's in very, very tiny pieces, so you will not be able to know if it's an appropriate R0 resection, especially if you have a concern that this might be a malignant lesion. So I reserve that device more for really flat scarred lesions that have had prior resection attempts, where I don't have a high concern for malignancy, or I practice at Mount Sinai, where you train for Prashant, it's like the IBD mecca. So there's a lot of patients with IBD who have had many years of scarring and fibrosis as a result of their inflammatory bowel disease, and those notoriously are very difficult to achieve, lifts for either EMR or ESD, and so we are exploring the use of endorotor in that specific patient population. I see another question in the chat here, Prashant, that maybe you can address. Is it essential to close the mucosa by clipping after every EMR or ESD procedure?
Great. So one last comment on the endorotor before we go to that question. I think that you're right. There's certainly a role for it, especially for these very, very scarred lesions. My one thing that I think is one of the biggest drawbacks about it is that it just destroys the tissue, right? You don't actually have a histologic specimen with architecture to understand the morphology of what you're submitting to the path lab. And so when you have an FDRD, you have a full thickness, intact specimen to give you margins, as opposed to the endorotor, which is just bits and pieces of tissue, which I think that's more frustrating for pathologists and ourselves to truly understand whether we got all of the tissue in RO resection. So that's my one concern about it. Is it necessary to close every EMR and ESD procedure? So the simple answer is no, it's not essential. But do I do it a lot? Yes, I do it quite a bit. So I think that the size of your defect, the location of your defect, the patient protoplasm in terms of their risks of bleeding all need to be taken into consideration here. So generally, if we're talking about colon per se, in the right colon, you're going to see more bleeding than in the left colon. That's just a standard that we know in terms of meta-analysis and literature after polypectomy and mucosotomy. So when I'm doing EMR or resections in the right colon, I am almost always trying to at least put some clips over them to help me sleep at night and help my partner sleep at night, so they don't have to come in for any type of post-polypectomy bleed. That being said, it's not essential. If there is somebody that is going to go back on anticoagulation for any reason, I'm going to be closing all of those things as well. For all my ESD procedures, I try to close those as well. There is literature that shows that closure of mucosotomy sites, it decreases your risk of perforation, delayed perforation or delayed bleeding in this patient. So for gastric and rectal and colon ESDs, I am closing them. In the esophagus, however, I do not. The reason being that I do not want to increase any risk for stricturing, and I kind of don't want to close off enough, because often these resections in the esophagus are almost hemicircumferential, if not more, and the risk of stricturing is already high. So in the esophagus, I tend to leave things alone. But in stomach, rectum, and then in colon, I am trying to clip or close or suture for most of those lesions. There are some newer devices that are coming out. There are newer closure devices and also newer gel devices that are coming out for prevention of delayed bleeding. So there's something called a PureStat gel, which you can basically just infuse the gel over your mucosotomy site. And it's supposed to help prevent delayed bleeding and also even treat active bleeding. And so there's options there that may be cheaper, quicker coming down the road. But personally, I sleep better when I do it. I don't know, Nikhil, how you try to address these issues.
I don't think I sleep as good as you, because I'm not as aggressive. So there was, early data looking, for example, in Japan and Korea, at some points they were doing second look endoscopies, that they were keeping patients with ESD in the hospital for a long period of time and doing second looks. I think for me, I'll address it with the colon EMR first. So I do subscribe to the data. Heiko Pohl had a publication in Gastro a couple of years ago, and in their analysis in this RCT, in their subgroup of data, they found that large colon lesions that are non-pedunculated, greater than 20 millimeters, you can reduce the delayed bleeding risk with prophylactic closure. There are some difficulties with doing large colon EMR closures, especially if the defect is very, very large, oblong shaped. It can be challenging sometimes to clip with traditional through the scope clips. Now, we do have wide jaw clips that are available on the market that can be utilized. There are also newer clips that will be coming out in the near future that may not be as dependent upon the jaw opening to close larger gaps. There is also through the scope suturing that can be utilized, and I have done that in some cases for large colon EMR defects. The through the scope suturing I like for right colon EMR defect closure because I don't have to take the scope out and mount a suturing device on. It can all go through the scope, and that device utilizes 4 helical tacks that are tethered to a 3/0 polypropylene suture. You can place the tacks around the defect, and then as you tighten the suture, those tacks come together to sort of close over a large EMR defect. So for colon EMR, large right colon defects more than 20 millimeters, I am closing either with through the scope clips or through the scope suturing. With respect to ESD, so I do think that the landscape may change with the advent of some newer closure devices, as well as with the gels that you can lay over the surface. Esophageal ESDs, I typically do not close. You do have to be very mindful of the stricture right there, as you alluded to. And a lot of times I will tell these patients that they're willing to come back for serial EGD with dilation to improve their stricturing. In the stomach and in the rectum, I also do not aggressively close unless I see that there's a defect in the muscularis propularis. But I will say that I am very, very meticulous about inspecting the resection base very meticulously. If there's any exposed non-bleeding visible vessels, I am prophylactically coagulating them. So I do take a lot of time to inspect my resection base once the ESD is done. I'm looking for any defects in the muscularis layer. If I see those, I'm definitely going to perform closure. And I sort of meticulously inspect for any non-bleeding visible vessels in the, both in the stomach and in the rectum. Probably the area where I will be more aggressive with closure is any duodenal resection. So we know with duodenal EMRs, for example, with adenoma, there is a relatively high bleeding rate comparison with EMR and other parts of the GI tract, sometimes as high as 15 to 20%. So I do aggressively close duodenal EMRs, and duodenal ESDs I do close. I have a healthy fear of the duodenum, I would say. The small intestine wall is certainly not as robust and thick, and not as forgiving as the stomach or the rectum. So I do more aggressively close in the small intestine than other parts. And stomach, the other important thing is I do keep those patients on a BID PPI, very aggressively to help with that. And I do have them stick to a liquid diet, over the first few days. I don't want solid food coming there and disrupting, the healing process, especially in the first couple of days. But I do think gels will play an important role, and potentially some of the other spray powders. They're quite expensive right now, but potentially can be used to reduce the risk of delayed bleeding. So I think with that, we will we'll welcome our next presenter. This is Mahalo. Mahalo, who will be coming on screen and sharing his video. And as a reminder, please utilize the chat function to ask your questions. We'll try to answer them throughout this session. So Mahalo, welcome, and we look forward to seeing your video.
Good morning, everybody, and thank you for inviting me for this conference. We're going to present a couple of videos at this point, and we will start with our treatment and our management of post-gastrectomy leaks or esophageal leaks by using endovacuum therapy. So I'm going to share that video first. and there should be a pre-recorded voice on it.
Endovacuum therapy. 2 methods of successful endosponge placement for treatment of anastomotic leak in the upper gastrointestinal tract. This is a 74-year-old man presenting for evaluation of anastomotic leak. Past medical history of distal esophageal adenocarcinoma treated with robot-assisted esophagectomy with gastric conduit. Post-operative course was complicated by anastomotic leak in right-sided pneumothorax requiring right thoracostomy tube placement. Esophagram with contrast reveals leak at surgical dehiscence. Endoscopy shows gastric conduit revealing anastomotic clips and dehiscence of the surgical staple line. The multidisciplinary team and patient's preference was for non-surgical management of the anastomotic leak. The patient consented to presenting his procedure. Shown are the instruments needed for both methods. The most important are the endosponge, a 16 or 18 French nasogastric tube, rat tooth forceps, and a suture. First, we cut a hole in the sponge using scissors or a hemostat, cutting all the way through the sponge in order to create a passage for the nasogastric tube. Then we insert the nasogastric tube through the center of the sponge. All of the holes of the nasogastric tube should be within the sponge. Next, we secure the nasogastric tube to the sponge by suturing one suture, alternating from one side of the sponge to the other, descending from the most proximal end to the most distal end of the nasogastric tube as shown. We then decrease the volume of the sponge using scissors, cutting it into a cylindrical shape in order to fit the cavity we are trying to reduce. In the first method, we create 2 to 3 loops of the suture at the tip of the dressing, which will be used to guide the sponge down to the cavity. We then insert a guide wire through a needle into the nasogastric tube. Next, we grasp the loops on the distal end of the sponge with a rat tooth forceps and insert the endoscope orally. As we advance the endoscope to the cavity, the sponge is guided and pulled down behind our scope. Once in the cavity, we ensure that the wire is in place so that it can act as a guide to prevent us from inadvertently pushing the endosponge into the esophagus. Next, we release the loop, retract the endoscope to before the sponge, grasp the tube using the rat tooth forceps, then push the sponge further into the cavity. The wire in the center of the tube serves as a guide when grasping the tube with the rat tooth forceps. This process then continues as we repeatedly insert the endosponge further into the cavity, release the rat tooth forceps, pull the endoscope back, grasp a more proximal part of the orogastric tube, and push farther. When finished, we can see the esophagus and the mediastinal esophageal cavity with the endosponge in place. We will now present the second method of placing the endosponge. The primary difference of this method is the use of an overtube. When using the overtube, it is important to cut the tip to widen the tube's opening so that the endosponge can later be inserted through the overtube. After the overtube is placed on the endoscope is inserted orally and advanced to the mediastinal cavity. The breech is inside the cavity. We remove our endoscope overtube in place. Next, we lubricate the endosponge and insert it into the overtube that now leads directly to the cavity. We guide it down the overtube until reaching the cavity. If the orogastric tube connected to the endosponge coils within the overtube, we can feed a rat tooth forceps down and grasp the endosponge in order to stiffen and uncoil the orogastric tube. If the tip of the overtube is still too tight and the endosponge gets stuck, we can use our scope to push the endosponge through the overtube. Once the endosponge is in place, we can then remove the endoscope. Next, we pull the overtube out. In both methods, we then perform a nasal exchange of the gastric tube by inserting a trumpet into the nares, grasping the trumpet in the pharynx with forceps, inserting the tube into the trumpet, and then pulling the trumpet out of the nares, bringing the nasogastric tube with it. We then connect the nasogastric tube to the wound vac and seal the connection. The wound vac is turned on continuous therapy at 125 millimeters Hg. On follow-up exam, we can see the beginning of the structural changes within the cavity from the vacuum therapy with granulation tissue form. The endosponge is replaced every 3 to 4 days. After 10 wound vac sessions, the last endosponge is removed, and we can see here the successfully closed cavity. Patient was discharged after 10 endovacuum sessions. On follow-up, patient denied any symptoms of dysphagia and is eating without any difficulty. There's no evidence of occurrence of the lesion on 2 subsequent endoscopic exams. Patient did not require any further surgery. Endovacuum therapy can successfully treat anastomotic lesions of the gastrointestinal tract using the 2 different methods of endosponge placement shown.
So that's yeah, go ahead, Prashant.
No, please go ahead.
This is one of the way we used to treat at Robert Wood Johnson Rutgers. We used to treat post-surgical leaks and anastomotic leaks, especially focusing on the chronic and late leaks treatment. For the acute leaks or early leaks, we used to do more of a closure strategy, either that be a stent, endoscopic suturing, or something to acutely close the leak or the perforation. But for the chronic leaks, we know that the closure strategy usually doesn't work, and we need percutaneous, possibly percutaneous drainage or different types of methods to close the leak, which includes endovacuum therapy, sometimes glue, sometimes percutaneous drain and weighting. What are your input, Prashant, regarding leaks?
Yeah, this is a great demonstration. I think that a lot of information can be gleaned from this because we've heard about this. A lot of people have read about this, but having a step-by-step process on how to set the entire system up is very useful, and that's not common knowledge. And so that's a very fantastic video for people to watch. I think obviously this is a labor-intensive process, right? The patient required so many procedures, so many imaging studies, and they're in the hospital the whole time. I imagine these patients are on TPN throughout this, given what's going on in the esophagus, you're putting them on parenteral feeding.
Correct. You have to consent and inform the patient very well about this procedure, because the success that we're going to see, it's going to be at least weeks to months until the actual perforation or a chronic leak closes completely. And again, most of the times the surgeons are not willing to reoperate in these patients. It's a difficult procedure, and the successes for them closing the leak is not high. So as long as the patient is willing to go through it, it's a successful procedure. But it's just going to take weeks or up to months for the patient to stay in the hospital most of the times and have recurrent and repeated procedure every 3 to 4 days.
So
absolutely.
I would actually say that I don't put those patients on TPN. I consent them to put a PEG in. If we can do enteral feeding, that's going to be the preferred route here. These patients are in the hospital for a few weeks at a time, though. It does take time to heal. What I will say that we see in the data in terms of specific to one of the cases that you showed, Mahalo, is that when this is done for cancer treatment, there's a couple of factors that have been shown to be poor prognostic factors with successful endovac therapy. So, for example, if the leak is not big enough that you can get the sponge into the cavity and it is intraluminal, that actually has been shown that you have a reduced chance of success with endovac therapy. The second is if there is a history of radiation in the area. So a lot of times these patients may have neoadjuvant chemo RT, and that has been shown to reduce their ability to have a successful closure here. In the setting, for example, post-bariatric leaks, where there's no, where there's no radiation therapy and where the hole may be big enough that you can get the sponge intracavitary, then usually those patients have a very good response to therapy. One other tip that I would add to the technique that can make it easier, sometimes I'll actually put my scope through the defect. And if there's a post-surgical drain that was left there, I'll actually pass a guide wire in through the surgical drain and grab it with my scope and pull it out through the mouth. And then the reason that I do this is because then I can actually tie the guide wire to the tip of my NG tube. And so as I advance the tube down the mouth, I can actually give tension pulling from the other end from the drain side to wedge that sponge into the cavitary site. So not only are we pushing from behind with the scope, we're able to pull using the guide wire. So I think if you have a drain that's there, utilize that post-surgical access site to be able to help assist getting the sponge into that cavity. Because you showed a good video, but sometimes it's challenging to wedge the sponge into those sites. So I like that as an adjunctive measure for assistance. I don't know if you have any other tips or tricks that you can share with the audience on this technique.
Yeah, I think wedging the sponge is probably one of the most complicated things during the procedure. The other complicated part is just setting that endo vacuum ready for the procedure itself. But I think the biggest mistake that we used to do is making that sponge too big or oversized, and sometimes we would not be able to wedge it, and sometimes even the vacuum would work, but the sponge is too big, so the actual collection will not shrink with size despite multiple treatments. So after some experience and some time, we started actually cutting the most of the sponge and leaving just a little bit of sponge just to make that vacuum functional, but that's all we need. And then you can see the cavity slowly closing and closing, and the wedging would be much easier with a smaller. Well,
yeah, I found sometimes that that if you cut it to a tapered tip of the sponge, that may be helpful as well. And you do not want to have a large amount of sponge left behind in the lumen, because what will happen is with the negative pressure, which can be quite high, -125, you can induce some injury to the esophageal lumen, for example, when the pressure is quite high. Usually, I would say -125 tends to be the more standard setting with a continuous negative pressure, but there's been reports anywhere in the literature from 100 up to 150, for usage. But I do want to repeat again, as I mentioned earlier, this is a labor-intensive procedure. I mean, you're bringing these patients back, every few days to your endo unit. So it's important to have a discussion with them before you undertake this process of what it will involve, because it can be very uncomfortable. Think about it. You're having an indwelling nasogastric tube in for weeks at a time, and if they're non-compliant, they try to pull it out, they're not going to be able to get that sponge to come through their nose. So you also have to make sure that it's secured well, have a very clear conversation with the patient about what they're getting into. But thankfully, the data is quite good with resolution of leaks, and in particular, the group in Brazil, Dr. Demora's group, has done a lot of outstanding work on reporting their data with use of the EndoVac sponge.
I think those are very useful tips, very practical tips to talk about, in terms of making sure a patient will be compliant with this therapy. There is a question from the audience here, Mahalo. Is there any such use of this in the colon, say for colonic anastomoses or rectocolonic anastomotic leaks? Has it been used, or have you used it in those areas?
we actually did 2 patients last year that we used it for colonic anastomotic leaks. The principle is basically the same. You put it under 125, usually 125 negative pressure with intermittent suction, and then you have to exchange it every 3 to 4 days maximum. But again, we have to make sure that the patients understand how cumbersome these procedures are and what their expectations are. That it's going to take months, and this time, unfortunately, the tube will be coming out of the rectum on negative pressure, so the patients are a little bit more uncomfortable compared to the patients with esophageal leaks, I would believe.
In this setting where there's stool contamination of the potential leak site and stool coming through the colon, is there any strategies that you're employing to try to reduce fecal contamination of the leak or the perforation or whatnot? Are these more patients that need to be on parenteral nutrition or liquid diets, or how do you manage that, or does it make a difference?
Yeah, so that's a very difficult question. One of the patients was actually had an ostomy, so we had that rectal leak bypass from stool contamination. The other patient, unfortunately, did have a full colon, so there was a stool contamination. But again, you treat them with antibiotics. You change the catheter more frequently, every 2 to 3 days in this kind of scenario, and just with time, it should be getting better. In terms of nutrition, I don't think there's data whether you should put these patients on TPN versus continue the enteral nutrition. And we usually prefer whatever we can to keep them with enteral nutrition because it's multiple, for multiple reasons, is better than parenteral nutrition. As long as the patient is not having signs of infection, you can continue the treatment despite having fecal soilage around the anastomotic leak. Again, most of it is taken care of just with the vacuum therapy itself.
Great comments. Thank you, Mahalo. Those great teaching points, great videos. I think what we're going to do now is move on to our next presenter, who will be Rodrigo.
Hello, everyone. I'm Rodrigo Duarte. I'm also a previous fellow of Dr. Kahela, everybody here. We're going to present a case of cricopharyngeal myotomy. So we're going to start a little bit of a background of what the cricopharyngeal bar is. A cricopharyngeal bar is mainly a radiologic finding, and it refers to a posterior indentation at the pharyngoesophageal junction found during the modified barium swallow. Although this is maybe a normal finding in patients without dysphagia, in patients with dysphagia may be indicative of dysfunction of the cricopharyngeal muscle, which relates to the upper esophageal sphincter. Traditionally, in the past, the treatment for this condition included dilation, Botox injection, and sometimes endoscopic surgery. Recently, the POEM technique has been adapted for the treatment of this pathology, using the same technique used for Zenker's diverticulum. We're going to present the case of the patient. We had a 75-year-old female, and she was disclosing dysphagia for about 10 years, mainly to solids. The issue was when she started to develop to liquids, she started to look for more help, and that's when the patient came to. Hold on, we're having issues with sharing.
While he's pulling that up, we'll get to some of the questions. And
no, it's good.
You're good? Okay.
Yeah. So she was, when she developed dysphagia to liquids, that's when she got more workup, and she was found to have the cricopharyngeal bar on radiology. And then she was, because she was having dysphagia and the findings on the barium swallow, she was referred to us to consider a procedure. So the decision was to perform myotomy of the cricopharyngeal muscle, adapting the Zenker's Z-bond.
Rodrigo, I'm not sure if your screen is sharing. Are you trying to show the video right now or just speaking?
Yeah, I don't. It should be sharing right now. Hold on.
Okay.
Is it showing now?
Yeah. Now
Okay.
Yeah. Great.
So, like any Z-poem, we started with injection of submucosal space, and horizontal incision was made to create the tunnel in a usual fashion. After the initial submucosal space was injected with ORISE, then we started submucosal injection using the Irby jet, and this section was carried until the muscle, the upper esophageal muscle was identified. We're going to show later how deep was the. Now you can see the circular muscles of the esophagus, and until about a 3 to 4 centimeter tunnel was performed, and we were completely sure the cricopharyngeal muscle was visible and ready to be cut. After this, the myotomy of the cricopharyngeal muscle, as you can see, is more of a bulging compared to the circular muscle of the upper esophagus. So myotomy was started in with the hybrid T knife. In patients with CPOM, this part of the procedure you can use the isolated tip knife. In this case, since we had a wide tunnel, decision was made to continue using the hybrid T knife for this purpose. The myotomy was extended down to include the fibers of the upper esophagus, and as you can tell, it was 3 to 4 centimeters myotomy. After the myotomy, the closure was performed vertically using 11 millimeters clip. We used 3 clips, and we got a good closure. Our protocol in Robert Wood was to admit these patients for observation. So it was the same with this patient. She was admitted. An upper barium swallow was obtained the day after and showed with no leak. And after diet was started and the patient tolerated diet, the patient was discharged. She had a follow-up 2 months later, and her dysphagia has completely resolved. And also, as you can see in this barium swallow later on, the posterior indentation by the muscle has completely disappeared. And in this patient, the adaptation of the POEM technique to treat cricopharyngeal muscle dysfunction was efficacious to treat the dysphagia. There's not a lot of information, a lot of evidence about the use of this technique. There's not that many case series, but seems promising to use what we call Z-POEM for cricopharyngeal bar. Now I'll leave you for you guys to discuss.
Fantastic presentation, Rodrigo. Yeah, so clearly the myotomy techniques in the foregut are evolving. So many different indications of them now. CPOM is a relatively new indication, and it's a spin-off of the Z-POEM, right? It's basically a precursor kind of pathophysiology that has not yet turned into a Zenker's, but it's the same cricopharyngeal bar hypertrophy that's causing this high pressure zone. From my experience in these procedures, it's very important to really look at that esophagram. Sometimes people will send for dysphagia and claim that they have a bar or whatnot, but really going through it, even with the radiologist, to identify that cricopharyngeal bar and the prominence. Sometimes they'll call it a premature contraction. Sometimes they'll see a distinct bar that is consistently there. Those are all important, ways to figure out which patients would be good candidates for this procedure. Yeah. I think that. Sorry, go ahead.
No, go ahead. I was going to say it's one of the theories that actually it's a early Zenker's, and this function will just cause the outpoaching, and then you got the Zenker's later on. And right. The issue that you mentioned is pretty important because you may find the cricopharyngeal bar in a completely asymptomatic patient, and doesn't necessarily mean the patient needs the myotomy. In this case, the patient was having dysphagia. We found the bar, and then we treat the bar, and then her dysphagia went away. So it's clearly indicated case.
Technically, these procedures are, in my opinion, slightly more challenging than an actual Z-POEM, right? You would think that it's just a shorter myotomy, a little hump in the tissue, but actually it's more challenging because there's a lack of space in that cervical esophageal region and the piriform sinus. You're almost really inside the sinus when you're starting to do this procedure. And as opposed to an open pocket where you can actually maneuver the scope inside of a tunnel, with CPOM, you were working with very small dimensions and whatnot. So how do you think the learning curve is for someone to step up to a procedure like this? And what has been your experience with this and Nikhil and everybody else in the audience and trying to do this and make sure you have the orientation of your scope and right for these procedures?
I think that these are very challenging procedures. I agree. Scope stability is very tough in this area. You're in very proximal esophagus. There's very little room for error. I think ZPOM, where you have a little bit of an open cavity and you have a septum that you can clearly see and divide, sometimes it's not as obvious endoscopically where you might have a prominent cricopharyngeal bar. I think Rodrigo made a very great point that sometimes you may find this, but if the patient's asymptomatic, you don't need to do anything. The most common presenting symptoms of cricopharyngeal bar are dysphagia and regurgitation. There is not a lot of data, although recently, I think in May in GIE, the Hopkins group published their experience with about 25 patients or so that they did a cricopharyngeal poem on. And they had pretty good clinical and technical success rates with improvement of dysphagia and regurgitation symptoms with a significant reduction in dysphagia score. They did have one or two recurrences. So overall, the recurrence rate is low. The other technical point that I think is important, aside from scope stability being a major issue, is that when you're doing closure in this area, you don't have a lot of working room. You're in the very proximal esophagus. So you saw in some of the earlier videos, we were doing mucosotomy closure with the overstitch device. However, that utilizes, a double channel scope oftentimes with an over the scope mounted suturing device, and there's just not enough room to work in that area for closure. So my preference for Z-poem closure or cricopharyngeal bar poem closure is to use clips that have very, very short tails and stems. Because if you use some of the clips on the market that have a longer tail or stem, that will irritate the patient and cause them to have discomfort in the posterior pharynx or in the upper esophagus. So I like the ones that have very, very short tails or stems for closure. Rodrigo, do you have any other additional points or comments that you think would be helpful for the audience in terms of technical tips or, to Prashant's point about the learning curve? For me, I think this is something that is going to take more cases for someone to become proficient at, as opposed to standard esophageal poem or Z-poem.
Pretty much to wrap up what you guys both discussed, it is technically difficult because, as you mentioned, your landmarks are not there like a Z-poem. So you're going to have to identify really well where your dissection is going to be. And once you did the myotomy, the other issue will be with closure. As you said, short stem is crucial there. And also you open horizontal and then you have to close vertical, which in this case, like in a diverticulum, you will have a little bit more mucosa to pull in and do the vertical closure. In this case, is a pretty much normal anatomy. So the closure is difficult, and that will not probably you have to get more proficient in Z-poem technique before you start to jump into cricopharyngeal bar.
Absolutely. So I think those are all very important points. Short stem clips are probably the way to go for these Z-poems and whatnot. Expect for your patients to have some discomfort, throat discomfort, a little bit of dynaphagia. Sometimes people have a globus sensation after these procedures because of those clips. Usually within a week or two, they will disappear. After even a few days, the patients feel much better, but it's not uncommon for them to have some soreness and globus. If that globus persists for more than a few weeks, these are the patients where you may want to consider getting an x-ray to see if there's a retained clip and have to remove those things. But in 9 times out of 10, we have not had to do something like that. I think we've done it maybe once in all of our cases, but something to be mindful of that if there is any persistent globus, some of those clips can sometimes just hang on, but for the most part, they do fall off. So excellent discussion, excellent case, Rodrigo. We're going to transition to Abed here for our next presentation.
Hi, everybody. My name is Abdulhai Abdulkader. I am a recent graduate about 2 years ago with Dr. Kahela and practicing in private practice in Florida. So we have a little bit of the palm trees in the background. Just to finish up on the last case, anybody on the panel, if thoughts on use of through-the-scope suturing for these mucosotomy sites, if they've been tried, and their ability to maintain avoidance of a leak afterwards.
I personally am not a fan of using the through-the-scope suturing for mucosotomy closure in the esophagus. You know, you have a tubular organ with your scope running in parallel with that organ, and in my opinion, for best utilization of that helical device, you want to get the helical device to be ideally perpendicular to the tissue plane. So I find that puts a lot of extreme, scope pressure in the esophagus, and then you're rotating a helical device in the esophagus, where particularly in the mediastinum or the thorax, there's not a lot of I don't want to cause injury to anything outside of the esophagus. Although those helical tacks are short, they're only a couple of millimeters in length. They have been utilized by some people for stent fixation, and some people have used them for poem closure. And my personal preference is not to use it in the esophagus. I do think that there are potential applications for it for closure of gastric poem mucosotomies. The stomach's a little bit more forgiving, and as I mentioned before, for closure of large colon EMR defects, I think that works quite well. But I'm personally a little bit hesitant in its use in the esophagus, and I definitely in a cricopharyngeal or zenchromatome, I think those are too proximal for usage, and if they get retained, those are very difficult to remove because those helical tacks have barbs on them, so they can be quite challenging to remove, especially that high up in the proximal esophagus.
All right, awesome. Thank you for that. All right. So here I'm going to be talking about a case for a lesion in the colon and the rectum that was removed by conventional ESD here. And before we start the video, we can see a little bit of the marking around the lesion. Typically, you want to mark around the lesion, identify your border, especially if you're going to use a full thickness resection device, BioVesco or typical ESD or any other device, really helps establish your borders. And I find the more markings you have, the better maintains your visual borders as you're manipulating the tissue. So here we have the injection needle and injecting Eleview here in the submucosa, expanding it. And we see here we get a really nice bleb at the perimeter of the lesion.
Can you review where is this lesion and what type of lesion is it?
This is in the distal rectum. This is a sessile polyp that was attempted to be removed by prior polypectomies that was residual. And then opted to do removal by conventional ESD, mid to distal rectum.
Fantastic, thank you.
Mm-hmm. So here again, we see the injection. And the rectum is a nice area to work in because you have a bulbular cavity, allows you to have a little bit more space as well too. And then this is the dual J knife being used to dissect the submucosa as well too, and creating a lip here. And here we can see our lesion essentially is starting to dissect and starting to retract as well too. And at the top of the screen is the center of the lesion that we're attempting to grab. And here we're using a device that allows us to create some additional traction once we have a bit of a lip on the lesion. Let's go back and fast forward here for a second. This is a device that has two wires that are kind of a taco shaped and attached to a clip. And that clip is right at 6 o'clock position here. And the other side of the clip is allowed you take another clip essentially and clip on the posterior wall behind the lesion. So the concept here is as we're dissecting, it starts to retract on its own. and gives us that tension and really shortens your dissection time. You can typically aim that away from you versus if you use a clip and floss, that'll be traction towards you. And here we can see some adipose tissue. This turned to be a significant submucosal fibrosis that turned into a full thickness resection. We can see a lot of that tissue and some of that blood coagulate at the bottom part. We can see our resection site here is quite large. So after removal of our lesion, we opted to use the suturing device to close the defect. And here we have kind of a large area, but we have sharp margins. So this allows for really deep, full thickness bites.
Abed, can you comment on how full thickness resections in this area in the rectum below the peritoneal reflection may be safer or we may be more comfortable with that because of the anatomy compared to other areas of the body?
Yes, so multiple things that's unique to the rectum. Well, you have about the mid-rectum separate from the pelvic reflection. So as long as the patient hasn't had any prior pelvic surgeries, technically is somewhat separate from the peritoneal cavity. So if there's any fluid or anything that kind of leaks through, it's kind of contained into the below in the pelvis. Two, you also have a larger cavity and it's short distance as well too. So visualization is fantastic. And you could even use a gastroscope in this case, or even a 1T or any type of gastroscope that you wanted instead of a traditional colonoscope as well. So accessibility, space, and the anatomy extraluminal as well too. And here you also have to keep in mind of any extraluminal structures in terms of the female anatomy or prostate in the males as well too, if you're understanding your orientation anterior and posterior in the rectum. And here we can see the...
You can get more aggressive with these rectal resections, because especially as you mentioned, if the peritoneal reflection is intact, they tend to do quite well. I worry more about soilage. If you have stool that that comes down and then leaves through the full thickness resection site, but if they have a good prep, patients end up doing quite well. Even when you have to go full thickness, when you're above the peritoneal reflection, that is where you have to really make sure that you've got very, very good closure and avoid any egress of GI contents, because that can lead to peritonitis, which can be quite challenging, because then sometimes patients need a washout.
Yeah, usually even in these patients, even if it's somewhat of a small to medium-sized lesion, I tend to ask them to do a full colon prep as well too. You have nothing to lose, and if you end up being more aggressive, you have everything to gain as well too. You're going to give them antibiotics anyways, but it's just one less thing for us to worry about in terms of closure and making sure there's no leakage. Absolutely.
Better safe than
Heals
sorry.
very well.
Abed, what's your post-procedure management for these patients? When you go full thickness like this, are you admitting them? How many days of antibiotic? What's their diet post-op? Can you explain that?
In general, the first day after the procedure, I keep them strict on PO. Then the following day, I start them on clears. I put them on Miralax for about 3 to 5 days. I let them know that they're not allowed to be constipated and avoid high fiber as well too. So about 3 to 5 days of Miralax twice a day, starting the day after the endoscopy. And I put them on a 2 to 3 day liquid diet as well too. I almost always admit them the following day as well too. Even I had a 4-centimeter lesion that I removed in the cecum through M-block through ESD, and I decided to suture that site closed using X-Tack and reinforce it with some clips, and kept the patient overnight. And in those patients, being more aggressive and preemptive is always the better route, because sometimes these patients may appear in the ED, they may come in with abdominal pain, and they're going to probably see a couple foci of free air, and then the surgeon being called and perhaps undergoing further intervention that might not be necessary.
Yeah, that's a good point. When we're doing third space cases, I think it's paramount that we use carbon dioxide, because especially when you're going full thickness, you will expect to see capnoperitoneum, if you're above the peritoneal reflection. The CO2, though, is very important because that will get reabsorbed much more quickly than air. However, if you need to, and you notice that patient's getting capnoperitoneum, you can decompress using an angiocath or a Verus needle. It is very important, I think, that you communicate, if you're admitting them for observation, you communicate with the primary team that capnoperitoneum is an expected finding after a full thickness resection. And as long as there's no signs of peritonitis and you've achieved closure, then there's generally no surgical intervention that's warranted. And sometimes you have to talk the surgeons off the ledge. One of the things that can be helpful if there is any concern that there might be a leak is that you get a contrast-based study to see if there's any extravasation. If there is any extravasation, then some additional intervention is warranted, either endoscopic or surgical. But it's very important to have open communication with your primary team when you're admitting these patients, and certainly a surgical team if they, for example, if a patient just gets a routine X-ray after some of these procedures, they'll get called that there's air under the diaphragm, and if they're not aware of what we're doing, then they may reflexively just call surgery thinking if there's a perforated viscus. So very important to communicate with the teams what we've done, really do our best in terms of durable closure. And then when you're above the peritoneal reflection, really make sure that you, if you do have full thickness, you avoid any egress of luminal GI content into the cavity. So if that means you have to change their position, try to keep the defect on the anti-gravity side so that there's no stool or blood leading to the peritoneal cavity.
During the procedure itself, I typically don't inject contrast, but I know sometimes people may do that, but that's just another consideration. Sometimes if there's a lesion that you're not sure if you need to add another suture there or clip or reinforce that closure site as well too.
These are super important points to when you're talking and you're engaging in these types of procedures, because these are the practical points that you don't really think about until after these procedures happen. Anytime I do a third space procedure on the patient, when they're discharged from the hospital, I inform them that if they have any reason that they feel like they need to come back to a hospital or emergency room, I want them to come back to our emergency room. I want them to come back to our hospital. I want them to name my name in the emergency room and ask the doctors to call me personally, because these are where, miscommunications and mismanagements can happen, because somebody who's not familiar with what we're doing, because it's not necessarily common knowledge to so many surgeons out there, can make a mistake, misdiagnose someone with perforation or whatnot, and bad things happen. And so really informing the patient, taking ownership, and making sure they get back to your center so you can manage them is highly important. Another comment I'll make on these types of procedures, which are fantastic demonstrations, full thickness resection procedures, I also think it's important to admit the patient initially, because they do have a decent amount of pain. With some of these full thickness resections, even though you've closed everything and there's no contamination, the actual air and CO2 insufflation into that space, and then also full thickness inflammation that occurs at your resection site, a lot of these patients will have some significant pain for a day or so. And so just managing that as an inpatient so that they don't have any issues as an outpatient is a good thing. And then finally, you mentioned the point of, contrast studies, if there is a concern for leak in these patients, CT scans, contrast, IV, et cetera, if you're going to be doing luminal contrast for looking for leaks, think about the type of contrast that you're using, right? So if you're going to assess for a leak, you're going to try to avoid using barium on your contrast study, because the barium, especially in this area, it's okay because it's below the peritoneal reflection, but for upper GI ESDs or any type of perforation above the peritoneal reflection where there's potential seepage into the mediastinum or peritoneum, you can get barium peritonitis and whatnot. So doing a water-soluble contrast is important for that evaluation to protect patients from peritonitis. I think we're actually time's up for the live cases and for the video cases, and we're going to transition back to lectures here. Fantastic presentation, Abed, and thank you for the entire panel for all of this discussion. Everyone's done a great job.
Pleasure.
AI-driven test to predict the risk of progression from Barrett's esophagus to cancer. TissueCypher.
Hi, everyone. My name is Nikhil Kumta. I'm an associate professor of medicine and system director of interventional endoscopy at Mount Sinai Hospital in New York City. I want to thank my teacher, my mentor, and my friend, Dr. Michelle Kahela, as well as the entire MAGIC planning committee for the kind invitation to speak on artificial intelligence in gastroenterology. I'd also like to thank Medtronic for their sponsorship of this symposium. Here are my disclosures. So in this talk, we'll review the creation of technology, terminology related to artificial intelligence, and the AI revolution. And then we'll talk more specifically about AI and its applications in healthcare, as well as gastroenterology, paying specific attention to the data that's out there on AI in colonoscopy and polyp detection. So what exactly is artificial intelligence? It's an information technology system that essentially tries to mimic the human brain. As humans, we use our senses, whether it's vision or hearing, and then we take that information and comprehend it in our brain as to what that input is. And then we act on that information. We also store that information back into our brain, which enables us to keep learning. AI does the exact same thing, but at a much lower capacity than the human brain. This is not the first revolution that we've been through as a society. So if you think about the mechanization of transportation, for example, going from horses to cars, and then that led to the Industrial Revolution, where we started to automate repetitive physical work. In the intelligence revolution, we're seeing a similar effect with AI and healthcare. So here's a glossary of multiple terms that exist within the field of artificial intelligence, and we'll take a deeper dive into some of these terms. So as mentioned earlier, artificial intelligence essentially tries to mimic the human brain, but it's different from humans in two ways. Number one, AI will learn exclusively from the input data and can only understand what it has been programmed to do. Secondly, AI predicts with extreme precision, but it cannot explain the logic behind those decisions. So in terms of the terminology within AI, artificial intelligence is any technique that enables computers to mimic human intelligence using logic, if-then rules, decision trees, and machine learning. Machine learning in and of itself is a subset of AI that uses statistical techniques that enable machines to improve at tasks with experience. And this category includes deep learning, which is a subset of machine learning composed of algorithms that permit software to train itself to perform tasks such as speech or image recognition. And overlying all of these terms is what's known as computer vision. Computer vision is kind of like human vision, but the computer is visualizing something on our behalf. So a simple example of that is facial recognition, such as using your face to unlock your phone. So we think back about the evolution of how AI started. You can see in this picture that sometimes it can be hard to distinguish whether it's a puppy or a bagel, or in this case, a chihuahua or a blueberry muffin, or a labradoodle or fried chicken. And people invented algorithms to try to distinguish between these two. But this was the early days of AI. And as we know, AI has evolved at warp speed to what it is today. And over the last 5-6 years, we've really seen a fast evolution of the ability of AI to really approximate human capabilities. So for example, in 2016, there was a really good model developed from a vision standpoint in terms of object recognition. And then we saw additional improvements with speech recognition, reading, translation, speech synthesis, and language understanding. So a classic example of language understanding are the algorithms that are in our emails. If you receive an email asking for a 12 p.m. meeting, for example, and you start typing a reply as yes, the algorithm will help you automatically generate a reply. Yes, that works. Yes, that's a great time. And this is a classic example of language understanding. Now, these can sometimes be applied towards colonoscopy, for example. Summarizing colonoscopy findings is an application of language understanding and AI technology. Now, there's numerous applications for artificial intelligence in healthcare. So AI can be used for big data analysis, for natural language processing, for voice recognition, robotics, clinical pathways, statistical analysis, and even predictive modeling. But for this talk, we'll focus more specifically on image analysis because that's where it right now is having its biggest impact within healthcare. A number of fields within medicine are being impacted by AI, whether it's radiology, optho, pathology, cardiology, or dermatology. In fact, in my institution, a number of the CT and MRI scan reads are being done with AI, and there's still a clinical team of residents, fellows, and attendings that are reviewing the scans, but there is an AI read that is included with the majority of our cross-sectional imaging. And AI can be very disruptive, not only in these fields, but also within gastroenterology. If we look specifically at dermatology, actually, with identification of carcinoma or melanoma, in certain instances, like in this paper, for example, the neural network, the AI, actually identified skin cancers better than 25 dermatologists. So over time, especially with deep learning, the smarter the machine gets, the more it's able to be very precise and potentially even pick up things that expert trained physicians are unable to do. So why AI in gastroenterology? Well, if you think about it, when we're doing endoscopy, we're often diagnosing, assessing, or treating purely just in that one endoscopic session. It's not like in radiology where you can go back at a later date and re-review a scan or have a colleague take a look at a scan. Endoscopy is an invasive operator-driven procedure that requires real-time examination and high-level expertise and analysis of mucosal features through a video-based review. So this is actually an ideal space in which we can apply computer vision and AI. So there are a number of potential applications for AI in gastroenterology. The main one that people are familiar with, which is available in the United States today, is polyp detection. But there's also research being done in terms of polyp diagnosis and characterization. So this is looking at size of polyps, as well as prognosticating on the pathology of the polyps, whether it's hyperplastic or adenomatous. We can also use AI for colonoscopy outcome measures, data documentation, identification and characterization of Barrett's esophagus, IBD, capsule endoscopy, early gastric cancer, and even pancreatic cysts. Over the years, there have been a number of publications, especially more recently, looking at artificial intelligence and gastroenterology. And this is a chart that just shows the explosion of papers that have come out since 2015 focusing on AI in GI. And this was one of the first papers before the current AI evolution that looked at polyp image classification. So this was a hand-programmed feature where the still images would be reviewed by AI. It can only be used on still images, not live video, because the processor was not fast enough to account for live endoscopy or clinical care. But basically, the computer was able to recognize, is this a polyp in this image, yes or no? It couldn't tell you where it was located, but it could take a look at the image and say, yes, this is a polyp, or no, this is not. One of the other earlier examples of AI in the literature is coming from this group in Spain. This was published in Endoscopy in 2016. And what they looked at was the creation of energy maps to try to delineate where a polyp was. So this was 6 years ago. And if you think about the evolution of AI since then, this is what we're really dealing with in today's colonoscopy with AI. So we have image identification of various different types of polyps. So you have flat sessile serrated lesions versus more adenomatous lesions, and ones that vary in size as small as 2 millimeters. So let's take a look at what are the key areas of AI use in gastroenterology, both in current applications and potential future ones. This is a rapidly evolving area. So on the top left, you have computer-aided detection. So this is where the computer algorithm is looking at the colon wall, and it's telling you what is abnormal and putting a box around it. And this is utilized today with a couple of different applications that are FDA approved. In the middle, you have computer-aided diagnosis. So this is where the algorithm can tell you by looking at this colon polyp that not only it's a polyp, but that it's hyperplastic or adenomatous, and I can actually give you a probability of what the pathologic likelihood is. Then we also have newer endoscopic quality indicators that can be assessed using AI. So for example, something that can be studied in a research perspective right now and potentially applied down the road is looking at what's the percentage of surface mucosal inspection done, or what's the quality of the bowel prep in terms of the Boston Bowel Prep score. Then on the bottom, you have natural language processing, which basically abstracts relevant text from notes or from EMR, and it can integrate it into a multimodal sensor fusion to predict the outcome of a specific question. Another potential application of AI in GI is precision medicine, using the data that we have available to know whether an IBD medicine will work on a specific patient. And then finally, a growing area of research is digital health, in particular wearables, which are devices that can accumulate a ton of data. For example, if you have an Apple Watch, it can get your heart rate, your activity, your sleep, and this is able to accumulate a lot of data that potentially can be utilized to identify early onset of certain disease processes. So we can see that there's a lot of potential applications within GI, and how can this potentially close some of the gaps or challenges in modern endoscopy? So as we spoke about with endoscopy, it's essentially a one-time procedure where you're utilizing video-based images, live video, and we need to, in real time, be able to detect and diagnose. And there are ways now that AI, in particular, can help an endoscopist improve or augment our detection. On the flip side, there are potential challenges with implementation of this technology in that it can be very costly. Sometimes it can be difficult or impossible to interpret. And in certain cases or potential applications, there may be a lack of widespread expertise. But we'll take a closer look at AI in colonoscopy and in particular colon polyp detection, where there's really been significant headway made over the last few years. So pretty much every company in the GI space is working on some sort of artificial intelligence pertinent to their devices or scopes. But the two that are currently FDA approved in the United States are the Medtronic GI Genius for polyp detection and colonoscopy, and AI's Vision, which is also a recently approved FDA technology for colon polyp detection. So what does this look like? These are simultaneous videos where on the left, there's no AI, and on the right, you can see that there is artificial intelligence being utilized. So this is a lesion that's in the ascending colon. You can see it's a very flat lesion. There's a little bit of an adherent mucus cap, but you can see that it's very easy to spot with the box that's around it on the right compared to one on the left, in which sometimes lesions like this can be very easily missed. So we'll clean the polyp, and you'll see how the AI is able to readjust the size of the polyp after the mucus has been cleared off. And as you can imagine, it's very easy with the AI to identify potential lesions, especially more challenging ones like the flat sessile serrated lesions that we frequently encounter these days. Here's another example of GI Genius at work. So doing colonoscopy, and then very quickly, the AI is able to detect and place a box around the polyp to assist us with identification, and then we're able to perform a polypectomy for removal. Let's take a little closer look at the data for AI in colonoscopy. This was the AIDS study, which utilized GI Genius. It was published by Ali Rapici and his group in gastroenterology a couple years back. And they had 700 eligible patients that they randomized to either just high definition colonoscopies or standard of care versus high definition colonoscopy with the adjunct of AI utilizing GI Genius. And what they found was that there was a 30% relative increase in ADR and a 40% relative increase in adenomas per colonoscopy. So very significant results when utilization of AI, in this case GI Genius, to help augment colon polyp detection. In this graph, you can see that not only is the adenoma detection rate statistically significant, but there was also identification of smaller polyps, medium-sized polyps, and bigger polyps where the AI arm had higher rates. This was also seen whether the polyp was polypoid or non-polypoid, and irrespective of location, the AI was able to detect more polyps both in the proximal as well as in the distal colon. So that was, in expert hands. What about in non-expert hands? So there was another study that was done where they took non-expert endoscopists, including some with very little experience in training, and they utilized AI in a randomized controlled trial. This was done internationally to see how AI could potentially assist non-experienced endoscopists. And what you can see is that whether it was a neoplastic lesion in the distal or proximal colon, polypoid or non-polypoid, and small or large polyp size, that in every one of those characteristics, the AI performed better than just standard high-definition white light alone. Now, adenoma detection rate has been evaluated in multiple randomized controls trials at this point, and this meta-analysis found that AI consistently improves ADR even in high-performing groups, and the improved ADR was regardless of polyp size, location, or morphology. In fact, AI actually increased the ADR by 1.44 risk ratio, and the absolute increase of ADR was from 25%, which is considered the standard benchmark, up to 37% in terms of adenoma detection rate. Here's another example of a meta-analysis that was done looking at randomized trials, specifically focusing on lesions that we are concerned about, those flat sessile serrated lesions. And you can see here that, again, the risk ratio was 1.67 and significantly favored the utilization of AI as opposed to just the control with standard high-definition white light endoscopy. So AI can help detect polyps irrespective of location, of size, of morphology. One of the areas that it can potentially be helpful for, and this was a study that was published last year in Gut, is actually polyp sizing. We know that traditionally we're not very good at estimating polyp size. A lot of times we actually overestimate the size. And utilizing AI, we can actually more accurately be able to detect the appropriate colon polyp size. So AI has also been used to determine what resection site to close. Now, most of us, when we're doing a resection and determining whether we're going to perform closure, utilize some of the more normal predictors, such as the size of the colon polyp, the location, whether the patient is on anticoagulation. But this study published a couple of years ago asked the question, can we use AI to actually assist with prediction for the specific patient that we have on the table in terms of their bleeding risk? And so they looked at the maximum diameter of blood vessels, the minimum radius of the blood vessels, the length of the blood vessels, and the overall length of distance between 8 neighbors in a chain that digitally formed an object contour, as you can see in the diagram below. And they were able to independently associate which EMR defects were going to have a higher rate of potential bleeding, and therefore guide the endoscopist on what resection sites should be closed prophylactically. If you haven't seen this already, this was an article that was published this year in Gastroenterology, and it looked at the impact of artificial intelligence on miss rate of colorectal neoplasias by Mike Wallace and a few others. And what they found was that AI resulted in an approximately 2-fold reduction in miss rate for colorectal neoplasia. And so it supported the benefit of AI in reducing errors for small and subtle lesions at standard colonoscopy. So the question always comes up with utilization of AI. How sensitive is it? Is it better than expert endoscopists with identifying polyps? And then what's the false activation or sort of false positive rate of this? So this is data that was examined in a multi-center trial. It was published in Gut a couple of years ago, and it looked specifically at GI Genius. And what it found was that GI Genius had a 99.7 sensitivity rate. It actually detected polyps faster than 82% of even expert endoscopists, and it had a very low, less than 1% false activation rate. So the question always comes up, will AI replace humans? And I think we can emphatically say no, and I'll explain why. So what makes AI different from other technologies is that it's going to bring humans and machines closer together. Now, AI is sometimes incorrectly framed as machines replacing humans, but it's really not about replacing humans so much as machines augmenting humans. So AI in the coming years is going to help improve our diagnostics, going to help increase our precision. It's going to make us more consistent and reduce variability across the board. Whereas if someone gets a colonoscopy, say in New York, versus if someone gets a colonoscopy in Montana, you want to reduce the consistency or variability. You want to reduce the variability and make it more consistent across the board. Now, humans and machines both have relative strengths and weaknesses, but it's about the combination of both of them together that will really allow endoscopist and patient outcome process to be able to scale 10x, 100x, or beyond that in the coming years. So why should we care about AI? Well, let's take a look at this study, which actually is not related to GI, but is a general psychological evaluation. So as the day progresses, our attention span is reduced, our reaction time changes, and in this experiment, as mental fatigue increased throughout the day, the mean reaction time increased, and the accuracy of decision-making went down in that setting. So this makes sense, right? If you think about it, if you or a loved one needed a procedure or a surgery, if you had to pick the time of day, would you prefer to be the first case of the day or the last case of the day? I think most of us would want to be the first case of the day because we want to have, our proceduralist have a very good attention span, have very good reaction time, and not get fatigued that can potentially impact their decision making. Well, the nice thing about AI is that it doesn't get tired, it doesn't need sleep, and it functions, accurately and precisely when it's been appropriately trained. So, with that, the future of colonoscopy is extremely intelligent. And so in the last couple of minutes, I just want to highlight what's ahead. So the first is that we can potentially in the future be able to learn from unlabeled data. So what that means is that if you have a video of a colonoscopy that you did, you can upload the video and the data will learn on itself. Collaboration is also going to be extremely important between AI and the endoscopist. And so what that means is that we as the experts in our field in GI need to supply the pain points to the engineers. Nowadays, there are sophisticated and huge teams that are dedicated to writing the code, being able to, to be able to employ the mechanisms needed to write these sophisticated codes that we can utilize for AI. And so we can't do this on our own as GIs. We don't have the background, the training. So we need to supply the pain points and work with the engineers and the coders to help them with their algorithms so that we can potentially use it down the road. I think AI for quality control is also going to be very important. As I mentioned before, we'll be able to utilize AI not only for calculating adenoma detection rates, but also determining the percent of the surface mucosa that we inspect, looking at the Boston Bowel Prep score, and a number of other potential quality measures that can be assessed with AI in the future. And then sometimes the AI will be able to see things that we can't even see. And I think this will be very helpful. For example, one thing that you can consider is whether AI can be utilized to, in real time, be able to identify areas of dysplastic Barrett's, something that right now with our own eyes and with NBI, we can't be able to histologically differentiate, but potentially AI can be trained and augmented with near focus or NBI or other types of chromoendoscopy to identify dysplastic lesions and help us with targeted management. There are a couple of issues with AI in the States, especially. One is FDA regulation. There are also financial implications with use of artificial intelligence in GI, and then potential legal issues. If there is a false positive, which thankfully the false positive rate is low, that patient may undergo an unnecessary treatment. The flip side is if there's a false negative and the AI does not detect a lesion, then a patient may not undergo a needed treatment. So in summary, AI, artificial intelligence in GI is here to stay, and it will only grow over the coming years. At the moment, the best current application is for looking at GI mucosa. So this is looking for dysplastic or cancerous lesion. And in particular with colonoscopy, we reviewed the data that AI consistently improves adenoma detection rate, but there are multiple potential applications in GI, and over the coming years, we'll certainly see these applications come into more prime-time fruition. The thought process is that AI will augment endoscopists, so it will help improve our diagnostic capabilities, it will improve our precision, it will improve our consistency, and it will reduce our variability so that it's not as endoscopist dependent. And then we talked about being AI with the programming and the coding being very complex. So collaboration is absolutely essential moving forward, particularly as we identify pain points, working with companies and working with industry to help develop new algorithms that can help us down the road. And then finally, we need regulations and legislations to help empower us as endoscopists. So with that, I want to thank you very much for your attention, and I look forward to the question and answer session. Thank you.
S-Path Pre-Mounted Biliary Stent System by Endo GI with a novel integrated RX proprietary self-detaching tip.
Hello, thank you so much for this kind invitation. Thank you, Michelle, and your team for this great endoscopy event, MAGIC. So I will talk today about artificial intelligence in advanced endoscopy. Endoscopy is a gold standard technique in the management for diagnosis and treatment for gastrointestinal disorders, including biliopancreatic disease. Most recently, technology advanced has improved the management of biliopancreatic disorders, including software for US diagnosis, elastography, histogram, contrast, Sharewave, and single-use cholangioscopy as a spyglass and IMAX for the diagnosis and treatment. However, in spite of the scientific and clinical benefits for patients management, many barriers for a widespread use are observed. What are the limitations? For endoscopic ultrasound, for example, learning curves are a big barrier because this can take a lot of time for achieve a good training for the fellows in training programs. Training centers. Few centers are available worldwide. Cost of training, the image interpretation, and operator skills. In cholangioscopy, the image interpretation, for example, the inter-observer agreement, and the cost per procedure are some of the limitations that can lead with these advanced technologies and techniques. Recently, this is a very good paper that has been published by Michelle Cajale and an international group where we participate. And I love the title of this paper, Digital Cholangioscopy Interpretation When the North Meets the South. And the conclusion of this study is that in spite of all classification that we have already, The inter-observer agreement and accuracy rate for digital single operator cholangioscopy using visual criteria from both Monaco criteria and OR classification are similar. However, some criteria from both sets suffer from poor inter-observer agreement, thus affecting the overall diagnostic accuracy. And more formal training and refinements in visual criteria with additional validation are needed to improve diagnostic accuracy. Well, I think this conclusion is very important because this is the real situation that we have nowadays between experts, between people that perform a lot of cholangioscopy in a day-to-day. So we can perform misdiagnosis, overdiagnosis, or we can not diagnose, have a correct diagnosis in some cases. And this can have, this can lead to a bad treatment to a patient, with a patient. So this is very important because we need to improve the diagnosis of what we are doing with these advanced endoscopy techniques. So why we can use, or we need to use, artificial intelligence in advanced endoscopy? This is a little bit what happens between experts and non-experts. Not everybody is expert. The expertise require a lot of skills and a lot of practice and a lot of different kind of situations that some kind of people had inside in their training and also in as a person. And a lot of people as non-experts sometimes doesn't have these skills. However, artificial intelligence can shorten the difference between experts and non-experts physicians in diagnosis and probably in therapeutic, and could improve the quality and the inter-observer agreement between both experts and non-experts. This was a video that I showed in one presentation that I had in 2009 about the future, my vision of the future of endoscopy in 2009. So I was talking about artificial intelligence in 2009 when really nobody believed me too much. And I was talking about pattern recognition and vascular recognition and a lot of small things using the technology that was at that moment, like iScan or FICE or NBI. And this was just to show you how this was thinking at that moment. Now, in 2021, we have a lot of AI technologies in colonoscopy, for example. We have Discovery from Pentax Medical, GI Genius from Medtronic, and CAD-I from Fuji. So recognizing and detecting polyps. And this is a very nice advance for the future of endoscopy. And nowadays it's using in many endoscopy units around the world. This is an example of real-time computer-aided polyp detection using Discovery from Pentax Medical in live procedures. You can see here how Discovery was detecting a small polyp that initially was not observed during our colonoscopy. And this is not just for clinical, the clinical application is real, the polyp detection. But now, nowadays, we have more advanced real-time computer-aided polyp detection, not just polyp detection, also polyp characterization. So this is an image from a video from the CAD-I from Fuji. This is not just a computer, a computer-aided polyp detection. This is also can give us small maps. You can see where neovascularization is. So you can see the yellow areas, that this is hyperplastic areas, and this is neovascularization area. So this polyp is not just detected. It's also, well, it's a big polyp, but this can help us to perform a characterization of the lesion, and probably future clinical applications of this technology, this artificial intelligence, will not be just for polyp detection, also for characterization, but probably also can be used for evaluate complete resection evaluation. And this is something that we need to see in future studies, how this kind of technology can help us during the live procedures to see if all the lesion was resected. So what about artificial intelligence for advanced endoscopy in endoscopic ultrasound in cholangioscopy? So the first paper that I review in the literature was coming from 2015 when the European team from Spain and Germany and Romania, Craiova, led by Adrian Saftu, they start to use the computer system and computer-aided software to measure the in a quantitative way the contrast-enhanced harmonic endoscopic ultrasound for differential diagnosis of focal and pancreatic masses. So using some algorithms, they arrive to differentiate in a quantitative way the contrast captation of the lesions in a pancreatic mass using endoscopic ultrasound. So for me, this is the first paper, the first step using artificial intelligence to perform, to aid, to help the physicians to interpret, to do a good interpretation of the image that they were looking during endoscopic ultrasound using contrast enhanced. Recently, a team from South Korea showed a very interesting study using artificial intelligence versus comparing trainees and experts for the interpretation of subepithelial lesions. And they showed that artificial intelligence is superior for the interpretation of subepithelial lesions in the accuracy and in sensitivity when it's compared with trainees and experts. And this is a very good, interesting study, because it showed how artificial intelligence will help the physicians, even trainees and experts, to have better diagnosis and interpretation of the image in endoscopic ultrasound when they are using for some kind of lesions in the gastrointestinal tract. This is also a very good study, recently published. This was a study that coming from Japan, where they used artificial intelligence for detection of malignancy in intraductal papillary mucinous neoplasm of the pancreas. So the accuracy of AI was of 86%, and the AI really increases the diagnosis of for detection of malignancy of IPMN, having a very interesting impact in the detection of this kind of lesions when compared with human eye. It has been also used artificial intelligence for for the as a training tool for physicians. This study is coming from China, using a deep learning-based pancreas segmentation and station recognition system in endoscopic ultrasound. And what they showed is that when the trainees were not trained by the artificial intelligence, the learning curves take more time to have a good interpretation of the image and a good evaluation of the pancreas when compared with those trainees that were under training by the artificial intelligence. So this showed also that the artificial intelligence could be used also for training proposed. Recently also, there are some studies published using artificial intelligence for the diagnosis of biliary structures using cholangioscopy. This is a pilot study from Portugal using just image and no videos, but the image. And this showed that the performance was very high, very good, with an accuracy in around 80 to 90%, in the characterization of malignancy with artificial intelligence. This study is coming, it's a multi-center study led by my good friend Mowen Kashab, and it's an international study, a multi-center study with more than 1 million images from more than 500 patients. And they showed that the sensitivity of artificial intelligence for detection of malignant structures was 81%, with very good specificity and very good positive predictive value and good negative predictive value. And however, this is has been just training an image, and until now, no more data we have with this, so not real time with this artificial intelligence developed by Johns Hopkins. We don't have more results from them, but the results are very interesting. So I will show a little bit what we have from Ecuador regarding AI for EUS and cholangioscopy. So together with the company MD Camps Group, we developed 2 artificial intelligence models for advanced endoscopy. One for endoscopic ultrasound, that is for real-time anatomical recognition during endoscopic ultrasound. The first pilot study showed a very good result with more than 90% of accuracy of the training models and in real time, not just in image and videos and in real time. And in cholangioscopy, we have a very good result also. So I will show a little bit the result. The first cohort that we had more than 100,000 samples. And this is how we performed the AI training in 5 layers, and how we develop the training not from image. We take it the training from real videos from the patients from our unit. For US, were performance from radial and linear. And this is an example of a video, of a real video. So this is the first model that we had 2 years ago. And you can see how the AI was detecting the areas, the anatomic structures. And the idea of this development is to have a model to have how to self-training and for the fellows, and to have also a good measure of how the training is going with people in endoscopic ultrasound. Then we had a second generation with improvement also, now we are going faster. You can see here the model not just showing the accuracy and, how exactly is accuracy that the computer is, but it's also taking the pictures of what you have. So if you have, a bad image, the computer will see you, will show you that you are not having a good image, and will help you to have a very good, a better image, quality of image. So now this is from the gastric window. You can see here the liver, and this is the results that we had. You can see how we have 28 organs trained, and how the road detection frames has been reducing with the time. And you can see here in your right all the structures that were trained, and how how has been right and the wrong structure detected by the system. And this is the observer agreement. The total observer agreement is around 99% in all the cases, with a sensitivity of 88%, 86%, and around 75 or 76%, and some organs that has been improved recently, including more and more organs and image, and also the predictive value is very high. So the training model is almost perfect now. This is an example of cholangioscopy. So the artificial intelligence is showing all the suspected areas, and we have now not just the first data of the results, the pilot study, but we have also the results of multi-center study together with Michelle and Belgian, Dr. Ratislav Kunda, that helped us with this study, and I will show the results. But in the same way, it's taking the pictures and showing you where are the lesions. And now we are conducting a new study to see if AI can help us to target the biopsies and diminish the difference between the biopsies and the visual diagnosis interpretation. So this is the first result of our study, of the pilot study. And we compare with oral classification and the neovasculatory criteria published in 2020 and the Mendoza consensus in 2021. And the results, the initial results were that artificial intelligence is similar to human eye to recognize malignant structures. And our second study, that was a multi-center study with 170 videos from different centers, 4 different centers. We had 58 lesions with suspicion of tumor, 46 with indeterminate stenosis, 31 with indeterminate dilation, and 35 with a filling defect, and the structures were located from the common bile duct in 48 cases, hilum 48, common hepatic duct 70 cases, and intrahepatic duct 4 cases, with an equal distribution among neoplastic and non-neoplastic to the individual single operator cholangioscopy diagnosis. The most prevalent biopsy diagnosis was inflammatory, 69, followed by cholangiocarcinoma in 39%. The AI software, the artificial intelligence software, achieved significant accuracy values for neoplastic diagnosis with a 90% of sensitivity, 60% of specificity, 70% of positive predictive value, and 85% of negative predictive value. The results of our study was the AI software accuracy was comparably and even statistically higher than endoscopy expert. And when we increased the study with non-experts, we saw that 25% of the experts can have misdiagnosis, and AI was superior in 25% of experts and in 50% of non-experts. So this is an example of real-time detection with AI in cholangioscopy. So this is a case that was negative biopsy in the first attempt, made it in another center. I'm sorry for taking a little time, the video. So this was a case that we do a live transmission to Chile. So you can see here the detection of the AI of the suspected areas, and the biopsies of the target areas from the AI, as you can see here. You see coming positive during the live demonstration, showing the interesting of AI in advanced endoscopy. So what is the limitation? So most of AI models, including GIs, used to be trained and even validated mainly or only with confirmed disease samples as a gold standard positive. Instead, a one-to-one relationship among disease versus normal or neoplastic versus non-neoplastic cases. Using more confirmed disease samples implies a risk of less false positives, and doing a real-world use, it can correspond to an over-diagnosis. What will be the future of artificial intelligence? And this is that I told the third generation. So in the future, we will have all around with real-time visualization with AI. So we can include in the future cognitive AI. When I'm talking cognitive AI, it's talking about putting a brain inside the machine, because when we are doing a procedure, as a physician, when we are performing a procedure, we are not just using our visual or eyes to perform a detection. We use our brain and use the clinical characteristics of the patient. So the combination of this will be very interesting to see what happened with this. So the lesion detection by US and mixed AI will be also very interesting to see in the future. The characterization of for US and mixed AI also is really promising technique. And the hologram with virtual augmented reality AI and 3D reconstruction will help the physicians in the future to do, therapeutic procedures with less adverse events, probably, and help the training, for trainees to perform in an easier way therapeutic procedures. So this is how we can see the future of AI using glasses and AI technology combined. And I would like to say thank you for the invitation, and I would like to invite you for the next online live endoscopy course that will be in August 2023. For more information, it's in pentacenter.com. Please join us. More than 70 countries and more than 5,000 physicians together with very nice procedures this year. We have Amy, and we had Michelle, and we had Dr. Carames, and a great panel of international experts doing live procedures with us. So thank you so much for this invitation and for listening to me. Thank you.
Well, hello, everybody, and thank you, Dr. Robles, for that fantastic lecture, and for the entire morning group of lectures. Thank you to all of our speakers. These have been really fantastic. We're going to transition to our Q&A session here, and I just want to remind the audience, everyone that's screening out there, that they can actually chat, put in some questions on the chat box, and we can transmit that to the speakers, and for all the speakers, just to turn on your cameras. We'll kick off this Q&A session. I'll ask Dr. Robles a question here. So the lecture was amazing and very interesting about where this field is potentially going with AI and how it could potentially help us. I think that we've had some lectures already this conference regarding indeterminate strictures in the bowel. This is one of the most difficult areas that we deal with as advanced endoscopists, and it's not only recognizing the lesion, but also obtaining tissue, as you spoke about. And so these cholangioscopy studies are starting to come out here. And my question is, there have been multiple technologies that have come out in the bile, like confocal, volumetric laser, cholangioscopy. Many of them have failed even because of the lack of inter-observer agreements. We're not able to reproduce them reliably to make decisions or obtain tissue. Can we get to a point where not only are we able to diagnose or see something with a high sensitivity and specificity, but to the point that we don't even need necessarily to get tissue? Because even if we could see something cholangioscopically and we want to target that area for biopsies, our biopsies are still the technology. That's the second hump, is to obtain tissue. So obtaining a virtual biopsy through AI for something like an indeterminate stricture would be like a holy grail. Do you think there's a platform or a pathway to that, and is it 5 years, 10 years, 20 years away for something to this extent?
So, Prashant, I don't think that Carlos is on, but I'm happy to tackle that question. So I think similar questions have been raised about non-tissue-based measures of assessing indeterminate biliary strictures. So, for example, volumetric laser endomicroscopy, confocal endomicroscopy, these are all imaging modalities that we can clue us in on potential areas to target, but we're not actually getting a tissue diagnosis. For me, when thinking about it from a global perspective of the patient, if I have a high suspicion that that indeterminate biliary stricture is malignant, do I think that a oncologist or one of my surgeons is going to, change their practice management with chemotherapy or surgery just based on a imaging finding that's non-tissue based? And historically, we've seen with confocal and with VLE that has not been the case. So I'm not sure that necessarily AI will move the pendulum unless the data swings very significantly. I will also highlight, I think this is available online just within the last couple of days in GIE, is that the Mayo Group, I think Neil Mario was the first author, they actually looked at using AI for malignant biliary strictures using cholangioscopy and what's called a CNN, which is a convolutional neural network. And the question that they wanted to assess was this AI capable of accurate stricture classification and sort of real-time examination just based solely on looking at cholangioscopy images. So they had over 150 patients, and I think their final database of images was well over 2 million. I think it was closer to 2.5 million still images. And the AI was actually able to have good performance in terms of mimicking expert annotations of these images. And it had really good accuracy as well. They can also generate heat map analysis, looking at malignant biliary strictures, to sort of clue you in where a targeted biopsy may be more helpful. So for example, areas where there's frond-like mucosa or these papillary projections that we all see, on cholangioscopy. So I'm not sure that right now, certainly in today's day and age, that it's going to have a big impact because of the lack of tissue sampling. But I think down the road, it will make us more accurate with where to take biopsies, potentially increase our overall sensitivity and specificity with tissue sampling. And remains to be seen whether treatment paradigms will shift in the absence of a tissue diagnosis, just purely based on images or videos.
Question. And so, Dr. Bapaye, we have a question for you. In terms of doing the POEM-F and entering the peritoneum, when you're performing this and working in the peritoneal space, how are you managing CO2 insufflation? Are you prophylactically placing a Veress needle, or how are you managing air dynamics in that space?
Right. So thanks, Prashant, and excellent question, actually. So we start off by getting into the peritoneal cavity, and we do not put in a Veress needle at that point in time. And however, because we need that distension and the peritoneal distension so as to be able to visualize the fundus clearly and apply the endoloop and the clips. But at some point in between, when the distension is optimal, kind of, and the bowel loops are falling away, we will put in a needle so that we can monitor the capillary peritoneum and we can maintain it at a particular level. So it's not that we start off with a Veress needle in the first place, but yes, we do put in a needle sometime during the course of the interperitoneal part of the procedure. So we do that.
Well, good. Good to see you again. We have a question from the audience. First off, beautiful demonstration of POEM-F. You're really on the forefront, and I know you've traveled the world teaching your technique. Is there any concern about retained foreign body in the peritoneal cavity?
Well, the endoloops that we're using are proline loops, which are nylon and proline loops, which are standard suture material. So they are going to form a granuloma, and it's the same thing with the clips. Inouye's also developed a technique where they're using sutures and pledgets. So I think that also is going to form granuloma. So finally, we're looking at an interperitoneal granuloma and adhesion formation. And, these are all inert materials, so we're not really worried about that. Of course, we need to ensure that with the clips that we're using are MRI compatible, because at some point in time in future, if the patient needs an MRI, we don't want these clips to be a hindrance to performing an MRI, but that's about it.
Fantastic. Dr. Iyer, I have a question for you. In general, I know the fantastic lecture, by the way, on these technologies. How do you have a mental algorithm for when you approach patients with Barrett's? When are you choosing one technology over another? Is cryo really your first line, or how do you choose on these?
Thank you, Prashant. It's a pleasure to be on, and nice to see some friends on here. I think when we approach a patient who has, say, long segment Barrett's with, let's say, high-grade dysplasia, in my mind, there are several things that go into what ablation modality one would choose. So obviously, the first step is to look for any visible abnormalities, resect them, and then consider ablation only after you are assured that the segment is flat. Then, in my mind, one of the major factors I look for is the strength of the evidence, right? So radiofrequency ablation is the only modality which has level 1 evidence at this point. PDT used to, but PDT is not not used anymore. So I think that is number one. The other maybe somewhat softer variables that I also tend to use are the length of the segment. So obviously, currently with cryoballoon, we really don't have a longer balloon which can treat larger segments. We are only treating with focal segments. So I think the challenge with treating longer segments is more with cryoballoon, even though we know that it works. If you look at the Coldplay 3 trial and some of the earlier trials, the maximum segment length there was 6 centimeters, not beyond that. So obviously, if you have something beyond that or even close to it, then I think it's just more efficient. The third thing I consider is the pathology. So, for instance, if someone has a cancer and perhaps it's an M3 cancer, and by that I mean it might be into the muscularis mucosa or maybe even into the superficial submucosa, and if that patient wishes to proceed with endoscopic therapy after discussing risks and benefits, then I think one advantage with cryo in that instance is that the depth of treatment is a little bit more deeper than with radiofrequency ablation. And then pain, I think, is another issue that we think about. There are some patients who are just extremely pain intolerant or may have more pain after procedures. Can you hear me?
Yes, we can hear you. You're doing great. Thank you.
Yeah. So I think those are some of the softer things that I will factor in as well.
That's really a great summary of your thought process. Thank you for sharing that with us. While we have you here, you were one of the authors on the updated ACG guidelines for Barrett's esophagus. So I'm sure that the audience is very curious about what are your biggest takeaways that you can advise from that document. And for those that are watching online, the guidelines were published in the Red Journal on Barrett's esophagus, and Dr. Iyer is one of the authors. So we'd love to hear some of your biggest takeaways from these updated guidelines.
Thank you, Nikhil. Yeah, I think we can certainly highlight a few things. So if we just go down the screening, surveillance, and treatment sort of section. So I think the biggest development in screening is the support for the non-endoscopic detection technologies. And I think that is likely to hopefully become clinical reality in the near future, in my mind. As you know, a lot of work is being done in the United Kingdom by Dr. Fitzgerald, and also in the United States by our group at Mayo, as well as Dr. Chak's group at Case Western. And a series of trials have been published and are actually in process. So I think those are, I suspect that is something that will become reality in the next few years, but certainly the evidence seems to suggest that. So I think that's number one. From a, go ahead, did you have a question?
Yeah, if I can ask to that point, do you see its utilization in GI offices or primary care practice offices?
Yeah. Again, this is my personal opinion. I honestly think that these technologies are probably going to be more applicable in the primary care office. Because typically once patients come to see a gastroenterologist, they have some indication for an endoscopy. So I think this is probably best implemented in my mind at a primary care level, which opens a whole other set of challenges. But I think that's where, at least that's just my thought. Moving on to surveillance, I think this is the first time we have endorsed a differential between long segment Barrett surveillance versus short segment Barrett surveillance. I think there's fair amount of evidence now to suggest that as long as you have a good baseline exam with no dysplasia, then if you have short segment Barrett's, meaning 1 to 2 centimeters, you could survey at 5 years. Whereas if you have long segment Barrett's, 3 or more, you could survey at 3 years. So I think that's a second big change that we have made. I think in terms of surveillance, we continue to endorse basic things, doing a quality exam. There's more emphasis on quality this time around, washing and cleaning the Barrett segment, making sure you use high resolution white light endoscopy, narrowband imaging, do your biopsies, look carefully. I think that's there. And then from a treatment standpoint, I think there is more support now for resection techniques like ESD. I think compared to EMR, I think EMR and RFA or EMR and ablation are great, but there might be certain instances, larger lesions, scarring, suspicion for submucosal invasion, where we might be better off using ESD. So I think that's sort of the highlights in my mind.
Thank you for that. That's very important because these are things we're doing every day, right? We don't have to be advanced endoscopists to learn new things. This is really the bread and butter of general GI, and it's important that we're doing the basic things right and improving our strategy. So thank you for that update on those recent guidelines. Nikhil, there's a question from the audience for you. So it's interesting that AI can level the playing field in polyp detection for low detectors and high detectors. Do you think that for high detectors, will the increase or marginal increase in polyp detection reduce the rate of interval colon cancers?
That's a really great question, Prashant. So that question does come up pretty frequently with AI talk, particularly with colon polyps. Are you detecting more just smaller polyps, and that's increasing your adeno detection rate? But what I actually will highlight is older data that we've had for quite some time, which is published in the New England Journal in 2014, that for every 1% increase in adenoma detection rate, that actually is associated with a 3% decrease in the risk of cancer. You have to remember that the adenoma detection rate is inversely associated with the risks of interval colon cancer, with advanced stage interval cancer, and with fatal interval cancer. So I think the general goal is to increase our ADR, and I think that AI will help augment that. And you can surmise that with every increase percentage-wise of ADR, we're also having an appropriate 3% decrease in the risk of cancer. So it is certainly an area that I think will be quite helpful. There also was a study that that showed that we are increasing our detection of particularly vulnerable lesions, such as the sessile serrated ones. These are ones, those of us that do screening colonoscopy, those are the lesions that we worry about. They're usually in the right colon, oftentimes very flat. We'll have a adherent bit of a mucosal cap of stool or mucosa that's adherent, but these are difficult lesions to detect. And I think AI in particular will be helpful for those more troublesome lesions that we can identify and remove.
Fantastic. There's a question from the audience for Dr. Amol. What is your impression on the endoscopic approach to acute appendicitis management?
Sorry, yeah. Well, it's something very exciting and interesting. There are two methods that have been discussed in the last couple of decades, I would say. One is the colonoscopy guided, retrieval of a fecalith, which came in as a video some time ago, and that was discussed. That's an attractive technique as well. And of course, we know the age-old Notes technique of performing an appendectomy, also which Dr. G.V. Rao had mentioned, and the team from Asian Institute of Gastroenterology, they'd done it way back nearly a couple of decades ago. So I think these procedures are definitely feasible, but we need to have larger studies, and possibly we need to define these patients really properly, because I don't think they're going to completely replace or that kind of a thing where we can have laparoscopic we can do these procedures endoscopically regularly, because I still believe that laparoscopy, the advantage that laparoscopy has of triangulation and the having several instruments inside and retraction and all these things are still not easily available through the endoscopy channels. But I think it's a step in that direction, and they're definitely opening up options of doing transperitoneal endoscopy in some way or the other. That's how it is. Yes, sir.
Absolutely. I think the notes spectrum has reopened in the last 5 to 10 years, and where it's going now is extremely exciting. But we have to be very cautious about the steps we're taking in that direction, because you're right, the degrees of freedom and ranges of motion that are achievable and laparoscopically do not necessarily match what we're able to achieve yet endoscopically, but that technology is starting to converge over time, so we'll see where things go. Nikhil, one other question for you from the audience here. Can you retrospectively review a video colonoscopy with AI for polyp detection?
Yes, you can. So you can take the video and then utilize the AI to retrospectively go back and see if there's been any lesions that you may have missed. But obviously, in the coming years, we're seeing more of an expansion now with GI Genius and Vision that are FDA approved in the States. It's really going to be helpful more in the in the prospective setting, so that we can increase our ADR and our adenomas per colonoscopy. See if we have any other last minute questions in the chat. I think all of the questions have been answered. We're coming up on 11:15, so certainly want to thank all of our speakers this morning, Drs. Komanduri, Iyer, Papaye, Robles. Thank you, Dr. Iyer, Dr. Papaye, for joining us for this live Q&A session. Really appreciate your insights and your knowledge. And Prashant, if you have any last words, we'll then send it back over to Amy and endoscopy for an update on the schedule.
You're very humble not to thank yourself, but thank you, Nikhil, for the lecture as well. So fantastic panel. Everybody's great, and looking forward to these cases.
Thank you so much.
Unfortunately, we had some technical issues with the water main break at the hospital this morning that prevented us from doing cases here in the endoscopy unit. So I want to thank all of our faculty for stepping in and presenting such excellent video case presentations and discussion, as well as our excellent lectures and Q&A session. We are going to change the schedule just slightly and go right into the next set of lectures right now. And then we'll hope to see you back here later this afternoon for some live cases at that time. Thanks so much.
Thanks for the opportunity to participate in this very important meeting. My topic is third space endoscopy, the rise of endoscopic surgery. I have no conflict of interest to disclose. Introduction third space endoscopy. This will be the script of our presentation. The topic is first space endoscopy, second space endoscopy, notes, and finally, third space endoscopy and different techniques. First space endoscopy, therapy on the luminal surface of the digestive tract, also called first space, had a significant milestone in the 2000 years. The development of submucosal dissection, ESD, allowed monoblock resection of large lesions and curative resections of early neoplasm. Nature orificial transluminal endoscopic surgery. Notes: receives significant attention and researchers protocol the access to the peritoneal space, the second space, through endoscopy and without scars, were the main reason for the growing interest. Due to laparoscopic surgery being already well established, less invasive, safe, and with a small external scar, nodes had limited clinical application. Nevertheless, nodes provide the fundamental concept necessary to develop the intramural surgery. Sumiyama and colleagues were the first to describe submucosal endoscopy with mucosal flap safety valve in 2007. They showed technical feasibility and safety in live pig study. In a study published in 2010, Inoue published the results of peroral endoscopic myotomy for achalasia in human performed from 2008 to 2009. This was a revolution in the development of endoscopic surgery because the muscularis propria was considered a border where the endoscopist should not intervene, given the risk of perforation. With the development of the submucosal tunnelite technique, this limit ceased to exist. In all cases, point significantly reduce the dysphagia symptoms score and at the resting lower esophageal sphincter pressure. There are 4 steps in the notes: entry to submucosal space, submucosal tunneling, endoscopic myotomy, and closure of mucosal entry. Gastroesophageal reflux remain a point to be improved in the technique, with incidence range from 10 to 70%. Inoue and colleagues in 2019 reported the point plus fundoplication technique. After complete the point myotomy, the endoscopy was advanced from the submucosal tunnel into the peritoneal cavity. A partial mechanical barrier is created by retracting the anterior gastric wall at the esophageal gastric junction with the use of endoclips and envelope. Inoue published 21 patients treated in 51 minutes. Number of patients analyzed, 15. Median follow-up, 3 months. About the GERD symptoms, mean Ecker score is 1. Gastric finds wrap in place in 100%, and the misery score is 7 in 15 patients, less than 3.1%. It's a very good result. In this video, it's possible to see the technique. This video is a courtesy for Dr. Amol Bapai. Now put the endoclip. It's a being fitted to secure to the final wrap. And analyze the results and close it with clips. Z-point, Zenker's diverticulum. Acknowledgement of submucosal tunneling allowed a more accurate approach to the septum of esophageal diverticulum. This cutting-edge technique obviates direct dissection of the septum and instead involved dissecting a submucosal tunnel around the septum to achieve a complete myotomy. First human Z-point was described by Lee in 2016 with a very good result. Zhang in 2022 described that the clinical success for Z-point was significantly better than conventional technique, the flexible endoscopic surgery. The treatment of middle esophageal and epiphrenic diverticulum, the D-point diverticulum per oral endoscopic myotomy, follow the same principle with the advantage that it is possible to extend the myotomy as long as necessary for the treatment of spastic disorders frequently present in these cases. Mo in 2016 described the first human G-point. The patient's conditions improve remarkable within short time of recovery. In this video, the author, Leopold and Kim, demonstrate the step-by-step of the G-point technique, introduce the endoscopy, identify the diverticulum in the area corresponding to the septum, incision to the mucosa after injecting physiological solution, and dissection until identify the muscle. When identify the muscle, start for the myotomy, the septum, until the Z-line. It's a very interesting procedure. After the procedure, it's possible to close the orifice by suturing. G-point, gastric per oral endoscopic myotomy. Gastroparesis is a common clinical problem characterized by delayed gastric emptying. Although surgical pyloroplasty has good result, it has its own issues of surgical morbidity and mortality. The same principle is obtained by the third space endoscopy with the dissection of the pyloric musculature under direct vision and preserve the other layers of the digestive tract. Kawai in 2012 described the G-point technique in animal lab. In the same year, the technique was also described by Chaves, and the first human case was reported by Kashabi in 2013 and Chaves in 2014. G-point has been shown to be effective, safe, minimally invasive, and shows promising results in studies. This procedure should be in the arsenal of the treatment option for refractory gastroparesis. Endoscopic tunneli stricturotomy. Gastric sleeve stenosis complications occur 0.1 to 3.9% of cases after sleeve gastrectomy and can result in significant symptoms. The endoscopic tunneli stricturotomy was first reported in 2018 and allowed the stapler line to be targeted for myotomy, relieving the tortuosity seen in a helical sleeve stenosis. In this video, we demonstrate the evolution of this technique, include full thickness dissection with staple line disruption, endoscopic tunneli stricturotomy with full thickness dissection. The patient underwent 3 endoscopic pneumatic balloon dilation in an attempt to treat the stenosis. Unfortunately, her symptoms did not improve. After failed the pneumatic balloon dilation treatment and endoscopic tunnelized structurotomy with full thickness dissection was performed. The procedure is performed in 6 steps. Identification of the stenosis, submucosal injection 3 or 5 centimeters before the stenosis, incision, submucosa tunneli, structurotomy with full thickness dissection, and mucosal closure. During follow-up, the patient maintained a 1,200 calorie diet without recurrence of symptoms. This technique is feasible and appears to be safe and effective in the management of stenosis after sleeve gastrectomy. This procedure may be an option after conventional treatment failure or may be considered as a primary alternative. In this video, it's possible to analyze pre and post aspect after the procedure. Thompson, in 2022, described the gastroplasty with endoscopic myotomy, GEN procedure, represent a novel endoscopic bariatric metabolic therapeutic that addresses several aspects of gastric motility to delay empty and induce durable weight loss. The procedure consists of 3 steps: pylorus sparing enteromyotomy via a submucosal tunneling technique to weaken the enteral pump and impede emptying, running suture at the level of the incisura to separate the enterum from the gastric body and to minimize tension of the myotomy access site closure, and a standard ESG in the gastric body to reduce mixing and limit accommodation. Perrectal endoscopic myotomy. In 2016, Bapai and his group described this technique for the treatment of Hirschsprung disease. The rationale of this is to disrupt the spastic bowel segment, like those in achalasia or pylorospasms. After a mucosal incision is made inside the dentate line, a 10 centimeter submucosal tunnel is created. Full thickness posterior myotomy is performed, stopping short of the anorectal junction. The mucosa is closed, use endocline. Bapai and colleagues published the case series with PRAN and conclude that it is a safe and effective minimally invasive procedure to treatment the Hirschsprung and results in long-term response. Laparoscopic endoscopic cooperative surgery was first reported by Heike in 2008 and emerged in the treatment of submucosal tumor by the concept of keeping an oncological enough distance from the tumor with minimizing resected organ. The technique was developed and involved a collaborative surgery and treatment of malignant tumors can be performed. There are many different techniques for this. The endoscopic full thickness resection has been performed for curative resection of early gastric cancer. And there are other variations. It's a non-exposure technique, such as noose and clean net. In this video, it's possible to identify for the lesion and the gastric image and outside the gastric wall. In this situation, after dissection for the tumor, it's possible to identify the adequate place to put the stapler, and you prevent the big resection and the stenosis in the subcardia area. There are different LEX techniques for resection, benign tumors and malignant tumors. When you analyze for different technique and the full thickness resection and submucosal tunneli, it's very important you discussion if one technique is better than other. Kahali published a recent paper and conclude and the STAIR, endoscopic full thickness resection and laparoscopic assisted resection are efficacious approach for resecting for subepithelial tumors with similar R0 resection rate, complication rate, and adverse event rates. Laparoscopic assisted resection appear more time consuming and is associated with a longer hospital stay. The same happens when you compare the technique of submucosal tunneli endoscopic resection versus endoscopic submucosal excavation. In conclusion, treatment of gastrointestinal disorders continue to advance and indication of third space endoscopic procedures are rapidly growing. We have entered into the area of incisionless surgery, the technology advances, and we get smart endoscopes and accessories that can dissect, cut, cauterize, and suture tissues. The future you'll be driven by the imagination of the endoscopy. Thank you very much.
Hi, I'm Avik Sarkar, and I'll be discussing resection of non-lifting benign colonic lesions. We'll start the discussion by talking about endoscopic mucosal resection for colonic polyps. We'll also discuss scarred colonic polyps and why scarring makes resection challenging. We'll touch base on different treatment modalities to resect these types of lesions, and we'll discuss a new innovation, endorotor endoscopic powered resection. And finally, we'll also have some videos demonstrating some of the techniques. Endoscopic mucosal resection is a well-established, safe, and effective technique for removal of colonic polyps. Complete removal is usually achieved, but the reported rates of residual polyps are anywhere from 10 to 32%, with higher residual rates seen in larger polyps. Up to 27% of interval cancers are due to incompletely resected lesions. Residual rates are significantly higher in non-lifting polyps, and traditionally these non-lifting areas were treated with an ablative modality, most commonly APC, and several studies have shown that APC use has consistently been identified as a risk factor for adenoma recurrence after EMR. There are several causes of non-lifting polyps: previous extensive biopsy of flat polyps, tattoo injection into the base of a polyp, failed prior resection attempts, polyp location, with rectal polyps being more prone to submucosal fibrosis from defecatory forces, inflammatory bowel disease due to the chronic inflammation of the colon leading to submucosal fibrosis, and lastly, malignant submucosal infiltration. Scarring can make resection of a polyp very challenging. Scarred lesions usually are due to submucosal fibrosis, and these lesions are often flat. One of the mainstays of endoscopic mucosal resection is being able to lift the submucosal layer off of the muscularis propria. And in scarred lesions, the fibrosis prevents the separation of layers and lifting of the lesion. This makes the lesion difficult to grasp and resect with a snare, and it also makes standard techniques risky because it can lead to incomplete resection as well as bowel perforation. Incomplete resection is not something to be taken lightly. 20 to 30% of interval colorectal cancer cases are attributable to incomplete resection of colon polyps. For piecemeal EMR, guidelines recommend surveillance colonoscopy at 6 months. In one particular study that looked at surveillance of post-EMR sites, about 12% of patients had residual adenomatous tissue on their first surveillance colonoscopy. 91% of this adenomatous tissue was visibly abnormal at the prior EMR site, but interestingly, 9% had biopsy of an apparently normal scar that did return with adenomatous tissue. There are currently several treatment modalities available to manage non-lifting scarred polyps. We will discuss these in detail, which includes endoscopic full-thickness resection, hot avulsion technique, underwater endoscopic mucosal resection, endoscopic submucosal dissection, and the endorotor resection device. The first technique we'll talk about is the endoscopic full-thickness resection device. This is a single-use over-the-scope device used to remove refractory colorectal lesions 2 to 3 centimeters in size. The device has a transparent cap with a 12.3 millimeter over-the-scope clip mounted onto a standard colonoscope. There's a monofilament polypectomy snare that's preloaded into the tip of the cap. A grasping forceps is advanced through the working channel of the colonoscope to grasp the lesion. The lesion is then retracted into the cap until the lateral margins are visible in the cap. The over-the-scope clip is then deployed, the snare is closed, and then resection is completed with monopolar current. The efficacy of the full-thickness resection device was evaluated in a multi-center prospective non-randomized study. The study had 181 lesions, but there was a subgroup analysis of 104 non-lifting adenomas, 72 of which had prior manipulation and 32 did not have prior manipulation. The target lesion was reached in 100% of cases, and the R0 resection rate in this group was 78%. 3-month follow-up colonoscopy showed residual neoplastic tissue in about 15% of patients. The safety of the device was also studied. Major adverse events included major bleeding, which occurred in up to 3% of patients, immediate perforation, which was also in about 3% of patients, and delayed perforation, which was also in about 3% of patients. Acute appendicitis and enterocolonic fistula has also been reported. The rate of surgery after an adverse event with the full-thickness resection device ranges from 0 to 11%. There are minor adverse events, which include minor bleeding and post-polypectomy syndrome. And there also have been reports of technical device malfunction, including the inability to close the snare and snare rupture. The next technique we'll talk about is hot avulsion technique. In this procedure, a hot biopsy forceps is used. It's a little bit different than hot biopsy polypectomy in that hot biopsy polypectomy uses a forced coagulation current, and there is high risk involved with that, including bleeding and perforation risk. The hot avulsion technique, although it does use a hot biopsy forceps, uses endocut rather than forced coagulation, which has mostly a cut energy and very little coagulation. And this is found to be more effective with less risk and less complication. Typically with this technique, we use endocut I with an effect of 2 or 3, and we use a tapping technique with tapping of the yellow pedal and each tap lasting approximately 1 second. This is a video of the hot avulsion technique. You can see here we have resected a polyp, and we've now encountered some scarring in the center of the polyp, likely at a site of prior biopsy from the initial colonoscopy. The snare was not able to resect this area as the snare was slipping over the area, so hot avulsion technique was used. And you can see here that the hot biopsy forceps are being used to grab the remaining adenomatous tissue. The biopsy forceps is closed, and then the tissue is lifted up and tented up away from the muscularis propria. And then you'll see some small taps of the endocut being performed and some tension being placed to mechanically avulse the tissue away from the underlying fibrosis. The efficacy of hot avulsion technique was evaluated in a 20-patient study of non-lifting polyps. The polyps were non-lifting in 55% of the patients due to previous EMR attempts and in 35% of patients from previous biopsy attempts. Macroscopic adenomatous tissue was removed in 100% of patients. On follow-up exam, 85% had no macroscopic or microscopic neoplasia that was seen, and 15% had a small area of residual adenomatous tissue that was noted that was easily treated with repeat hot avulsion. Another study evaluated hot avulsion versus APC in piecemeal EMR. 63 lesions were treated by piecemeal EMR with adjunctive APC ablation of visible residual neoplasia. The recurrence rate in this group was 60%. 46 lesions were treated by piecemeal EMR with adjunctive avulsion to remove visible neoplastic tissue. The recurrence rate in this group was only 10%. The safety of hot avulsion was also studied in this study of 212 polyps. The majority of the polyps were located in the right colon. About 12% of patients required hemoclips to control intraprocedural bleeding. 6% were admitted for observation post-procedure, and 3% of patients experienced post-polypectomy bleeding. There were no delayed perforations. The next technique we'll talk about is underwater endoscopic mucosal resection. This is a procedure which involves snare resection of a lesion without submucosal injection after suctioning the gas in the colonic lumen and infusing sterile water or normal saline. This technique works because, as has been evaluated with colonic endosonography, the mucosa and submucosa float away from the deeper muscle layer when infused with water, while the colonic muscularis propria remains circular with adequate distance to the lesion. There was a study that involved 58 patients who underwent EMR of a polyp with a prior resection attempt using underwater EMR. The mean polyp size was 20 millimeters. 72% of the polyps were in the right colon. 43% of the polyps were removed en bloc, and an additional 43% were removed piecemeal using the snare alone, but fully resected. One patient had residual adenoma on follow-up colonoscopy, and one patient developed delayed bleeding. Endoscopic submucosal dissection is another technique for non-lifting colonic polyps. It is challenging because, as was discussed, it is difficult to create an adequate submucosal cushion with an injection, but different ESD techniques can be utilized as a salvage therapy for endoscopic removal of these non-lifting lesions. In a single-center prospective study of 30 patients with residual colorectal lesions after an attempted EMR, technical success of salvage ESD was 100%, with an 83% R0 resection. In 3 patients with an R1 margin, one decided to go to surgery, and another 2 had another attempt at salvage ESD, which achieved R0 results. 2 patients with RX margins because of electrocardiography artifact had no endoscopic or histopathologic evidence of residual disease during a follow-up colonoscopy. At 6-month follow-up of 29 out of the 30 patients, there was no evidence of residual or recurrent disease. The reported rates of perforation with salvage ESD for refractory colorectal lesions have ranged from 0 to 9%. The last treatment modality we'll discuss in detail involves the endorotor resection device. This is an adjunct therapy for non-thermal resection of residual lesion tissue. It uses adjustable suction and a rotary cutting blade to precisely resect mucosal and submucosal tissue. There's a low adverse event rate. It's effective for non-lifting lesions with an 84% curative rate. A benefit of this device is that it allows for capturing histologic specimen, and it does not hinder further endoscopic intervention. There's also a fast learning curve with the device. In preparation to resect a non-lifting lesion with the endorotor device, the lesion is typically injected submucosally with the blue dye solution and diluted epinephrine solution. The purpose of this injection is to limit any mucosal oozing or bleeding that may occur with the usage of the device. The vacuum setting is also adjustable on the device with a recommended start range between 50 to 300 millimeters of mercury, with higher suction commonly used during resection of significantly scarred lesions. The resected tissue is suctioned through the catheter and collected into a tissue trap. Here you see several pictures of the catheter, the device, as well as the tissue trap and the specimen that's obtained. In the top middle here you see the catheter, and you see a solid black line that's going down the center of the catheter. That indicates that the cutting blade is 180 degrees opposite that black line, and it helps you line up your orientation to complete the resection. On the bottom left here, you see the tissue that's collected in the trap, and in the bottom middle here, you see the trap that's used for the device. The efficacy and safety of the endorotor for scarred colonic polyps was conducted in a 19-patient study. The overall rate of complete resection was 84%. There was no perforations, no delayed bleeding, and no significant post-procedural adverse events. 2 patients did experience intraprocedural bleeding that was successfully managed endoscopically. Another 28 lesion study was conducted looking at the efficacy and safety of the endorotor for scarred colonic polyps. 25 of the 28 were previously resected. The technical success of the procedure was 100%. The clinical success was 15 out of the 17 patients that followed up for their 6-month colonoscopy had no evidence of residual adenomatous tissue. 4 patients did have intraprocedural bleeding that were treated with epinephrine and monopolar forceps. 2 patients had delayed bleeding. In the final few slides, I'll go over some videos of cases I've done with the endorotor device for scarred colonic lesions. This is a case of a patient who has ulcerative pancreatitis for the last 20 years and has been stable for the last few years on 6-MP and 5-ASA. There's no history of biologics for this patient. The patient gets frequent colonoscopies and recently had a colonoscopy by her IBD specialist and was found to have a 40 millimeter adenomatous appearing polyp in the ascending colon, Paris class 2A. As you can see from the video, most of the lesion was able to be resected with a snare, but there's a center portion of the lesion that did not lift and could not be resected with a snare. So here you see the endorotor device being used, And you can see that the blade is able to catch the tissue and kind of pull it into the blade, resecting it, cutting it, and using the suction to capture it into the tissue trap. You saw that the base of the resection was clean with no further adenomatous tissue remaining. There was some minor oozing and minor bleeding noted, and so coag grasper forceps were used to cauterize visible vessels. And then lastly, hemoclips were used to close the EMR site successfully. The patient did well post-procedure and had no issues post-procedure. The specimen returned as a tubular adenoma, and the patient is scheduled to have a follow-up colonoscopy in six months. This next video is of a patient who had a colonoscopy 1 year prior and had a 25 millimeter rectal polyp, which by report was cauterized and removed in pieces. The patient subsequently had a follow-up sigmoidoscopy 3 months from the initial resection and was noted to have residual polyp, and a biopsy revealed tubular adenoma with high-grade dysplasia. The patient was then referred for additional resection, and as I'm starting the case, I'm doing an evaluation of the lesion with a cap, and I can see the significant scar that's present. And you can see the scar kind of in this whitish area that's in the center of the lesion. This did not look like a lesion that was going to lift, but I still attempted a lift, but I used a different device to lift. So the first thing I did was mark the edges of the lesion, and then I decided to use the Erbijet, which is a high pressure injection. And my hope is to be able to use this high pressure injection to lift through the scar tissue. And I knew that a hand injection would not have sufficient pressure to do this. So by using the Erbijet injection, I was able to get a minimal lift, but the center of the lesion still did not lift well. I then switched over straight to the endorotor device because I knew I was not going to be able to get a snare to grab any of this tissue. And the endorotor device, I start off on the left side of the lesion, and it kind of gradually automatically pulls you to the right side of the lesion. And so we're doing several left to right motions, and slowly we're able to layer by layer resect the mucosal residual adenomatous tissue as well as the scar that's underneath it. I am encountering bleeding, but just by washing, the bleeding typically stops, and I'm able to maintain my visualization to continue the resection. And you can see here slowly we're able to resect the whole lesion. And that was a successful resection of a very, very scarred lesion with the endorotor device. I decided to close the lesion. It was in the rectum, so one can argue that closure was not necessary, but because of the bleeding that I did encounter, I did want to do a closure, and because it was easy to access in the rectum, I decided to close it with endoscopic overstitch. And here you can see I'm using a tissue helix to ensure I'm getting a good full thickness bite, and by using one stitch and one suture and several bites, I'm able to fully close the lesion. The patient did very well after the procedure and did not have any post-procedural bleeding or any post-procedural issues. The polyp, again, did come back as a tubular adenoma with high-grade dysplasia, and the patient will be returning in 6 months for their surveillance colonoscopy again. So one of the key takeaways from this talk, I think, is what not to do for incomplete snare resections. And the main thing is not to use APC to attempt to eradicate any residual neoplastic tissue after an incomplete resection. We know that leads to a substantial risk of recurrence, and APC leads to an incomplete treatment of deeper layers, which is the reason for this substantial risk of recurrence. It is okay to use APC to treat normal appearing mucosa at the margin of the resection, or you can also use hybrid APC technique to treat the margins, but this is also good to treat any microadenomatous tissue that may be at the resection bed. Macroadenomatous tissue should be treated by one of the other techniques we discussed today. Some other modalities to consider that we did not discuss in detail today includes the use of special snares, such as the Histolock snare. This is a stiff, twisted monofilament snare wire that helps recruit tissue and resect flat polyps. Using the Erbijet to lift through fibrosis is sometimes successful, as we saw in the video previously. A cap-assisted EMR technique can also be useful, where you have a snare open and then you try to suction the lesion into the cap and then close the snare around the lesion that's been suctioned into the cap. There's another grasp and snare technique that requires the use of a double channel scope, where you have a snare open in one channel and in the other channel you have a grasper or a rat tooth forceps, and then you pass the forceps through the snare to grab the tissue, and as you pull that lesion towards you, you can close the snare and resect the tissue. And lastly, there's been reports of using cryoablation to manage these scarred residual lesions. Lastly, I'd like to discuss my treatment algorithm for scarred lesions. I usually start with a standard EMR attempt, and I also try to use the special snares, such as the Histolock snare, which is great for flat scarred lesions. If that doesn't work, I attempt to do a lift with the Erbijet, which is the high pressure lifting jet. I then will try an underwater EMR attempt if the first two techniques were not successful. If the underwater EMR attempt was not successful and the residual lesion is small, then I will go to hot avulsion technique. But if the residual lesion is on the larger side, I will go to the endorotor endoscopic powered resection device. And lastly, on a case-by-case basis, I will sometimes use the full thickness resection device as well as ESD, again, depending on the case. Thank you, and I'll be available for questions in the question and answer session.
The EVA 15 insufflator and smoke evacuation system is easy to use, easy to integrate, and cost-effective, and it requires minimal workspace.
Thank you for inviting me to speak in MAGIC, and it's my pleasure to talk about chronic ESD in this symposium. I would like to start with a slide showing the increasing rates for surgical management of chronic polyps in the United States. So you can see here from the year 2000 to the year 2014, there was a significant increase in colonic surgery for non-malignant colorectal polyp. It's an excellent study done by the group from North Carolina. Honestly, it showed that this trend is increasing in spite of decreased surgery for colorectal cancer in general, because the number of cases of colorectal cancers are decreasing. But I'm showing also another study which shows the opposite. It shows that the colonic surgeries are decreasing. And you can see here, this is a study from Kaiser Permanente in Northeast, and basically it's, I think, in Portland. And what they show here that when they started having colorectal cancer screening program and they established advanced endoscopy practice for managing these polyps, the rate of colectomy decreased. So how come it is increasing everywhere and decreasing in that particular system? Because this delivery system or care delivery system is monitored. It has a specific interesting fact that the insurance is covering the cost of the care. And when the insurance is covering the cost of the care, they will be focused on cost-effective techniques and cost-effective analysis. And it is no-brainer that, and many studies show that endoscopy and endoscopic resection is cost-effective in these scenarios. What is happening is that there is this trend of referral of these patients with complex colonic polyps into surgery from the gastroenterologist. Do I have a proof for that? I'm going to show you another study, and that study from the group in North Carolina, no, in Michigan. And basically, this group from Michigan, University of Michigan, looked at the regional variation of colectomy for both colorectal cancer and colorectal polyps. They did not find correlation actually between both of them, but they saw this regional variation. And you can tell here that this variation mostly in areas that we can consider slightly underserved. They have higher rate of colectomy. And the authors said in their paper, while we do not have information on the use of specific advanced endoscopic techniques in the study, the extensive variation in use of colectomy for benign polyp suggests there may be underuse of non-surgical treatment in some regions. So basically, what you're trying to say that there's a variation of the use of endoscopy which led to more colectomy. And we see that everywhere. It's actually in the same practice. You might have an endoscopist who decide to send 3-centimeter benign polyps for surgery and other who would send it for advanced endoscopists. And we showed that in one of the studies that even within our group, some of these complex lesions are sent for surgery. So when we talk about endoscopic resection, it has two techniques, EMR and ESD, and I know that everyone knows the difference between them, but quickly, the basic main finding of ESD, what we want to do is that we want to be able to assess the lateral and deep margin and lymphovascular invasion to see if you have curative resection or not. By EMR, we are resecting the lesion with a snare, maybe in one piece, we call them block, or maybe in multiple pieces. EMR is a technique that's widely available. However, it is associated with a higher recurrence rate. It has a short and easy learning curve compared to ESD. However, it may not be for every lesion. And why is that? Because we can find lesions like the one we see in the picture here. So what we're seeing in image number 1 is a lesion that is non-granular. That lesion here, you don't think it is a cancer, but actually the biopsy from this lesion was T1A. If this one was removed by EMR, he would go for surgery because you will not be able to assess lateral margins or deep margin. Or lesion like the one down here, it is granular, but is large, more than 3 centimeters. And even look at these granules here. It is heterogeneous granular, like one granular larger than another, and one of them might have high-grade dysplasia and early cancer. So you want to do as ESD with accurate resection of the margin. And you can see here, we're taking good space between the lesion and the margin so that when it gets assessed, you have enough area of clean tissue that does not have cancer. Or you might have a lesion like this one, which is a very fibrotic lesion, and it is very hard to raise. If you try to use a snare here, it will just slide over it. You will spend 45 minutes to an hour trying to remove it with maybe a hot biopsy forceps or avulsion methods or APC. But with ESD, you can even faster remove that lesion and take it in M block, even if it is fibrotic. We can also have lesions like this one, like appendiceal orifice lesion, which is very hard to dissect. So you can do ESD to ensure that you remove them completely, or you can have submucosal tumor, or you can have patients who have ulcerative colitis, and an ulcerative colitis lesion could be a high risk for cancer. You want to do ESD for them, and on. So there is a need for ESD. I'm not saying that we should ESD every colonic lesion, but I'm saying that we're going to see more complex lesions that requires ESD, and otherwise it's going to be sent for surgery. So what's the good story of ESD? You want to do the procedure, no major bleeding, which is in the colon is not as problem as we find in the upper. You want to avoid perforation. You want to achieve clean margins. Peripheral and deep margin are clean. We call that R0 resection. And you also want to be efficient. You don't want to do that in 6 to 8 hours that anesthesia is upset and the OR or the endoscopy unit staff are not happy, or next time they're going to do ESD, everybody's dreadful about doing it. You want to be efficient, but also careful and achieve all of this. So is this that easily achievable? Unfortunately, in the colon is not the case. It is very hard to do colonic ESD. The colon wall is thin. Actually, the submucosal space is small. You inject it, and by the time you remove your needle and advance your knife to do the dissection, your injection is gone. So there is a limited expandability of the submucosa. And whatever you see in the animal training, when you have this very nice dome-shaped mushroom, you cannot find that in the colon. Also, the muscularis propria can be easily disrupted. It's a very thin wall that any wrong move, you can cut into the muscle and can have a perforation. Also, you have chronic looping. Some of these patients are obese, and now with epidemic of the obesity, we have a lot of patients who have above 300 pounds, and that is very hard to apply pressure or reach to a certain area in the colon. And add to that, if the lesion is behind a fold or starting in front and going to the back and you're not able to see it because you're looping, all of these would make ESD difficult. If you even have a difficulty reaching the cecum, imagine removing a lesion over the IC valve. So it is hard, but it's not completely impossible because we do have solutions for that. Before we talk about this, I want to just say a word about the ESD learning curve. And it is steep and it takes time, in my opinion, from the moment you decide you want to learn this technique till you do your first case. It should be around 2 years. And why is that? Because first, you want to be good at EMR. You don't have to be senior endoscopist, but you want to have some experience. It's very hard when I hear about we are training our fellows to do ESD. You can, but they are not going to be skillful to do something like chronic ESD out of fellowship. Most of the people, even the one who had exposure to ESD and fellowship, and they said, I'm going to go and work on it, they are preoccupied by improving their ERCP cannulation techniques. So you go out of fellowship, ERCPs is needed for being on call, and you want to be good at it. So you'll find that part of your brain occupied by that. So that reason I feel that you get to ESD when you're comfortable with your skills in EUS or ERCP, or maybe you decide, I don't want to do EUS and ERCP at all and focus on these techniques. So planning, you have to make structural decision in your unit. You have to make sure you have carbon dioxide insufflation. You have to make sure that the room that you're going to do the procedure, there's not another doctor following you that day, and then, or that moment, and then in 1 hour, everybody knocking your door. You don't want to put 7 cases and then put the ESD in between in the middle. All of these things, although seems like very obvious, I see these mistakes happening all the time. So you have to think about it. Also, you have to start studying, knowing which lesion to do, how you assess the lesion. Then after that, you can go for observation of ESDs. You can observe in the United States now in a lot of places, and any one of you is welcome to come to my unit at Baylor St. Luke's in Houston to observe. I welcome everyone every Tuesday. This is my ESD day. Even some of the physician in town, they just stop by at any time and watch ESD. You also can do in vivo and ex vivo training, animal training, which is also important. You need to do 20 to 30 hours working an animal in order to get better in doing it. Once you do ex vivo, maybe you can do one session in vivo. If you ask me how many courses of ESD I should go to, honestly, at least 5. I get so amazed by some of the physicians who have this expectation that they're going to show up for hands-on course for 1 hour or 2 hours and then expect to do ESD after that. It is not like this. You're going to try it, you're going to feel intimidated, and you're not going to be successful. So you have to set yourself success, invest a lot of time in watching procedure, working in animal lab, then move on to clinical ESD. Be careful in your first 40, 50 cases. Spend a lot of time, schedule cases for 3-4 hours at the beginning so that you can achieve the end block resection rate. Don't just go and cut the lesion in pieces every time we're doing ESD. Then you're going to develop this bad habit. Have a goal to get 80% in block resection if you want to do ESD. If you want to do it once a month, that's fine. If you want to do it once a week, is good. But don't say, I'm going to do 2-3 ESD today and end up chopping off each lesion and then not doing the procedure. So treat ESD with respect. Once you get up to 80 cases, then you have to expect to get en bloc resection rate of 90%. If you're not able to achieve that, then maybe you're not choosing the right lesions. Your speed has to be reasonable too. And once you become so good in it, then you have to really look at your curative resection. It's not only en bloc, but curative, because curative resection is indication of knowing what lesion to resect versus what not to resect. And at that point, if you reach to above 80% in curative resection, that's mean that you are a clinical teaching location for ESD, and maybe at that time you can start teaching it to other people. So what is the standard ESD strategy? Usually we do circumferential incision followed by dissection. That's what we do for every ESD. But then there is a tunneling method, which is a method mostly used in esophagus. We can also use it in the colon. And there is a bucket method. And the bucket method, as we can see here, is the most commonly used one. You start on one side, you dissect as much as you can, then you complete the incision. And the reason is in the colon, because you don't have enough submucosal space, if you do the full circumferential incision from the beginning, you're going to lose your water outside. So you want to do a bucket, work in the bucket, then dissect the rest, which is something agreeable, unless you're going to do traction technique. And I know there is another lecture about that. And in traction technique, you better start circumferentially. So here is the toolbox for tissue resection. We have the ESG unit, injection devices, resection devices, hemostasis devices, ablation devices, traction devices, tissue opposition devices, and stabilization devices. Today, I'm going to talk about 4 of them because there are novel devices that help us to resect, novel knives, and also traction and tissue stabilization and opposition devices. It facilitates chronic ESD in particular. So let's talk about one of the novel knives that came in the market in the last 2 years, which is a RISE knife. And this knife have a flat disc and central injection. And this knife in particular allows you to inject while you are dissecting. So you can see here, we are after injection, initial injection, I'm trying to dissect. And in this area, I had to inject a little bit to ensure that we're safe because there was more injection in the front of the lesion, not in the back. And we can nicely use the knife to do that injection. Also, in areas where you are very close to the muscle layer, you will find that injection can save you by pushing the muscle away when you are dissecting. The flat shape disc of that knife prevent also muscle injury, because sometimes if you have this pinpoint shape or something like needle shape, this can cause muscle injury. But if you have a flat shape like that, the flat disc will disperse energy. So instead of having a lot of cutting, there is some coagulation. And you can see here how we are injecting and dissecting in the submucosa with no problem. So that was one of the innovation in the knives that made a difference. And we're going to publish very soon our safety data using this knife and how that in expert hand, it has way less complication compared to other knives. Traction-assisted ESD. And traction-assisted ESD is an important because, in my opinion, it expedites the procedures and make it easier. I'm not going to talk much about it because I think the lecture after mine is about that. But in summary, you want to left mucosal flap in the other oral side and start dissecting. Allows you to have better visualization, dissection plane, faster dissection, avoid deep muscle injury. You can use clip with a line, double clip with rubber band, multi-loop traction, dual scope method, magnetic bead, snare traction, and a lot of new, like we can have a lecture just in tractions. I would like to quickly show this video of how to use traction because I think, as you can see here, this is a called flexible grasper, and I'm using it for traction. And initially, what's happening? The muscle is tented up there, which means that we did not yet separate the muscle layer from the lesion. That's a very important point because here, if you dissect a little bit lower, you may cause a muscle perforation. So at the beginning, when you are doing the traction, you have to understand that the muscle will tent up, and the more you dissect carefully, the muscle will go down, retract, and then the lesion will be separated away. And you can see here with every dissection is doing that. But you cannot only dissect in the middle and get excited about it. it has to be all the way to the end. So you have to go to the right side and the left side, as we can see here. So do not forget that when you dissect from the middle to the edge on one side and from the middle to the edge on the other side. And that's allow you to have the nice triangle of dissection. And if you don't do that, traction may not be helpful. And that's why some people come to me and say, I'm trying traction and it's not helping me. Well, it's not helpful because you have to use it the accurate way. You have to be far away when you're working. You have to visualize all the lesion. You have to look at that edges and dissect and free up the edges too when you're working. And we can see here using the traction in a dynamic fashion, which is moving it in certain direction. It will help us to improve and help us to dissect quickly. And you can see the timing of this lesion and how a huge lesion like that is removed very quickly. We'll move to the next devices with the tissue opposition devices. So for closure, and when we close lesions, we really want to ensure that we are having a strong closure. But a lot of time we have large gaps. And if you have large gaps, you get into a problem. What should I do? If you can suture, that's great, but certain location, you will have to use clips, like when to clips. For example, if you have a defect of more than 3 centimeters in difficult location, like right side colonic defect and third part of the duodenum or gastric fundus, all this area is very hard for the scope. And then maybe clip would be better here. And I know there's other devices that came in the market, like X-Tac, for example, which can cause what we call tissue approximation. I would like to highlight here a very interesting concept. And although you were thinking about tissue approximation using something like suturing or X-Tac, you can also use the clip to tissue approximate. So here, this is a novel clip, which you will utilize that one edge of the tissue will be approximated to the other, then close. And if you see a wide space like that, you would think, oh, I need a very wide clip so that it can get to both sides and close it. But if you look at this clip, it's only 11 millimeter, but what it can do, it can hold to one side of the tissue, grab it to the other side, then use it to close it. I feel that this clip too will help us with complex closure on the right side, and I'm very excited about using it too. We'll go to stabilizing devices. And stabilizing devices in the market, there's 2 of them. That's the first one. It's a double balloon device called Dilumin, and it allows you to go in and out and stabilize the colon, creating therapeutic space, improve visualization, and also have a suture at the end that allow you to do dynamic retraction. This other device we call Bath Finder, and Bath Finder has some concept called dynamic rigidization tube. The tube is very soft, and then you use suction, and with suction, you make it very stiff. And you can see here how it is taking a certain shape, and it will help with facilitating lube reductions. However, it does not allow you to do tractions, but you can use other method of traction with it. So I'm showing here an example of appendectomy done transcecal, and transcecal appendectomy is a new thing I'm working on. So far, I performed 3 cases, and we're writing our experience with the 3 cases as a new method of removing the appendix. Please do not try this yet. There is a lot of caveat, and it's beyond this lecture to explain how you can do that safely without complication. But as you can see here, using the traction and also the stabilization device allow us to go all the way to the end of the colon and dissect outside the lumen and extract the entire appendix using both the traction method and stabilization device in the same time. So using a stabilization device here is valuable. I can get the scope out, clean the lens, come back, and also use the device to facilitate closure, which is much easier to do the closure with that having the stabilization device than when you are free alone in the colon. And you can see here the entire appendix is completely removed, 2.5 centimeter appendix. That's our experience using the double balloon device, and we compared here a standard ESD versus double balloon, and you can see that standard ESD was 81 minutes, double balloons 96 minutes. It takes a little bit longer time, but allowed us to do more en bloc resection rate. And it allows us, you can see here, the hybrid ESD was 51% of cases in the standard and 36% was double balloon. We published that in 2020 for cases done in 2018. And then we have now more data, new number of patients was in this new registry, and in this new registry that have 144 patients was successfully was done by double balloon, was Lumen, and you can see here that it was successful in 89% of the cases. If you have anatomical variation, severe diverticulosis, patient had prior surgery, maybe they are not good for using this double balloon. We had two group EMR and ESD, and we did that in 3 centers in the United States. And you can see that the ESD polyp is 4 centimeters in size for the ESD group versus 2.3 for the EMR group. It takes longer time to do the ESD, but look here, it says 43 minutes. There's significant improvement in our time from the previous study. So when you learn how to use these devices, it really improves the procedure. Look at the time to closure down, 11.6 time. The overall case time is 85 minutes in 83 patients, and 85 minutes is 1 hour and 20 minutes for chronic ESD for lesion 4 centimeters in size, and most of them had fibrosis. I think this an excellent outcomes. This was another video for the best finder. And in summary here, we'll say chronic ESD is evolving, particularly was using both methods, the bucket method and traction-assisted ESD. These are the 2 ways of doing chronic ESD, in my opinion. Stabilizing devices, enabling accurate dissection in tough location. And I am proponent of using stabilizing devices in the United States. And you have 2 options right now. You can choose one of them that fits you. I know some people say it increases the cost of the procedure, but it allows you to do procedure that in the past you wouldn't be able to do in ESD, and they would have been sent for surgery. Dynamic traction will expedite ESD dissection. You saw in our series, we're able to remove larger lesion in less than 2 hours. I do 4 ESD per day now because each one is scheduled for 2 hours, so your 8 hours equal 4 ESD. The novel dissection and closure device, like the one I showed, will enable safer dissection and post-resection closure. Thank you very much for listening, and wish to meet you in person next year. And if anyone would like to observe ESD or know more, you're welcome to come to Houston. Or, of course, you can follow Dr. Michel Kahela. He is the 3rd space endoscopy king, and I feel like next year, hopefully I can work together with him in this course in person. Thank you.
Good afternoon, everyone. It's a pleasure to present at the MAGIC conference. I'd like to thank Dr. Kahela and the rest of the organizing committee for this opportunity to speak about an emerging procedure and technologies that I'm getting heavily involved in now. So my topics are increasing adoption of ESD in the West through dynamic traction. And so I'm a professor of medicine and I chair the gastroenterology and hepatology department at the Mayo Clinic in Florida. And I've had an increasing interest in submucosal endoscopy, particularly ESD. And, being a Western trained endoscopist, looking for ways to make the procedure more efficient and safer. I have several conflicts of interest, which do overlap with some of the items I'll be speaking about in this presentation. So with respect to learning objectives, I want to speak a little bit about the different endoluminal resection strategies, EMR versus ESD, the need for endoluminal robotics and triangulation, data on traction or TESD versus conventional ESD without traction, what are the strategies for traction and the different sort of traction directions, and what are some products used in the US, such as the track motion system or the dual clip band system, dynamic traction wire, and so on. And so as we think about ESD, obviously it's important that we have very high quality optics. We need to be able to see not only the pit pattern of a lesion, but have really great visualization to differentiate submucosal fibers from fibrosis. And so this is an example of an image taken from a Fuji endoscope using both BLI and optical magnification. And I think the optical magnification's been particularly helpful for me. And here we've actually, there's been identification of a really depressed area, suggesting early gastric cancer in this lesion. So, some other conventional endoscopes may not have detected this. We have a variety of accessories to help with ESD, hoods, different types of knives, the clutch cutter, and so on. And so I think, how do we best use these technologies to allow for a superior outcome? These technologies, unfortunately, a sort of unidirectional through the scope and don't really provide any traction, which it can be helpful. So there's piecemeal EMR or PMR and ESD that's used for large superficial gastrointestinal lesions. And there's several disadvantages of EMR. You don't get en bloc resection in large lesions. Certainly it's hard with the lesions being over 2 centimeters. There's a high rate of recurrence because you don't get en bloc resection. And sometimes, for some flat lesions, actually impossible to resect. Your snare continues to just slide off the top of the lesion. And so some perform a hybrid ESD for this approach, although in my opinion, we should really be moving away from hybrid ESD and just stick to conventional ESD to get sort of premium outcomes. Now, what are some disadvantages of ESD? Well, there's a steep learning curve, there's prolonged procedure time, an increased rate of adverse events. It's certainly technically demanding, and currently in the US at least, reimbursement suboptimal, although I know there's a lot of groups and societies campaigning in that space. So what do you think about some of the big difference between endoscopy and surgery, and really what are we missing at this moment in endoscopy? To think about when a surgeon performing surgery, they use they sort of behave like we are when we're eating a steak. We use a knife and fork. We sort of see from on top, and our accessories to help us eat come from different directions. The surgeons do the same thing. Their non-dominant hand provides traction while their dominant hand provides dissection. We're unable to do that with endoscopy, and effectively we're trying to eat a steak with a knife only. It's very hard. And so what does traction do? It increases the separation of the mucosa and muscularis propria, and this sort of results in improved visualization of the submucosa, provides tension on the submucosa for more efficient dissection, and it also reduces procedure time. So as we look to the future, let's think about the ability to triangulate and have different sort of perspectives of view as we're working on a lesion. And this can be done using sort of an endoscopic robotic system. And there are some flexible systems that are emerging, which use sort of this master console and robot slave. And so one would sit, the endoscopist would sit at the console on the right. It could be in the same room or even in a different country to the presence of a robot. And there's sort of a lot of ergonomic benefits that are the result of these emerging technologies. And so this is what it looks like. You can see here, you have a flexible platform. Then you have a camera that can move in and out and provide, that's flexible, that can provide sort of different angles of view as we're working through a lesion. And then you have two arms, which can provide several directions of motion. And when you sit at the controller, as you can see in the middle, you get sort of haptic feedback. And the imaging sort of does provide, in a way, sort of this three-dimensional view. I've used this particular model ex vivo, and it takes a little bit of learning, but incredibly exciting. And actually, you pick it up a little bit faster than what you might think. And so this is an example here of, sort of taking out, a bit of mucosa that could represent a lesion, for example, using the system. So you can see what you can do with sort of the grasp and dissect strategy, and sort of moving around the lesion through different angles to get great exposure of that submucosa. And here the ESD was performed even without a submucosal dissection or injection. So quite remarkable. And not only can you dissect the lesion efficiently and safely, but you can actually do a really robust closure. Not only is it available sort of per rectum, but there's flexible upper GI systems that are 75 centimeters long that are being sort of trialed overseas. So does using traction actually confer any benefit? This is a really nice systematic review and meta-analysis from Sawani at Johns Hopkins, where she looked at both randomized control trials as well as observational studies, looked at 30-day follow-up. In total, there were 23 studies. Importantly, 22 were from Asia, and there was only one from Europe. So this may not be directly translatable to our sort of Western practices. But over 2,500 patients, evenly split between those who underwent traction ESD versus conventional ESD. Now, the clip with thread method, which I'll go through later on, was the most common traction-based strategy. And there were several outcomes that were looked at, which I'll describe. And so if you just compare the randomized controlled trials and observational studies with respect to total procedure time, what you can see was that there wasn't a significant difference between the two study methods, and both had approximately a 20-minute reduction in procedure time with the use of traction. And as you look at the different regions of the body, the esophagus, stomach, and colorectal region, actually the traction ESD conferred the greatest benefit with respect to a reduction in procedure time in the colorectal region. Now, what about IRO resection? This is an important outcome and a surrogate for the risk of recurrence. And there was a outcome that favored traction. And what about perforation rate? I guess another important outcome when it comes to ESD. The perforation rate was lower when traction was used because of that better visualization and tension on the submucosa. And in fact, it was lower overall and lower when just RCTs were reviewed. Now, importantly, I think this is translatable to us in the West, that there was a French study that was included in this meta-analysis, the only European study. And in that group, they actually include the ESD endoscopist learning curve, and they actually had an 18% perforation rate. So what it tells you is that early on in your learning curve, your adverse event rate is going to be higher, particularly perforation. So, right at the end, I'll go through some of the closing technologies. So I think it is important to not only be able to perform the resection, but close at least some aspects of a lesion if need be. So in summary, ESD resulted in a shorter procedure time, improved IRO resection rates, lower perforation rates. And in this meta-analysis, there was actually no difference in en bloc resection or rates of bleeding, which are important outcomes. There were some limitations. This is a systematic review and meta-analysis. There were variability in expertise and definitions of procedure times of the endoscopist involved. Now I want to go through the different types of traction methods and traction directions, because it's important to understand as you think about which traction strategy you'll use in dealing with your lesions. And one of the simplest sort of traction techniques is the distal cap of a hood. And this is attached to the distal end of the scope. It allows for an improved visual field. It gives you a focal distance away from the submucosa. It everts the mucosal flap to help you enter into the submucosal space. And it provides that tension on its own on the submucosa. There's gravity, which is very effective, and one would argue could be the first-line traction method used. And so what you want to do is place the lesion in the non-dependent position, particularly those lesions that are large and heavy. They really benefit from the use of gravity. And then you can get great exposure of the submucosa. So how can you tell where the dependent area is and if the lesion is on the dependent side? You can sort of put your injection needle out and slowly drip some fluid through it and see which direction it goes, or you can even use the water jet to see where the fluid pools. And you really don't want the lesion to be on the dependent area, even if it's an easy resection, because if you do hit a vessel, then fluid pools basically over the submucosa that you're dissecting through, and it can be hard to see. So if you can place the lesion in the non-dependent position, it can be helpful. As you think about maneuvering the patient to leverage gravity, it's obviously easiest for colorectal ESD because it's much easier to spin the patient, supine, left lateral, even right lateral. It's much harder to do when you're doing a per-oral approach. So another sort of type of natural traction is using buoyancy. And so, if you found when you perform ESD, if you are unable to move the lesion away from gravity, you can get into this situation where it's actually the mucosal flap and the lesion are heavy and you really can't get underneath it. And so you try all sorts of techniques and you end up sort of filling that area with fluid, you over-inject sometimes, and then you end up with the situation where you've got a lot of bubbles and this, gas fluid interface, which also hurts visualization. And so what if you just immerse the whole lumen under fluid? And so if you look at the image on the bottom left, you can actually create a buoyancy of the lesion. Ideally, you want to use normal saline because the specific gravity is actually higher than that of water for improved buoyancy. And then you can use the water jet function of the endoscope and basically use that to sort of force the mucosal lip up, and then use your cap and endoscope to sort of get into that submucosal space. So a really nice and often underutilized strategy. It can be problematic if you hit a vessel and get some bleeding. Obviously, it's much harder to see sort of through that blood mixed fluid. And then there's a pocket creation technique, which sort of allows traction through maintenance of the mucosa and submucosa surrounding the lesion. So if you do a full circumferential release and trimming, what happens is you lose a lot of that natural traction when that lesion's connected to the wall. So a submucosal tunnel, sort of when used with the pocket creation technique, sort of allows the endoscope to be parallel to the submucosa, which makes dissection of the submucosa easy. The scope's actually hugged in this tunnel, so it's quite stable. And you don't get much sort of leakage of the submucosal injection fluid. So what you do is you make a sort of 1 to 2 centimeter mucosal incision, get the scope into the submucosal space, and start to tunnel beneath the lesion. And then you want to keep, as mentioned, don't want to dissect don't want to do mucosal release early, but once you think you've done enough submucosal dissection underneath the lesion, then you can do your mucosal release of the dependent area of the lesion, the gravity dependent, and then do the non-dependent lesion. Lesion should just fall away. What you don't want to do, though, is overextend your tunnel. And it can be easy to do because you're underneath the lesion. You're not sure what's normal and what's not. And you can extend distally as well as laterally. And so what I've done is sort of do at least a distal release sometimes first, so I don't overextend the tunnel in the distal aspect, but also do like an intermittent lateral release. So leave little mucosal bridges there that still provide that traction, but you clearly know when you're beyond your lesion, so you don't over dissect. Another simple method is using sort of a clip flap method. So if you just cannot get your cap-fitted endoscope underneath the lesion, just drop a clip on the flap and then sort of use the body of the clip to sort of help you to elevate or evert the mucosa to get underneath the lesion. So as we think about the different traction methods, the sort of distal diagonal traction, F, seems to be the most favorable approach. So you've got the sort of your vertical traction, which is image A as you pull up with great exposure of the submucosa. You've got proximal traction, B or top right, which isn't that helpful, but can add some value when combined with the sort of vertical traction that you get with a hood placed on the endoscope. Distal traction in D is nice, but it tends to become less as you dissect more of a lesion. And sometimes you actually end up pulling the muscularis propria, or you evert the mucosa, evert the lesion so much that you can actually inadvertently injure the mucosa, the sort of mucosal surface on the underside of a lesion, sort of making deep margin assessment hard. So ideally what you want is sort of F, this sort of distal diagonal traction system. And you can see there how much exposure you can get of that submucosa as you sort of fire through that lesion. So the different methods of creating that sort of traction direction, if you take the sort of two on the left here, the external forceps method or a clip and snare method, so they use either a snare or a forceps that's sort of railroaded on the outside of the scope, deployed on the edge of the lesion to cause proximal traction. So it's unidirectional and somewhat limited, but because of the stiff nature of the forceps or the snare, you can actually get a push and pull. So sometimes you can get some distal traction as well. But you do need to remove the endoscope and it can be a little burdensome. So there's a clip and line method, which is what I mentioned has been most extensively studied. But again, it's unidirectional. And then you've got what I think is particularly exciting is the clip with loop method. This is an internal traction method. It doesn't require removal of the endoscope, and where you can actually use sort of a band and sort of this dual clip technology to basically cause a sort of distal diagonal traction. So these are some examples here of why you need to think about your approach as you're going through these lesions. If you start in retroflexion, the clip and thread traction system needs to be in one place. If your lesions with a greater curvature or you're going in a forward direction, you may want to place your clip and thread on another. So all has to be thought about and planned prior to deploying any traction method. And so here's the clip and line method with the lesion sort of being accessed in a retroflex position. It's a very simple technique using dental floss or suture. It's unidirectional. However, because you sort of got something running outside the scope, you actually get, not uncommonly, this clip falling off. There's just some friction there. And so this is how it's done. You tie some dental floss or suture to the body of the clip, close the clip and retract it back into the scope, and then you go down, deploy the clip, and then exchange the scope out and go back down and provide sort of that external tension. Here's an example where you've got a lesion at the incisura angularis, very heavy and floppy. We can't get underneath it, and sort of a clip's deployed. Then sort of the sutures pulled at the level of the mouth, really nicely exposing the submucosa with the scope in retroflexion. This is the sort of clip and snare method. So you sort of mount the snare on the tip of the endoscope, then push the snare forward as you've grasped the lesion, and then sort of leave that behind and sort of pull on that snare body to get that proximal traction. So to avoid the sort of unidirectional traction, someone created this suture pulley method. So a very clever method whereby you sort of use the opposite luminal wall to the lesion to create another axis, so that when you do provide traction, you actually get some vertical traction and a distal traction to get this diagonal traction, as opposed to simply just a proximal traction that you get with this simple sort of single clip and thread method. Now, when you think about using this sort of dual clip and band method that I described very early on, this sort of internal method, you've got to think about a couple of things. So it's very simple to deploy. The way it works is that you have a clip with a band attached, you place that on the mucosal edge, then you sort of grab the band with a second clip, drag it up to sort of the vertical or even distal aspects, and then deploy that second clip. Now you can see you get sort of both that vertical and distal traction. However, this is really only valuable when you've got a large space. Otherwise the suture pulley method or this method won't work. So it's not very helpful in the esophagus or duodenum. Also, you can dictate the amount of traction based on insufflation. The more you insufflate, the further away or the larger the lumen is, and the more traction you get. Now, you want to avoid somewhat in the retroflex position because it can provide a lot of tension on the walls, which can sometimes dislodge the clip. But here's an example of a sort of a lesion that underwent ESD, where there was a lot of fibrosis from a prior EMR, and this sort of clip, double clip band traction system was very helpful with the release. And this is one study from France, which looked at almost 600 cases, very high on block resection rates. Perforation rates were still 5%, and the lesions were about 5 centimeters in size. So it seems to add value through the scope and easy to use. Now, you can have more than one ring or two rings, of course. You can have 3, and this way you can deploy multiple clips through multiple axes and sort of change the orientation of the sort of the lesion as you're dissecting through the submucosa for a more efficient dissection. Just a quick point on duodenal ESD. The scope position can be difficult and unstable. Sort of water immersion can be very helpful to sort of leverage that buoyancy. When you have water immersion, you don't have gas insufflation, so the walls aren't thin. Thinner the wall, the higher risk of perforation. And the pocket creation method can be helpful here too. So what are some of the available technologies for traction? So this is the Fuji track motion system. This is my favorite approach. where you use a double channel endoscope, and one channel is used for the track motion device, which sort of is very dynamic. You can go forward, back, sort of grasp and re-grasp as necessary. And then your sort of standard ESD accessories go through that second channel. And so this is what it looks like. In vivo, you can use the track motion with the clutch cutter, any type of ESD knife, and really provides an excellent exposure to that submucosa. So one of the concerns initially before using this was, a double channel scope, isn't it stiffer? Doesn't that make ESD more challenging? Well, interestingly, this Fuji double channel scope actually has a very, very tight bending section. It's really very soft and flexible, and you can get remarkable range of motion. And furthermore, the working, even the smaller diameter of the working channel, the secondary working channel is still 3.2 millimeters, which is larger than the 2.8 millimeter working channel of some of the other scopes. So really, you get sort of two large working channels, which help with significant suction. And also the imaging is excellent. I mean, here LED lights are used rather than xenon, so you get really high quality imaging here. And you can see, and I'll show you video, but on the bottom there, you can see the tight angulation that you get when using the even this double channel scope. It's remarkable. And so here's a video of the device setup. You remove a track motion from the packet. You can see here that you get 1-to-1 rotation in either direction. To open and close, it's a one-hand system. You close and flex or extend the system using your thumb. There's a little attachment that allows the track motion to be placed on the double channel therapeutic endoscope. It takes about a minute to load. And once sort of locked in position, you can use this system with a cap or without a cap. And you can see here, you can go open and close. You can go back and forth here. So you use traction across multiple orientations. So I want to show you a case here of the system here. This is one that we performed live as part of one of the ASG meetings. This is a large, almost 8 centimeter or 10 centimeter lesion that is in the rectum. We thought that traction would increase the efficiency of our technique. So we did an anal side release here, and you can see that actually gravity was rather surprisingly helpful here, but you can see some large vessels across the anal side. However, when the scope's in retroflexion, we became very on fast with the muscle layer. And so we thought that it might be good to deploy the track motion. You can see here that despite being heavily retroflexed, very acute angles here with ease. You didn't feel any stiffness whatsoever. And you can see with a simple grasp and rotation, you get a lot of stability of the scope because you're attached to the lesion. You get great exposure of the submucosa. You can grasp the top of the lesion, you can grasp the undersurface of the lesion, and you can see again the traction present there. You don't want to overdo the traction. You can see that you're tending to elevate the muscle. The traction is very powerful. So just be cognizant of that when you're using this system. You can see here you can go through the submucosa. You really don't have to adjust the track motion. You just keep your hand on the ESD knife and just using the Irby precise setting here, you're actually very easily able to dissect through this submucosa. The stability was really quite surprising. And then as you get to the end, often that sort of last little bit is very floppy and hard to dissect here. With the track motion system, you can get really, the angles can be very, very acute. You're seeing that submucosa and then you dissect with ease with a lot of submucosal tension. Now, Microtech also has a system, the Shore track system, and I think I've showed you sort of some animations of this. Basically, it's a primary clip with a double ring band, and then a second clip that's used to provide that traction. So you can put the second clip sort of on the distal aspect of a lesion or even on sort of tissue further away. And so here we have a published case using this system here. So you're grasping the proximal mucosal flap, getting the second clip, grabbing the band and putting on a distal aspect of a lesion to really give some quite significant traction there. And you'll see here some really nice exposure of the submucosa, and it can be hard in the hepatic flexure here. So some nice exposure and safe and easy dissection. This is an example of the system being used in the colon in a slightly different manner. So standard ESD techniques are used here. There's a circumferential incision, but there is a dependent area on the left there at 9 o'clock. So this is Sawani's case, and she sort of decided to deploy short track. So primary clip deployed, and then you want this sort of distal diagonal traction. So the secondary clip is used here, sort of kind of nice and atraumatic. And here, instead of getting it on the distal aspect of a lesion, which is already dissected, she's actually grasped sort of the normal colonic wall and get really nice exposure of the submucosa and a very efficient dissection once again. Now, similarly, there's the Prodigy traction wire. So this is a very similar system, but instead of using a band, there's a dynamic traction wire that's used. So again, 2 clips, similar design. The clips are atraumatic, so obviously even if you grasp, the secondary clips used to grasp the normal lesional, normal wall away from the lesion, your lesion is not stuck inside the lumen. You can easily remove these clips with some grasping forceps. And there's 2 different sizes, a 20 millimeter and 35 millimeter, that can be used depending on the size of your lesion. So here is the use of the lesion, the Prodigy system for a lesion in the gastric antrum here. You grasp the mucosal flap with the initial clip, deploy, and then you use your secondary clip to grab the traction wire. And here again, it's pulled outside the lesion itself. And you can use, sometimes even 2 of these systems. You don't just need one, so you can basically get, a nice sort of even distribution on the left and right side of the proximal aspects of these lesions, really nicely elevating that mucosal flap and getting great submucosal dissection. So using 2, I found, can be particularly helpful. And so last, somewhat not designed for this region, but is the Apollo X-Tac. You've probably all seen this. This is a helix suture system that is used to close mucosal defects. This is a nice video that's courtesy of a great endoscopist at Duke University. So here's we approach the lesion with the X-Tac. We place the tac forward, which has a suture running through the scope. We deploy that first helix. Then we go to the opposite wall, sort of in a vertical direction. So here you get really nice vertical traction as opposed to the other 2 systems I just showed you. The band and the dynamic wire, you don't really get a whole lot of vertical traction. Here you can get a lot with this. You can get a lot of vertical traction with track motion, certainly. But here we get the advantage of that very strong vertical traction. You deploy, and then using that sort of suture pulley technique, you can get nice exposure of the submucosa. So just briefly on closing ESD defects, there's a variety of methods to close defects, from sort of clips to the over-the-scope, clips to endoscopic suturing, or even X-Tac, which could be, I guess, somewhere in between. And there's pros and cons of each. There's very large clips that are available, and some even 22 millimeters, which can be very helpful to approximate some of these really large lesions. And I think as you start to perform ESD and you have these large defects, it's very helpful to not only close the lesion to prevent post-procedure bleeding, but it does allow you to actually send a patient home the same day. So in summary, I think traction ESD is here to stay. It's going to significantly aid dissemination of the ESD in the West. The benefits are greatest in those less experienced. It allows for improved RO resection, decreased procedure time, and a lower rate of perforation, all important outcomes. There's several simple to deploy through the scope methods available, and then closing ESD defects has some benefits. So thank you very much.
Hello, my name is Dr. Melissa Latore, and I am the Section Chief at NYU Langone Health Tisch Hospital and Kimmel Pavilion, an assistant professor of medicine at NYU School of Medicine, and chair of the ASGE GI Hospitalist Special Interest Group. It is an honor for me to be here today, and I thank the course directors for inviting me. I will be speaking about hemostasis and the next frontier. These are my disclosures. My objectives today are to review the latest guidelines in GI bleeding, to discuss novel devices in the treatment of GI bleeding, and to showcase real-life GI bleeding cases that highlight the implementation of new guidelines and technology. I would like to begin first with the 2021 ACG updates in upper GI bleeding and peptic ulcer disease. When it comes to pre-endoscopy, they recommend risk stratification with the Glasgow-Blatchford score and say that patients with very low scores of 0 to 1 can be discharged for outpatient follow-up. A GBS score of 0 to 1 confers a less than 1% risk of transfusion, hemostatic intervention, or death. They also recommend the use of prokinetic infusion of erythromycin, 250 milligrams, to be given 20 to 90 minutes before endoscopy. This reduces the need for repeat endoscopy and also reduces the length of stay. They recommend a restrictive PRBC transfusion threshold with a hemoglobin of 7, except in the cases of hemodynamically unstable patients, as these patients with exsanguinating bleeding were excluded from studies. For patients with acute coronary syndrome or pre-existing cardiovascular disease, they recommend a higher transfusion threshold of 8. They could not reach a recommendation for or against PPI prior to endoscopy and found there was no benefit in further bleeding or mortality. However, it is known that PPI does lower the risk of stigmata of hemorrhage and at the time of endoscopic treatment and may benefit patients when endoscopy is not available or delayed. They recommend patients should undergo endoscopy within 24 hours of presentation. This is for low and high risk patients with a Glasgow-Blatchford score of greater than or equal to 12. This is a change from prior guidelines, which stated that endoscopy may be considered within 12 hours in patients with high-risk clinical features. Studies exclude patients with hypotensive shock that did not respond to resuscitation, who may require more urgent intervention. They could not reach a recommendation for or against endoscopic therapy in patients with an adherent clot that is resistant to vigorous irrigation. Either course of action can be considered acceptable in this case. I would like to take a moment to review the Forest classification and the prevalence of stigmata of recent hemorrhage in patients that are hospitalized with GI bleeding. The most common still remains clean-based ulcers at about 55%. On this second chart, you can see the risk of further bleeding without endoscopic intervention in patients with clean-based ulcers remains low at 5% and increases as the stigmata worsens, with active bleeding having a risk of rebleeding of about 55% without endoscopic intervention. This also confers an 11% risk of mortality. With that said, the new guidelines make recommendations on endoscopic management and make a strong recommendation for bipolar coagulation, heater probe, injection of absolute ethanol, and epinephrine, not alone, but in combination. They make a conditional recommendation for through-the-scope clips, argon plasma coagulation, soft monopolar coagulation, and TC325 hemostatic powder for active bleeding, and over-the-scope clips in the situation of rebleeding. As always, therapy should be individualized to the ulcer and the patient at hand, and the best treatment is the one that is accomplished safely. Depending on the endoscopic features of the ulcer at hand, different endoscopic management might be recommended. In the situation of active bleeding or a visible vessel, they continue to recommend endoscopic therapy followed by high-dose PPI therapy. With an adherent clot, there is no recommendation for or against endoscopic therapy, and either course of action, removing the clot or leaving it alone, can be considered appropriate. Regardless, this should be followed by, again, high-dose PPI therapy. In the situations of a flat pigmented spot or clean-based ulcer, no endoscopic therapy is recommended, and standard PPI therapy can be implemented. Following endoscopy, high-dose PPI should be administered continuously or intermittently for 3 days after endoscopic treatment of an ulcer. This reduces further bleeding and mortality. Intermittent dosing can be given orally if feasible, and they suggest the use of 80 milligram bolus with 40 milligrams 2 to 4 times per day. They also suggest continuing high-dose PPI therapy twice daily up until 2 weeks after endoscopy. They cannot determine beyond 2 weeks, but the relevant study continued patients on PPI once daily. Unfortunately, as we all know, rebleeding can occur, and in this situation, they recommend a repeat endoscopy, as a repeat endoscopy can achieve successful hemostasis 75% of the time. In the situation of rebleeding, use of the over-the-scope clip can be considered. Patients with bleeding ulcers who have failed endoscopic therapy should be treated with transcatheter arterial embolization. This results in fewer complications, shorter length of stay, and no difference in mortality compared to surgery. Next, I would like to discuss the use of novel technology in GI bleeding. I'll first begin with the over-the-scope clips. The guidelines recommend the use of the over-the-scope clip in patients with known peptic ulcer disease previously treated with standard therapy who experience rebleeding. This effectively is secondary therapy. I've had great success in using the over-the-scope clip in other scenarios and recommend these practical uses. I'll share the data for this a little bit later in this talk. But severe and hemodynamically significant GI bleeding as primary therapy, in patients with large or deeply cratered ulcers not amenable to treatment with standard techniques, and on patients on anticoagulation and/or antiplatelets where bipolar cautery is not recommended and through-the-scope clips are ineffective. This is the study that led to the recommendation of the use of the over-the-scope clip for patients with peptic ulcer disease rebleeding, called the STING study. In this study, they took patients with recurrent peptic ulcer disease bleeding who were treated with standard therapy and randomized them to hemostasis with the over-the-scope clip or hemostasis with standard therapy, their second time around. The primary endpoint was further bleeding, and you can see the incidence of further bleeding in the over-the-scope clip group was 15%, compared to 57.6% in the standard therapy group. This was statistically significant, thus leading to the recommendation of the use of the over-the-scope clip for peptic ulcer disease rebleeding. There is also excellent data for the use of the over-the-scope clip for primary hemostasis. In this single-center RCT of 53 patients with severe non-variceal upper GI bleeding, the patients were randomized to standard endoscopic therapy with hemoclips and cautery versus over-the-scope clip. Following endoscopic treatment, standard of care was delivered, and the patient and the primary medical team were blinded to the treatment arm. The primary outcome was rebleeding. And after standard treatment, rebleeding was noted in 29% of patients versus 4% of patients who were treated with the over-the-scope clip. This was a 90% risk reduction in bleeding. They also evaluated 30-day outcomes with the over-the-scope clip and showed that there was reduced rebleeding, fewer severe complications, and less PRBC transfusions post-procedure when the over-the-scope clip was used for hemostasis. Here we can see the Kaplan-Meier curves for this study with the proportion of patients without rebleeding at 30 days and we see that the over-the-scope clip was more effective than standard therapy at preventing rebleeding. In this second study, looking at the over-the-scope clip for primary hemostasis, similar to the study for rebleeding labeled the STING-2 trial, there was a multi-center RCT of 100 patients with acute non-variceal upper GI bleeding, which evaluated for successful endoscopic hemostasis without rebleeding. This study was not blinded. In this study, patients underwent standard endoscopic therapy, most of which received standard through-the-scope clips, versus over-the-scope clip. Hemostasis without rebleeding after standard therapy was noted to be 73%, versus 92% in the over-the-scope clip group. This was statistically significant. Persistent bleeding occurred in 6 patients in the standard group who were subsequently treated with the over-the-scope clip. As a result, it was determined that the over-the-scope clip is superior to primary standard therapy with standard clips. Now that we've discussed the data, I'd like to review some practical considerations prior to deploying an over-the-scope clip. First, was there any difficulty reaching the site of bleeding, perhaps a stenosis or a narrowing? This might indicate it will be difficult to pass the over-the-scope clip through. Next, what is the proximity of the lesion to the ampulla, as we would never want to cause a biliary obstruction? Is there a possibility of causing a luminal obstruction by deploying the clip? And what are the anticipated challenges of deployment? Perhaps scarring and fibrosis, ulcer depth, or positioning. There are many unanswered questions with regard to the over-the-scope clip, such as how long will the clip stay on? What if it doesn't work? When and if to use epinephrine? What if the ulcer is too big for the clip? What if the clip is placed incorrectly? Should an endoscopic Doppler probe be used? I hope to explore some of these in our case series. The next novel technology I'll be discussing is the endoscopic Doppler probe. The endoscopic Doppler probe can be used to detect arterial blood flow within an ulcer base and has been associated with higher rates of ulcer rebleeding. The 2021 guidelines mention that the endoscopic Doppler probe is still under evaluation, but there are many practical uses, which I will share here. First, when deciding between stigmata, such as a visible vessel or a flat pigmented spot. Next, to determine the optimal site of endoscopic therapy, to map the trajectory of blood flow within an ulcer base, and to assess the effectiveness of hemostasis. It's an easy device to use, very similar in its appearance to a bipolar probe. It should be used before epinephrine if possible, as epinephrine can mask the signal that is detected on the Doppler. The goal is to use the mid-range depth setting to minimize surrounding noise and to break the ulcer into 4 quadrants and search for the areas that have arterial blood flow. Your therapy should be targeted to the areas where blood flow is mapped. So what's the evidence for the use of the endoscopic Doppler probe in hemostasis? This is a randomized control trial comparing standard hemostasis to endoscopic Doppler probe-assisted treatment. In this study, you will see that the 30-day rebleeding rate for standard therapy was higher at 26% than the Doppler-assisted rebleeding rate at 11%. This was statistically significant. In this meta-analysis comparing standard endoscopic therapy and endoscopic Doppler probe-assisted treatment, you will see there were improved outcomes with the use of the endoscopic Doppler probe as it relates to rebleeding, surgical intervention, and bleeding-related mortality. Next, I'd like to present a case that demonstrates the effectiveness of the endoscopic Doppler probe in assisting hemostasis. This is a 71-year-old man on aspirin and clopidogrel presenting with syncope, hypotension, melena, hematemesis, and an acute 2-gram drop. An EGD was performed within 12 hours of presentation. On visual appearance, none of these ulcers would receive treatment. At best, one can be classified as an ulcer with a flat pigmented spot. However, given the severity of this patient's bleeding, we decided to evaluate the ulcers for risk of future hemorrhage and arterial Doppler signal. So which of the ulcer was the culprit? On our examination with the Doppler probe, we noted that ulcer number 3 had a strong arterial signal at its base, while the others had no arterial signal noted. The ulcer with the arterial Doppler signal was subsequently treated with through-the-scope clips and epinephrine. After the treatment was completed, we noted that the endoscopic Doppler probe signal was eliminated. Next, I would like to present some cases which highlight the use of the novel endoscopic therapies that we just discussed. These were performed by our general GI fellows and general GI attendings. This first case focuses on the use of novel technology in rebleeding. Here we have an 82-year-old woman with rheumatoid arthritis and daily NSAID use, presenting with hematemesis, melena, and acute anemia. This is her initial EGD, and we see her initial findings. On this first EGD, she receives standard therapy, and her ulcer is treated with bipolar cautery and epinephrine as per guidelines. On day 3, she has recurrent acute anemia with a 1 gram per deciliter drop, and on day 4, she undergoes a repeat endoscopy. On this endoscopy, the stigmata noted was either a clean-based ulcer versus a flat pigmented spot. Regardless, no endoscopic intervention was deemed necessary. The patient continued to receive medical management with PPI therapy, and on day 7, she had recurrent acute anemia of 1 gram per deciliter and melena. She subsequently underwent a third endoscopy for rebleeding, and this time the ulcer was evaluated with an endoscopic Doppler probe to assist in treatment. On this next video, you'll see the evaluation with the endoscopic Doppler probe that shows a positive arterial signal, which was subsequently treated with an over-the-scope clip. Following over-the-scope clip placement, the ulcer was checked again for arterial blood flow, which confirmed that the arterial blood flow was eradicated. You hear a strong arterial signal within the ulcer base. An over-the-scope clip is positioned. And finally, the over-the-scope clip is deployed, and the Doppler probe confirms there is no further arterial signal. Case number 2 highlights another case of rebleeding from peptic ulcer disease following standard therapy. This is a 58-year-old man with chronic back pain and opioid use disorder who presented to an outside hospital with syncope and was found to have a duodenal ulcer with a visible vessel treated with standard therapy. He left against medical advice and presented with recurrent melena, tachycardia, and acute anemia to our institution. Here you can see evidence of his prior therapy with one standard through-the-scope clip. The endoscopic Doppler probe was used to assess the ulcer for an arterial Doppler signal at the base. An arterial Doppler signal was confirmed on this procedure. Using a snare, the previously placed through the scope clip was removed. And this was done to allow for placement of an over-the-scope clip. Here we see the over-the-scope clip positioned on the ulcer base. The duodenal bulb ulcer is suctioned into the prongs of the clip, and the clip is deployed. In case number 3, I'll highlight the use of the over-the-scope clip as primary therapy in severe non-varicose upper GI bleeding. This is an 83-year-old man admitted with pneumonia who developed new-onset hemodynamically significant melena and hypotension after starting a blood thinner for a deep vein thrombosis. A large clot was seen and irrigated. The base of the clot was injected with diluted epinephrine, and the clot was removed with a 33mm snare to allow for treatment. A large visible vessel and the ulcer was seen. The over-the-scope clip was deployed for primary hemostasis, and hemostasis was achieved without further bleeding. Case number 4 also highlights the use of the over-the-scope clip for primary hemostasis in severe non-varicose upper GI bleeding. This is an 87-year-old man with multiple severe cardiopulmonary conditions presenting with a large pulmonary embolism started on anticoagulation with subsequent hemotemesis and large volume melanoma with hypotension. Here we see the stigmata of hemorrhage that was identified on endoscopy, a large ulcer with a visible vessel that was prone to bleeding. Here we are using the cap on the over-the-scope clip to position ourselves for deployment. Next, the ulcer base is suctioned into the cap to allow for deployment of the clip. We can see the ulcer is now surrounded by the over-the-scope clip, and successful hemostasis is achieved. Next, I'd like to discuss hemostatic powder spray TC325. The guidelines indicate that hemostatic powder spray can be used for active non-varicose upper GI bleeding, or as rescue therapy when conventional therapy fails or is not available. Other practical uses include treatment of diffuse mucosal bleeding, such as one might encounter with tumor bleeding. Hemostatic powder spray is easy to use and is very similar to a device you may already be familiar with. The first step is to activate the CO2 canister, to connect the catheter, to open the valve, and then to deploy the spray. You want to push the catheter down, aim the tip, squeeze the button, and sweep the scope to cover the areas of active bleeding. The catheter comes in a 7 French size for a standard endoscope and a 10 French size for a therapeutic endoscope. The recommendation for the use of hemostatic powder spray in the 2021 guidelines came from this non-inferiority RCT. Here, hemostatic powder spray and standard therapy with clipping or contact thermocoagulation and epinephrine are compared. The outcome of rebleeding at 30 days was looked at for non-varicose upper GI bleeding and specifically peptic ulcer disease. The threshold for statistically significant difference was 10%. Here you can see that rebleeding for non-varicose upper GI bleeding occurred in 10.2% of patients who were treated with hemostatic powder spray and 18.9% of patients treated with standard therapy. In the peptic ulcer disease group, you can see that rebleeding occurred in 12.5% of patients treated with hemostatic powder spray and 15.4% of patients treated with standard therapy. There was no statistically significant difference in the outcomes from both treatment arms. The conclusion was that TC325 hemostatic powder spray was non-inferior to standard therapy. There are still several unanswered questions with regard to hemostatic powder spray TC325, such as what is it made from, how long does the effect last, and is it necessary to do a relook after it's been deployed? I also mentioned that there are other hemostatic powder sprays under development, which may be available in a future. In this next case, we'll evaluate the use of hemostatic powder spray TC325 in active diffuse mucosal bleeding. We have a 63-year-old man with von Willebrand deficiency and a predisposition to bleeding. He has grade D esophagitis in the distal esophagus and self-discontinued PPI and was admitted with acute anemia and spitting up of blood. This is his initial endoscopy, which shows active bleeding and severe grade D esophagitis. The decision was made to use hemostatic powder spray TC325 due to the diffuse nature of his bleeding. The hemostatic powder spray was deployed along the esophagus, and following deployment, you can see there's no further active bleeding. So in conclusion, I'd like to share some take-home points. First, incorporate new GI bleeding guidelines into your practice. Second, novel devices can aid in the successful detection and treatment of GI bleeding emergencies. And finally, new technologies can be easily adopted by general gastroenterologists and trainees. Thank you.
Introducing Endorotor-powered endoscopic debridement, an evolution of necrosectomy. Endorotor is the first and only market-cleared device providing physicians the power to address challenges of endoscopic necrosectomy.
Hi, everyone. Welcome back to the afternoon session. We will have some live cases coming to you. Nikhil Kumta here, and it's my great pleasure and honor to introduce my co-moderator for this session, an accomplished endoscopist in Houston, Associate Baylor, but an equally accomplished painter, Dr. Isaac Reichman. Isaac, welcome, my friend.
Thank you. Thank you so much for having me. It's a pleasure being here. Great seeing you all.
Great seeing you. So while they're getting everything ready in the endoscopy unit, I'm going to share a quick couple of videos on therapies for Zenker, and then we'll get back over to the endo unit that I'm sure everyone wants to see some live cases. So awesome. We'll talk about different endoscopic options for Zenker's diverticulum treatment. Just a refresher for our audience, with a Zenker's diverticulum, it's a posterior diverticulum that occurs just above the cricopharyngeal muscle. And as you can see in picture C, here's the cricopharyngeal muscle, and then you have this posterior outpouching. When it gets bigger in size, or even some small ones, patients can get symptomatic. And the symptoms of Zenker's include dysphagia, regurgitation, cough, halitosis, and sometimes these patients can aspirate. Now, if they're small and asymptomatic, nothing to do, you leave them be. But if they're larger or they're symptomatic, we need to perform a cricopharyngeal myotomy. And what that entails is basically dissecting down and cutting down this muscular wall of the septum to reduce, the sort of high pressure pocket that's created. Because most of the time when we're doing these cases, what you tend to see is that because of the cricopharyngeal septum, the majority of the food contents are going to want to go into the pocket as opposed to the esophageal lumen, which tends to be quite narrow. There are a couple of different endoscopic approaches that we'll review for the next 5 to 10 minutes. We'll show some videos. And I included a picture here of the duckbill scope. This is available in Europe. And basically, it's a over-the-scope attachment that you can backload on the scope channel, and you can advance it over the scope so that the septum is wedged in between these duckbills, and that allows you to have the septum nicely lined up to perform your septotomy. So there's 2 basic endoscopic approaches that we've discussed over the past couple of days for Zenker's. One is a standard flexible endoscopic cricopharyngeal myotomy, where we just cut all the way down to the bottom of the diverticulum. And the second is utilizing POEM technique, utilizing tunneling to expose and then cut the septum. So let's see what that looks like. So here's the more standard approach that's been used. You have a patient with a large Zenker's diverticulum. And when we go down with the upper endoscope, we immediately just encounter this large diverticular pocket, and you can see that there's retained fluid in there. And you can see how tight it is to actually get down into the native esophageal lumen. And we come back and you can see there the esophagus is on the right and the Zenker's is on the left. So in this case, with the more standard fashion technique, we place a wire into the esophageal lumen. This just helps preserve our orientation. And again, the esophagus is on the right and the Zenker's is on the left. And then we're using, in this case, a scissors type of electrosurgical knife called the SB knife or stag beetle knife. And this enables us to cut right down on the septum here. The outer edges of the knife do not conduct electricity, so it is somewhat insulated. And there you can see we're starting to expose that cricopharyngeal muscle that's causing the patient's symptoms. So we then just work our way down to the bottom of the septum. And it's very important to know your measurements with this technique, because if you cut too far, you run the risk of having a perforation. So this knife is rotatable, as you saw there, and we can use it in a very quick manner to dissect all the way to the base of the diverticulum. Now, there is some debate with this technique whether or not you place a clip at the bottom of your muscular division just to reduce the risk of a perforation. I do tend to place a clip there just so that I can minimize any potential chance of a perforation with this technique. So once we make this last cut, we'll have completely dissected the muscular septum, and you'll see how there's really not much of a significant pocket that's left And now the esophagus is much more easy for food and other contents to go down. So here we place a clip right down at the bottom. And then this patient we admit for observation and did quite well, had no additional symptoms once they recovered from this procedure. So the next technique that we review is utilizing same disease process, the Zenker's diverticulum, but utilizing a tunneling technique with POEM. And with this technique, here's the esophagus, there's the diverticulum. What we do is we start by making a submucosal bleb just at the base of the septum. Sometimes you can do it on the septum itself. And for this, we're utilizing normal saline with methylene blue. And here we're making a mucosal incision. We're extending it towards over the top of the septum. And the goal here is to tunnel on either side of the cricopharyngeal muscle. So we're going to tunnel on both the diverticular side and on the esophageal side to expose that muscular septum. And then within the tunnel, we'll be able to then perform our cricopharyngeal myotomy. The nice thing about the tunneled approach here is that we can cut all the way down to the base of the muscle. And if we cut a little bit too far, it's okay because we have the tunnel protecting us, and we close the mucosotomy of the tunnel with clips at the end. So here we're now dissecting on the esophageal side. You can see the muscle, cricopharyngeal muscle up at 11. And we're just exposing these fibers, dissecting in the submucosal plane. Sometimes a tapered cap can be used here, but not always. And there you can see we've divided on both sides. Here's the diverticular side, and then on the right is the esophageal side. So now we're ready to do the myotomy. And so we dissect all the way down. Again, we can be pretty aggressive with the how far down we go, given that this is a tunneled approach. The standard approach that I showed you in the last video probably takes about 15 to 20 minutes to do. With the Z-POEM approach, it takes a little bit longer, probably closer to 40 or 45 minutes to perform this procedure. In some instances where there's a very large diverticulum with the tunneled approach, you may have a mucosal flap that persists after you close with clips. And sometimes you have to bring them back and dissect that mucosal flap so they don't have a retained pocket. So we're just finishing up the myotomy here. And then once that division is complete that you can see there, that's just the esophageal normal muscle that we see. So we don't need to cut down significantly further. So now we'll close this with clips. My personal preference is to use the short stem or short tail clips and just close it in a zipper fashion from a distal to proximal approach. Isaac, do you have any tips for our audience members? And in the interim, I'll also ask that if you have any questions, feel free to put them in the chat box. But what are your thoughts on those techniques, and what's your personal approach?
Yeah, I like those techniques. My personal approach is for the last 25 years, I've been doing the same procedure, which is I use a needle knife. And then I cut to the base of the septum, and that's it. Sometimes I use a covered tip knife, an insulated tip, but most of the time I use a standard biliary needle knife. There are times when you have to, depending on how the anatomy of the patient is, you cut from the esophageal lumen towards the diverticulum or vice versa. And there is no one way or the other is better. You just have to choose the one that is safest at the moment of the patient. And there are times when a wire kind of backfires because it pushes the septum too far down. So sometimes you can do it without the wire. And I do like to place clips afterwards. Just because I don't know if the patient is going to have hacking or something that is going to increase the local pressure and cause problems. And one must do is that this procedure has to be done under CO2. Never do it on, with room air endoscopy. At least in my experience using the needle knife, as I mentioned, 97% success rate, 3% possibility of recurrence within a year. So it's very safe. And I don't routinely admit patients to the hospital. Yeah.
Yeah, those are all great points, Isaac. I think the other important thing in addition to CO2 is that these patients should be intubated.
Yes.
You're working very high up in the proximal esophagus, and especially if you're using a tunnel technique or even with the standard technique, if you have any bleeding, you don't want to have any aspiration. Oftentimes they'll have residual fluid, as you saw in that pocket, that once they go under, if their airway is not protected, they can have an aspiration event. So those are all really excellent points that you make. Even historically, they used to use NG tubes down in the esophagus, and that would really, push the esophagus and alter the anatomy in terms of the septum. So, sometimes the wire is used, but is not always necessary, as you alluded to. I think the other important point is scope stability in terms of determining the direction of which way you're going to cut, either towards the diverticulum or towards the esophagus. So you really want to make sure that you have a stable scope position, and you want to have control when you're doing your dissection, regardless of the approach that you take. Remember, if you cut through the diverticulum, you've got a free, perforation. If you cut through on the esophageal side, you have more ability for closure. So I prefer to try to tend to work towards the esophagus if possible. But again, it depends on scope stability and how much control I have.
The other thing is it all depends on how the septum looks, because not all the septa are the same. Sometimes they come in odd shapes, pulling more on one side than the other. So when the exposure of the septum is not great, one of the things that I like to do is actually, before I start cutting, I will put a clip, and I also use a short stem clip. I will put a clip on one side and a clip on the other side, and then I will make my incision in the middle, in between the two clips. So that ensures stability of the septum as it separates, and then you can cut all the way down and then clip the end.
And that's a neat tip. I hadn't heard of that before.
It works well.
Thank you for that. All right, Isaac. So you ready for some live cases?
We're ready for some live cases.
All right. So we're gonna turn it over to our team at Robert Wood Johnson. If we can pull up the case introduction slide, please. And again, for those that are watching on YouTube, you can write in the chat for any questions or in the WhatsApp chat as well. So let's head over to Robert Wood Johnson, please, for the live case.
All right. Good afternoon, everyone. Welcome back to Robert Wood Johnson. We're going to be starting our live cases. The first case that we are going to do is in room 1, where you would have Dr. Sarkar and Dr. Shahid. We have a 39-year-old female patient who had a history of gastroesophageal reflux disease, hyperlipidemia, and morbid obesity. Initially, she was seen in the clinic and definitely trialed on various support groups, dietary changes, assistance with medications to reduce her weight, especially in the context of her significant hyperlipidemia and acid reflux disease. But all of these efforts were without success. All of the options were discussed with her, and she did not want to pursue any surgical intervention. So finally, patient wants to pursue upper GI endoscopy with endoscopic sleeve gastroplasty, or ESG, and that's what we would be performing in room 1.
Hey, hi everyone. Can you hear me okay?
We can hear you, Alec.
Yep. Great. So thank you everyone for being with us this afternoon. We apologize for some of the technical difficulties we had in the morning, but we're glad to have been able to sort that out and do some live cases with you guys this afternoon. So as you heard from the presentation today, first case for the afternoon is going to be endoscopic sleeve gastroplasty. We'll just introduce our excellent team in the room today. I have Tim here, our CRNA, with Dr. Kohlmeyer, our anesthesiologist. We also have Catherine and Kelly helping us, and to my left here I have my partner Haroon Shahid. So the first thing I'm going to do for this patient before we start the procedure is I'm just doing a diagnostic endoscopy to make sure I'm not catching any contraindications to the endoscopic sleeve procedure. So, things that I'm looking for is, any significant gastritis, any ulcers, any large polyps, any kind of acute pathology that I'd be worried about. I'm also looking to see if there's going to be a large hiatal hernia that would prevent me from doing the endoscopic sleeve procedure. And so far, things look okay. I am using a Pentax upper endoscopy scope, and I'm just cycling through some of the modes here. And so far, things look great. The upper exam is normal, and I'm not seeing any contraindications to our procedure. So I'm going to slowly withdraw my scope and come out, and then we'll switch over to our double channel scope and get the procedure started. For this patient, we have a history that's pretty common for a lot of the patients that I see for this procedure. She has been trying to lose weight through conventional methods for many years with diet and lifestyle type changes. And, she was probably, I think, her baseline weight is around 160 pounds. And then she had some kids, and her weight increased to 200 to 210 pounds. She went on several diets and lifestyle modifications, saw dietitians, nutritionists, worked with her primary care doctor, and she was able to lose 10, 15 pounds, but within the course of a few months, she regained the weight that she lost. So we see this very often in our patient population, and don't get me wrong, the diet and lifestyle changes are the key to sustained weight loss for patients. But, for whatever reason, we have kind of counter-regulatory measures in our body that when we lose weight, the body is kind of fighting against us with the weight loss and kind of working against us, and patients tend to regain weight. And there's several studies showing that it's very difficult to maintain a weight loss, and only about 5% of patients can maintain a weight loss of 10% or greater 1 year or more out from their dietary attempts. So, I'm a big believer now in helping patients with whether it's procedural interventions or medication interventions to kind of get them over that hump while kind of keeping their dietary and lifestyle changes intact. And I feel like that'll give them a more successful, sustained weight loss. So,
that's a great point that you mentioned. There's a number of FDA-approved weight loss medications right now for the treatment of obesity. I guess two questions for you. One, how long do you typically wait after meeting these patients? Do you typically wait before doing this procedure? With bariatric surgery, they have a pretty strict 6-month criteria, although in endoscopic bariatric therapy, it may not be as stringent. And then secondly, there was a New England Journal article earlier this year that looked at once weekly administration of a GLP-1 receptor agonist that had really outstanding weight loss results. So do you have them also see someone for medical therapy before you consider EBT, or do you do it in combination and tandem?
Yeah, great question. So, typically when I see a patient, I kind of take a pretty good detailed history. I usually spend anywhere from 45 minutes to an hour with them on their first visit. And I'll really try to get down to what they've tried to lose the weight so far. And if I feel like they've made a concerted effort to lose the weight, then I don't really have them do anything extra. But if I've talked to them and I feel like they have not given diet and lifestyle changes a good enough shot, I usually wait about 3 months. I have them see a nutritionist or a dietitian. I have them work with their primary care doctor, and also start an exercise program, because it's very hard for us to just do a procedure and then expect patients to be able to adhere to the dietary and lifestyle changes right after the procedure unless they're used to that. And so I want to see that they've at least attempted a 3-month trial, getting used to the lifestyle, getting used to the dietary changes, getting used to the small meal portions, getting used to eating lower calorie meals, getting used to an exercise program. So if they've shown me that they've done that, then I don't usually have them do anything extra. But if I'm not convinced, then I do usually wait 3 months to make sure that they can follow the post-procedural recommendations. With regard to the medications, yeah, there's some outstanding medications that have come out, recently in the last couple of years, and there's even, better, more effective medications down the pipeline. And so I fully disclose that to patients, and I tell them, these are the options. We can do medications, we can do procedures that are minimally invasive without scars or incisions through endoscopy. And I kind of go through with them the risks and the benefits of each approach. And I really try to get down to their goal. I mean, some patients just want to be healthier. They don't necessarily want to lose 100 pounds, but they want to lose, 40, 50 pounds just to be healthier. And other patients, want to lose that 100 pounds. So in those patients, I may consider a combination approach with medication plus an endoscopic bariatric procedure if they don't want a surgery. And in patients who just want to be healthier or not so inclined to lose as much weight as possible, then I'll usually offer them both approaches. If they prefer to try the medications first, we go that route. If they prefer to do the procedure first, we go that route. And then usually I'll reassess at the 6-month mark. If they've not reached their weight loss goals, then we'll talk about alternate options. So before we get started, I just want to kind of go over the Apollo overstitch device, which I have here loaded onto my double channel endoscope. This is actually, I think, one of the best innovations we've had in endoscopy. This device also has been an amazing innovation for endoscopic bariatric procedures. And it's really allowed us to reach patients who we've not adequately treated in the past. Obviously, bariatric surgery has been there for several decades, but despite that, only about 1% of patients who are eligible to have a surgery go on to have a bariatric surgery. So by having this option available to patients where we have a minimally invasive endoscopic weight loss approach, we've seen many more patients willing to undergo procedural weight loss. So right here, attached to my my shaft here, I have the needle driver handle, and I can open and close this. And as I'm opening and closing this, if you look at the tip of my scope, if you can raise the camera. Yep, that's good. If you look, Haroon, do you mind holding this? Yep. If you look at the tip of the scope, if I close the handle, my needle driver closes. If I open the handle, the needle driver opens. The suture is already loaded here to the a silver anchor. It's a metal anchor at the tip that's holding the needle, and then on the other end here, which is attached to this this catheter here, I have an anchor exchanger that I'm pushing out of the scope now. So what happens here is as I close my needle driver handle, I can push out my anchor exchange catheter and pull it off, and you can see the suture has now come off my needle here, and it's solely on my anchor here. It's a little hard to see, I think.
It's a little blue, yeah. It's zoomed in on your hands. What's that? Is that better?
Yeah, so you can see that the suture is now here on the anchor exchange catheter. So now I'm going to load the suture back onto my needle driver, and here you can see, again, it's a little bit difficult to see, I think, but the suture is back on my needle driver here.
If we can get an endo view as well, that might be helpful.
Yeah, so I'll go ahead and introduce this now into the patient.
So, Avi, you've been doing this for a little while, doing endoscopic bariatric therapies. There's a certain patient population that you want to select for this. What are the indications, or what is the patient population you would generally choose for endoscopic sleeve gastroplasty? And then what do you do about patients that maybe don't meet that criteria and have potentially higher BMI that don't want to undergo surgery and still want to get this procedure? What is the data regarding that?
Yeah, that's again a great question. I think this procedure is relatively new. It's been around for about 10 years or so, and I think initially when this procedure was started, not getting insufflation here. Initially when this procedure was started, our goal was kind of to target patients between a BMI of 30 and 40. But I think as the procedure has become more well known, and we've had interest from patients who are outside of those BMI targets, I think we've started doing patients who have higher BMIs, and we've realized that it can be just as effective in making those patients healthier. And so although, traditionally the recommendation is, or the preference has been to do patients with a BMI between 30 and 40, we have been doing patients a little bit higher BMI, but we kind of always discuss with them that, the procedure is meant to make them healthier with higher BMI targets. And we usually get about a 20% total body weight loss with this procedure. And it's been shown in studies to have durability. The longest study we have is about 5 years, and the results have shown to be durable. So I'm here getting started.
Quick question, Isaac here. Hi to everyone.
How are you?
Good. How are you?
Good.
Any comments on marking with argon plasma coagulation?
Yes, that's a great question. So this procedure, again, is done several different ways and with several different techniques. And I think one of the first things you'll notice is I'm not using an overtube, and I know many endoscopists for this procedure will use an overtube. I used to use an overtube, but I think more recently in the last year I've not used it. I think the overtube is helpful because sometimes you're coming in and out of the patient to clean your scope. The procedure can get a little bloody at times, but I've been able to safely do this without the overtube, and I think I just feel more comfortable without it, so I don't use that. Marking is something I used to also do initially, but again, over the last year or two, I've stopped marking. I think when you're starting this procedure, marking is helpful to give you some kind of ideas of where to place your sutures. But as I saw that I was marking, as you kind of do your first few sutures, the marks that you placed move because, you're kind of shortening the stomach both in length and in width. And so the initial marks are not really where I plan to suture. And so I've kind of over the years gotten a good spatial orientation. So I kind of just start with my suturing, and then as I go, I kind of know where to place the following sutures, and I'll kind of demonstrate that.
Yeah. Do you think that there is any value of not just for marking, but also to the nude mucosa? So then the nuded mucosa to the nuded mucosa will sort of seal and retain the placation longer?
Yeah, that's another great point. So in this procedure, we are going to be using full thickness sutures, and as we tighten the sutures, we get mucosa to mucosa contact. And if you stick mucosa to mucosa together, they usually will not stick unless there's some sort of injury, and as it heals kind of stuck together through fibrosis and scar tissue. So I think if you're going to be doing APC for that indication, you really need to do very deep lines of APC, not just marks, to really get that effect. And I think, there's also been some literature out there of doing EMRs of several areas of the gastric body first, and then doing your sleeve. And I think that makes sense because you're really getting good apposition of tissue, and as it heals, it'll really heal well in that configuration. The other thing we kind of lean towards is serosa to serosa contact with this procedure. So although mucosa to mucosa contact may not, stick that well, the serosa to serosa contact should, cause some bridging and fibrosis a little bit better. So APC, I think, for that indication is definitely reasonable, but I would recommend if you're going to do it for that purpose, you really need several lines of APC, and it has to be really deep APC lines, not just APC spots for marking. So I'm going to get started here. So I usually start here at the incisura you see here. This is the antrum. So we don't really go in the antrum with our sutures. We start right here at the incisura along the anterior wall, and then I kind of come down the body, and I end up here back at the posterior wall. And then we usually do a U shape. So as I come down, I'm going to step back and then go back up, and then I drop the anchor, and then you're going to see I'm going to use a cinch to tighten it. And by doing this, I can shorten the stomach both in length and in width. And we're going to do several of these patterns coming all the way up the gastric body. And we usually stop right here, right at the GE junction in the cardia area. We do not try to retroflex to go into the fundus, and we'll discuss some of the reasons for that in a bit. So I'm going to get started. I have Kelly here doing the tissue helix here, which is coming out of my other channel, and it's kind of like a corkscrew. And I'm going to put this out into the mucosa, and Kelly's going to give me about 3 twists. And by doing this, we're going to corkscrew through the mucosa, through the submucosa, and hope to capture the muscularis propria. Once that's captured, I'm going to kind of pull that back into the towers of the overstitch device, and then I'm going to try to deploy my suture so that I can get a good full thickness bite. So, Kelly, you can push that in for a minute.
Avik, on average, how many bites are you taking per suture that's used?
Go ahead. So, on average, it's about anywhere from 6 to 10 bites that I'll take. So, this is an important kind of thing here. As you saw, Kelly was corkscrewing this device in. You saw the whole mucosa kind of twist. And that's what I want to see. And that, to me, is a good indicator that we've captured the muscle. I'm going to try to pull this back a little more into the towers more fully. I'm going to suction down a little bit, suction down a little bit more. And I want to try to, as best I can, to get a pink out. And that, again, ensures a good full thickness bite. Go ahead, undo. And you see I've gotten this pink out here. And so I'm pretty happy with this bite. So I'm going to back away a little bit. I'm going to give myself some slack.
Nikhil and Isaac, when you're doing, just for, my information, do you tend to mark before you're doing sleeves, and do you use an overtube? My practice is that I do still do it, although I have not done as many as Dr. Sarkar has. What is your experience?
Yeah, so my experience is I do not use the overtube. And I do like to mark, but as was mentioned, I don't mark just for guidance. I mark for mucosa to mucosa adherence. So it's a fairly deep mark. And then one thing that I do like to do is create a very long central along the greater curvature line that reminds me where my middle line is. And that's just my personal preference, and that's how I do it.
I also do not use an overtube, and I still, however, do use markings. I don't follow them very specifically because, as Avik mentioned, the anatomy and the planes may change. But just for reference, just so I make sure I don't close it too tight or leave it too open. I don't. There has been data more in animal studies about use of gastric mucosa denuding with APC and that leading to fibrosis and scarring that leads to weight loss. But it's probably quite a bit of gastric mucosa that you have to denude to have a sustained, scar down fibrotic effect. It's funny. I'm having flashbacks. I think Kelly and I were part of one of probably the first gastroplasty in New York City almost 10 years ago now. And, I'm reminiscing about that case, seeing her working with you. And, for reference, that case took us about 6 or 7 hours to do in the operating room. Now, this is a routine outpatient procedure that gets done in about, 40, 45 minutes or so. So it's really remarkable just to see the evolution of this technique, over the years.
Mm-hmm. Any specific liking to a U pattern versus an X pattern?
Yeah, again, I think there's obviously different techniques and different ways that have come out to do this procedure. Go ahead. I think the most crucial part is obviously to make sure you're full thickness and getting good bites, trying to get that pink out with each bite. I'm not, sure that the pattern you use is as important as just getting these full thickness bites. I tend to use the U just because that's what I've trained on and that's what I've been doing and I've had good results with. But what kind of patterns do you guys use?
I also use the U pattern. There was a study that was published 2 years ago in Endoscopy International Open that looked at different suture patterns, and they really did not find any significant difference between the suture patterns in terms of weight loss. So I personally prefer the U pattern. I think the other important thing that needs to be mentioned for those watching this case is that there was really a landmark study that was published just about a month ago in The Lancet, which was a multi-center randomized trial utilizing gastroplasty for treatment of class 1 and 2 obesity. And this was the MERIT trial, which was led by Barham Abudai out of Mayo Clinic and involved, I believe, 9 centers around the U.S. And they actually, this was level 1 evidence, so they randomized patients to ESG versus lifestyle, and I think they had the ability to cross over, later on. But they had outstanding results that ESG, at 52 weeks had excess weight loss close to 50% versus just 3% in the control group, and similar types of efficacy with respect to total body weight loss, which was about 14% for the ESG group versus 0.8% for the control group. And as we know with this procedure, there are significant improvements in the metabolic comorbidities. So that was really an outstanding trial. I give them a lot of credit to do a proper randomized controlled trial that really gave us great evidence to support the use of gastroplasty.
Yeah, that's, honestly, that's what I think we've all been waiting for. There's several studies that have been done in a retrospective fashion. And one of the challenges with this procedure is getting insurance authorization. And so to have a randomized controlled trial that's come out, I think is a big step in the right direction. And, I think as a result of that trial, the Apollo has now received FDA authorization to market this device for endoscopic weight loss, which I think is huge because now this can lead to increased awareness for patients for this procedure as well as for our referring doctors for this procedure.
Absolutely. Going back to the pattern of the X and the U, there have been several reports favoring one over the other, but I think that we all tend to follow the one that we feel the most comfortable with. And for the most part, at the very end, on the last row of our gastroplasty, we tend to freelance it quite a bit. Yeah. They would try to follow a pattern, but we tend to do some freelancing.
Exactly. So I've just completed my first suture U pattern, and you can see that the tissue has come in together nicely. I'm just checking here to make sure my outlet is still okay and open, and you can see that it is. And so it takes probably about 2 or 3 sutures before you really start to see the sleeve forming. But I think, the first 2 sutures are really crucial to kind of set you up well for the rest of the procedure.
In your practice, how often are you doing just one row of sutures versus doing a row of reinforcement sutures as well?
Yeah, so that's another, I think, technical difference that some endoscopists have. Some endoscopists tend to do a second row or a reinforcement layer of sutures. So I found that, I was kind of doing my first row fairly close together and fairly tightly, and I didn't really have much space for a second row. So I don't really do a second row, but I do know that is something that other endoscopists do.
Isaac and Nikhil, do you do reinforcement sutures?
I do exactly the same thing that we're watching now. This is the exact same thing that I will do.
Yeah, I agree. If you have a tight first layer, you don't always need the second layer. If I think that I have more room to close down, then I will do a reinforcement layer.
Yeah.
It's also, I think, very important to underscore that not only are we reducing the the diameter of the stomach, but on the second half of each of these sutures, you're actually coming back more proximal. You're reducing the length of the stomach as well. So ideally, the goal here is to try to reduce the stomach's overall volume by probably about 60% or so. There is variability. The way Avik suture is probably different than the way Haroon suture is and the way that I suture you. So there is, an endoscopic variability just depending on who the practitioner is. But the goal here is to reduce not only the diameter but the length.
Yeah, and I think the U pattern or the Z pattern, just having kind of 2 rows allows for that shortening. If you're just doing single rows, you're not going to get as much shortening as if you're doing 2 rows before you do your cinch.
For sure. The other thing that's important is when we're creating the gastroplasty is not to leave pockets behind. Mm-hmm. There is that possibility that you're bringing a lot of tissue proximally, but you're not really bringing the greater curvature in, so you leave pockets. It's a must avoid.
So I'm going to, I guess, play devil's advocate there, Andu. I think we've learned that this procedure obviously is a restrictive procedure. It makes your stomach smaller, and so you're able to take in less. But, we've seen from studies and also from my personal experience, sometimes I'll scope these patients again in 6 months or 12 months for whatever reason. And, despite, the initial sleeve looking good, when you go back in, you'll see, mucosal bridging, you'll see some pockets, some gaps, yet the patients have still lost 20% of their weight and maintained that. So, some other studies have shown that these pockets may be beneficial because they can cause some delayed gastric emptying, and you're able to lose weight not just from the restriction from the procedure, but also due to hormonal changes that the procedure produces, as well as delay in gastric emptying that may be influenced by some of these pockets that are present. There's also studies showing that ghrelin after the procedure decreases, although we've not really resected any sort of tissue that you may get with a surgical sleeve. Studies have shown that ghrelin does decrease, and I think part of that is, and we'll get to, is a technical aspect where we leave the fundus open. So, because the body is so narrow, food will tend to kind of sit in the fundus and give you that sense of satiety.
Yeah. I'm not sure how to test whether the pockets are influencing the outcome of the patient as much as the actual suturing and the reduction of the width and the length. I personally try to avoid the pockets more so for the simple fact of food entrapment, because then people will come. Remember what used to happen with stents, right? Where food will get stuck alongside the stent and patients will complain of various symptoms. So that's to me the main reason to avoid the pockets.
No, I agree. I think obviously when you were doing the initial procedure, we try to avoid the pockets, but at least from experience, when I go back for a few patients that I have, 6 months or 12 months down the road, there invariably are those pockets.
Yeah.
We mentioned earlier that Apollo has received FDA clearance to market this for sleeve gastroplasty, but it still is not something that routinely is covered by insurance. What are you guys seeing in your practice? Are you able to get this covered by insurance? What process is involved? Do they have to trial medications first? Do they need to undergo any other form of therapy? Or are you just seeing patients that want to pay cash and get this procedure done?
The latter. We just have patients that want to get it done. They're desperate to have something done. They have tried multiple things. They don't want to have surgery. And some patients actually know about pharmacologic therapy, but they don't want it.
Yeah.
You know, you probably are seeing this tendency among patients that they just don't want pharma, not just specific for obesity, but for multiple other things. So, they're willing to pay out of pocket. So that's what we do.
Nikhil, are you saying the same thing in New York?
Yeah, I, more recently have had some success with insurance approval for endoscopic bariatric therapies with the balloon and with gastroplasty. We don't offer, just for completeness sake of ET, we don't, there is a feeding tube, or not feeding tube, but a drainage tube, the aspiration therapy that is FDA approved as well. But in New York City, we don't have a clamoring of patients that are keen on aspiration therapy. I think the reason for that is, when you eat, you have to go to the bathroom 20 or 30 minutes later, and it's just not feasible for a lot of folks in the city. But with respect to your question with insurance, we are getting some coverage, but predominant driver is patients that are paying out of pocket. I will say that it is quite an exhaustive process to get insurance approval for balloons or for ESG. It involves an extensive amount of documentation. There's oftentimes a denial, and then my team will appeal it. And sometimes that appeal goes all the way up to the New York State Department of Health, and then you get an external reviewer. And so typically we will ask for an expert reviewer to be an advanced endoscopist or someone with experience in bariatric endoscopy to be able to make a decision. But it is quite an onerous and exhaustive process for insurance approval. So like Isaac, I would say the majority of my cases are out of pocket. Patients don't want to wait that long if they can afford it. The problem is that despite all the good data that we talked about, it creates a two-tier system of patients that can afford it right now and patients that can't. My hope is that in the coming years, especially as we get, good 5-year data that Reem is publishing and even beyond, and we start to have more widespread adoption of this technique, this is a great treatment for early obesity. And there's, as Alec mentioned, you have 99% of people that are eligible for bariatric surgery where it's covered by insurance are not even getting it done. So we certainly have an opportunity here to provide a minimally invasive endoscopic therapy. We know that obesity is an epidemic and will only continue to rise in the coming years, both in the United States and globally.
Yeah. There are services that offer payment plans. So we try to accommodate that for all patients. So there are some that paying out of pocket may not be too difficult.
Yeah.
And then there are some others that are willing to take the chance of planned payment, and then do it.
Avik, our experience here maybe is a little bit different. You want to talk about, getting insurance coverage here?
Go ahead. No, I think it's fairly similar to what Nikhil mentioned. It is painful to get insurance coverage for this procedure. It requires a lot of documentation, a lot of manpower to send the documentation, follow up with the insurance company, do an appeal, do a peer-to-peer, and sometimes doing 2 or 3 peer-to-peers. So, I think we're probably around maybe 20 to 25% success with insurance. And I think it's fair to say more recently we have had more success, and I'm hoping that's because of the MERIT trial. But I think the majority of patients who want this procedure are the patients that will pay cash for it.
Yeah.
So we've been talking, Alec, about primary endoscopic therapy while you've been doing a great job suturing. Can you also talk about some of the options for secondary bariatric therapy in a patient that may have had a prior Roux-en-Y gastric bypass and then has regained weight, or a prior surgical sleeve that has regained weight? What are some of the endoscopic bariatric treatment options that you can offer to those patients for secondary therapy of obesity?
Yeah, absolutely. So we using this same Apollo Oversitch system, we can do revisional therapy. So for patients who've had sleeve gastrectomies, over time, over the years, the sleeve can start to dilate out. So in the same way that we're doing this primary weight loss procedure, we can do a similar type of procedure to kind of retighten the surgical sleeve. It's not this exact same procedure because the stomach is obviously much smaller. But we kind of achieve the same outcome, and our goal is to kind of make the sleeve back to the size that it was after the initial surgery. And then for Roux-en-Y gastric bypass patients who have regained weight, typically it's their stoma that's become dilated, and using this device again in a procedure called TORI, or transoral outlet reduction, we're able to reduce the size of the stoma back down to what it should be.
And these are patients that surgeons don't want to reoperate if they can avoid it.
Oh, yes.
So this is an excellent opportunity for us to be involved in that process. We have a question from the audience. For someone that doesn't have experience with endoscopic suturing, what is the learning curve? What advice would you give to someone that is looking to get into the bariatric space? Haroon, do you have any advice? And we'll kind of go around the panel. Isaac and Avik, your thoughts as well on that question.
I mean, I think you need to be trained well in endoscopic suturing and how to deal with any issues with the device itself. And I think all of us here, at least on the panel, are advanced endoscopists and have gone through a 4th year of training where we were trained in endosuturing. But there are some bariatric endoscopy fellowships around the country as well that don't necessarily require a separate 4th year. I think it's very important to gain that knowledge to know how to troubleshoot a lot of issues that may come up with the device itself. So I think having that year is definitely very beneficial. I know there's courses that are available where you can go and kind of play with the endosuturing device and ex vivo and maybe even in animal models. But you need a lot of experience, and I think going through an extra year was definitely beneficial. I don't know how you guys feel about that.
Yeah, I think definitely the extra year gives you an added level of comfort because you've seen the device a lot, you've used the device a lot, you've known how to troubleshoot the device, and I think there's a lot that goes into that. I'd say before starting endobariatric cases, I think probably 25 to 50 suturing cases is required just to kind of get comfortable with the device and understand the nuances of the device and learning how to troubleshoot the device. And after you're comfortable with the device, that's when I would recommend getting started with endobariatric procedures.
I agree. And also you can see all the, watching you doing the procedure, there are multiple times during the procedure that you move your body, right?
Yes,
in order
absolutely.
to get the proper rotation and the proper accommodation in the lumen. And oftentimes that is difficult to teach as to how to keep the spatial orientation within the stomach. And that's where having a good knowledge of the tool that you're using and then concentrate on maintenance of the lumen and figuring out that spatial space is so important.
Yes, for example, on my last bite that I just took, I was having a little bit of difficulty lining up the needle driver to the anchor exchange catheter. And so that's a tactile sensation that you need to feel.
Yeah.
So I was able to kind of adjust my body a little bit to get that feel and then do the transfer appropriately.
Yeah, sometimes if there is too much tension on the suture, it will deviate the alignment. And now what you're doing there is interesting because I have had experience teaching this when the fellow will pull so hard on the suture.
Right. So exactly. So
that goes your entire suturing.
Yes. So I usually will tighten it until I see a bend in the catheter, and then I'll actually let the suture go a little bit as Kelly is cinching it, and that way I can make sure the suture is not too tight. I think you guys can also let me know your experience. I've noticed that if you make the suture too tight, it's more likely to have kind of a cheese wire effect eventually, where the suture will slowly start to kind of pull through all the tissue, and maybe when you come back in 6 months or 12 months, you'll see that the suture is still in place, but it's kind of come and pulled through the tissue.
Yeah, I personally do the same thing. Once the suture bows and the suture feels like a guitar string sort of feel, that's when I release it.
Yeah, I also, when I'm cinching, I like to tap on the suction and decompress the wall tension for my insufflation, just to get a little bit of better tissue capture. But I agree, once you start to see that cinch catheter bend, you probably have to readjust the amount that you're pulling with. The last thing you want to do after you're taking anywhere from 6 to 10 bites is have that suture limb break, and then it unfolds. The other point that I will make with respect to suturing is that you're doing this with the overstitch device. So this is a 2O polypropylene suture. The through the scope device, which is the XTAC, that is a 3O suture. That is a thinner suture. So if you try to pull with the same amount of tension for the XTAC as you are with the overstitch, you have a higher likelihood of breaking the suture. It looks like here you're trying to get the helix off.
So this is a good learning point here. So we've put the helix in. I've gone with my suture, and you can see the suture's in place, but the helix is having a difficult time coming out from the tissue. And so Kelly and I were kind of silently working there, but I was trying to give her the visualization that she needs to kind of learn which way she has to rotate to get it free from the tissue. And so eventually we were able to do that.
Yeah, they're making it look very easy, but when you run into those issues, at least for the people watching, it can be very difficult. And you don't want to tear through the tissue. Oftentimes when it gets caught like that, it's in the muscle layer, and you don't want to pull too hard and potentially cause a perforation.
Yeah, the helix is the most dangerous aspect of this device because that's what can, perforate through and cause injury to surrounding organs. When that sometimes happens, when I'm doing a case, sometimes I'll take the tissue helix out and clean it, because if you have tissue that's embedded within the helix, it can just get rotated into the tissue, and then it won't be able to free the device very well. So sometimes if you notice that's happening repetitively, take the helix out, clean it, get all that extra tissue out that may be getting stuck. We have another question from the audience, Avik, about post-procedure management. What do you tell these patients to expect? What's the diet? Walk us through the conversation that you have about post-procedure management.
Yeah, that's also a very, very important discussion to have with the patients, because you do not want them to get surprised after the procedure about the way they'll be feeling. So I usually tell them they will have some discomfort after the procedure. The discomfort, I say, is going to be kind of like a cramping discomfort. It can be severe at times, but we make sure to give them medications initially in the post-op area, and then also when they go home. So if they're having pain in the post-op area, I usually like to give them an anti-inflammatory medication of some sort. I think most of the time we end up using Toradol. And then if they need something additional, I'll give them a mild narcotic medication. And then we send them home with liquid Tylenol with codeine. And I also tell them to expect to be nauseous after the procedure and dry heaving sometimes. But we try to limit that by giving them a scopolamine patch. Oops, we lost that. Pull it in. Scopolamine patch. And then we also use Emend, which is aprepitant. It's a strong antiemetic, as well as Zofran. So we want to make sure they're getting several antiemetics to limit the amount of vomiting or dry heaving they're having, because, again, we just did this procedure and we don't want them to have any of the sutures get dislodged. I tell them they may get some gas pains, some bloating, some constipation, and we want to make sure that they get medications to help them manage that. Symptoms post-procedure typically last for 3 to 5 days, and then they start to get better. We do have them stick to some form of a liquid diet for about 2 weeks post-procedure. Usually I'll do clear liquids for 3 days, followed by full liquids for about the duration of the remaining 2 weeks. And then for the 3rd and 4th weeks after the procedure, I will have them do kind of a soft or a pureed diet. And then after the first month, I usually have them kind of restart normal consistency foods, but we want to make sure they're doing small portions throughout the day. I usually have them stick to about 4-ounce portions and have them eat every 2 to 3 hours or so. And we have them continue to follow with a nutritionist to make sure they're getting their appropriate caloric intake, protein intake, fat intake, vitamin and mineral intake.
We do the same thing.
Earlier we mentioned that, there's obviously risks like a perforation during the procedure. It is a relatively safe procedure, but what are some of the risks that, the patient should be informed about before performing this procedure?
Yeah, there's been, several studies looking at this and showing this is a very, very safe procedure. Do some more, Kelly, here. So I believe the major complication risk for this procedure is about 1%. So again, it's very safe. Most of the side effects that we see, again, are within the first 3 to 5 days, and those are the accommodative symptoms that I was mentioning, a little bit of abdominal discomfort, some nausea, possibly some constipation, bloating. But the major risks are very, very low with this procedure. It's about 1%. They do include some reports of bleeding, some reports of perforation, some reports of fluid collections forming, but again, very safe procedure.
You did mention...
Just as a comment, been doing this for a long, long time, and I just, for the very first time, recently I had a patient that on the 11th day after ESG, she presented with acute dyspnea, and she was diagnosed with a subtle embolus of the lung and required immediate intervention and full anticoagulation.
Wow.
And not to relate the complication of the emboli to the ESG, but it happened within 11 days. So just something to consider, since obesity has a 2.5-fold increase of blood clots compared to general population.
Yeah, absolutely, and I'm sure maybe post-procedure these patients are not the most mobile. They may be in bed a little bit longer, so it's definitely important to have them stay as active as possible after the procedure to hopefully reduce that risk of blood clots.
Yeah.
What about advice on women of childbearing age and pregnancy?
Yeah, that's funny. Abed is around here somewhere, but he was telling me that he recently did a sleeve on a patient, and I think within 3 months she got pregnant. So I think, I would tell them just to avoid getting pregnant within a month of the procedure. Obviously, we want to make sure they can maintain their nutrition before they get pregnant, and I think the first month it sometimes is difficult to do that. But after the first month, and I think they would be able to maintain their nutrition adequately, and I think it should be safe for them to try to be pregnant. Obviously, also it brings up the question, they're going to gain some weight when they're pregnant. So what is that going to do to the sleeve? And I don't know if there's enough data to suggest what happens in that scenario, but at least from a safety standpoint, I think it's safe for them to become pregnant within after a month from the procedure.
Yeah, I would probably advise 3 months just to get over the first trimester, because that's when most of the symptoms will occur, especially nausea, vomiting. And they're already nauseated when we do this procedure, and then just to add fuel to the fire.
Yeah, I'm probably a little bit more conservative. I actually advise more in the 3 to 6 month range. I think with the hormonal changes and the weight gain with pregnancy, to me it doesn't make sense to do the gastroplasty so close if there's an anticipated conception. I think that it's also tough to know how those patients are going to do I like to generally have a goal for my patients to achieve 10% total body weight loss by the first 3 months. That's shown to be a good indicator that they'll have success with 6, 12 months, 18 months weight loss. And so if they, I do ask about contraception or, planning for pregnancy. Obviously, things can happen.
How many have we done? How many sutures so far?
Sometimes outside of that, but I generally advise closer to the range of Isaac, more in the 3 to 6 month range to avoid conception if possible.
The sleeve looks like it's coming along really well. Avika, how many?
Yeah, so I was just asking because I lost track, but we've done 5 sutures so far. We're near completion. I'll probably put 1 or 2 more in. I'm just cleaning up the stomach here. So what I've done is I've removed my tissue helix just so I can get some better suction, and I'm putting in some water and cleaning up some of the blood. As you've been watching, it can become a bloody procedure, which is, it's normal. And I think as we become more proximal and place the sutures more proximal, we get more vascularity and see some more oozing. The good thing is once we tighten the sutures, the bleeding stops. And so right now I'm just doing a little cleanup to get a good visualization. You can see here, sleeve is coming along nicely, and this is our GE junction up here. So probably 1 more, and we should be done. How many sutures do you guys typically use?
Depends on the patient's anatomy, but yeah, I would say usually around 6 or so. I'm also very meticulous about trying to get any blood or clots out. I think when they sit there in a freshly sutured stomach, when that patient wakes up, they're going to start having nausea and retching, and I try to be as aggressive as possible with an antiemetic regimen. I don't want there to be any, even if I can prevent it, retching. So I think the clots, when they stick around in the stomach, can induce some of that nausea, and the patient tries to vomit it out. And so freshly after sutures being placed, you don't want to have any suture line dehiscence. That's when you're probably at the highest risk of having a small leak that sometimes needs to be managed with a drain or whatnot. But yeah, I try to do the same as you're doing, clean out the stomach very well, get all the blood and clots out as best as possible.
Yeah, I have a kind of a resistant clot here that I'm not being able to suture up, so I might just try to grab it and come out with my scope just to get it out.
Now, you're taking full thickness bites here. Is it routine for you to give antibiotics for these patients, and how long do you normally give them antibiotics, if you do?
Yes, so typically I will obviously give them antibiotics for the procedure. Can we just clean the lens also? Give them antibiotics for the procedure, and in addition, I'll give them Decadron, a steroid, and to have an anti-inflammatory effect. We'll give them PPI, and obviously we'll give them some antiemetics during the procedure. I have them go home with usually 3 to 5 days of the antibiotic as well. And, we are, again, going, like you mentioned, full thickness. We want to make sure we're not causing any infection.
Nikhil and Isaac, what are your thoughts about that?
Yeah, I personally do not give them antibiotics. I have not done that routinely unless there is a very specific reason for it. And then we do use any antiemetic necessary. You mentioned EMEND before, and sometimes we want to use that, but we have difficulty with insurance paying for EMEND, and EMEND is quite expensive. And then in the recovery room, we may give them a steroid. And just as a comment, we were talking about complications of the procedure, and one of the things that is important is for people that do not do endobariatrics, but scope a patient because of bleeding after ESG, they get scoped somewhere else, they'll call you, oh, there is an ulcer in the stomach, or there is this. Sort of expected things to see, not to be alarmed by. They don't get treated like a regular ulcer.
Yeah, so we've had that a couple of times. And, typically, luckily, the doctor that's doing the scope actually just calls me and says, hey, I scoped this patient, and this is what's going on. I see some foreign objects in the stomach. And I think in one patient, there was an ulcer adjacent to the cinch. And it looked like maybe the cinch was kind of rubbing up and causing that ulcer. So, I appreciate the call, and I'm able to kind of explain to them the procedure that was done and kind of discuss with them the treatment. And I try to discourage removing these objects without knowing what the purpose of them was or the intention of the procedure was. So I think, whenever possible, if an endoscopist is seeing something in the stomach that they're not sure what it was, to give the endoscopist that actually did the procedure a call and communicate would be great.
Absolutely.
I tell my patients to come to my hospital where, if there's any issues. But thankfully, generally that's not needed. But yeah, the nice thing is this is a same-day outpatient procedure, so we don't keep these patients, overnight for observation. Dudes tend to watch them a little bit longer in our recovery area, and I also make sure that they're very well hydrated with IV fluids on the day of the procedure. The main thing in the first couple of weeks is that they maintain a liquid diet, and you want to make sure that they're not getting dehydrated. And whether it's a balloon or a gastroplasty, if there is any concern for dehydration, you can bring them into the office and give them a liter or two of fluid if they are unable to keep up with their intake. But it's usually with this procedure, I tell patients that if there are any issues, call me right away and try to get to my hospital, if at all possible, as opposed to a hospital that may not have experience with EB teams.
What's your typical post-op follow-up for these patients?
In our practice, they all get a call the day after the procedure, a call at 2 weeks, and then they have office visits at 1 month, 3 months, 6 months, 9 months, a year. And then after a year, then as long as they've been doing well, then we start to space them out from there. But there was data that Lopez Nava had presented at DDW a few years back, which shows that patients that have more, encounters or visits with the team, not just the endoscopist, but also the nutritionist and endocrinologist or obesity expert, those that have more sort of patient contact visits with the medical system have a much better job of sustained weight loss. And in some cases, we consider pharmacotherapy in combination if the thought is that may help benefit the patient. But we do phone calls and then follow-up visits. Isaac, how about in your practice?
Exactly the same program that you have, just a carbon copy of it. Yeah.
We're obviously
we're obviously
doing ESG here. But there's a lot of things that are on the horizon for weight loss in terms of endoscopic procedures. I don't know if Isaac or Nikhil, you want to talk about some of the other potential procedures in the future, like POSE and duodenal jejunal bypass liner, duodenal resurfacing, transpyloric shuttle, anything like that.
Yeah, there's a lot that is available. I think the more in prime time right now is ESG, but there are certain types of space occupying lesions, like there's a hydrogel beads that can be ingested before meals that can expand and take up space. There's transpyloric shuttles that have been approved, FDA approved for weight loss. There's also different types of suturing systems now that we will be seeing coming to market. Endomina is one of them. The POSE procedure is another application by USGI, another platform for suturing. And then you mentioned some of the therapies that are still in the investigational phase, but I think will be very promising, particularly from a metabolic approach. So these are more of the small bowel therapies. There's a sleeve liner known as endobarrier, and that basically is an impermeable polymer liner that extends from the duodenal bulb down to further down in the small intestine, and it basically bypasses much of the foregut with food. They actually had a study that was done about maybe 7 years ago now, that was terminated early because they had a relatively high hepatic abscess rate compared to what they initially anticipated, and that was thought to be due to some of the metal barbs in the anchoring system of the duodenal bulb. But duodenal bypass liner is one. I think one therapy that I'm particularly excited to see, where one of the studies that's involved is fractal, which is duodenal mucosal resurfacing. That utilizes ablation treatments in the duodenum to try to reduce the patient's A1C, their insulin requirements, and as well as contributing to their weight loss. There's also magnetic systems that have been designed and that are in the research phase as well. So a lot of promising new therapies on the horizon, both for gastric targets and for small intestinal targets, with the small intestinal ones having thought to have a more anti-metabolic effect.
We'll probably eventually evolve into a combination of endoscopic management, right? Where we will do possibly restrictive therapy as well as resurfacing, just because you will accomplish two different things, but in combination, maybe synergistic.
Good. So I'm putting in my last bite now, I believe, and then we're going to cinch this, and then we'll take a look at the final sleeve.
Yeah, it looks like it's coming along really well.
It looks great. We'll stick with you to till you're just wrapping up in the next couple minutes, and then we'll transition over to the Q&A. But we'd love to see the final product in the last couple minutes. Really great job.
Yeah, excellent job.
Thank you. So Kelly just took out the helix. I'm taking out the other catheter, and then we're going to load our cinch. And we can just show quickly the cinch here on the camera. It looks kind of like a pumpkin, and we're going to pass the suture through the tip there, and this is going to be the plastic cinch that's going to help us tighten the suture down.
So while you're doing that, one of the things that, just as a side comment, that we talk to patients before the procedures, I oftentimes don't talk about movies with patients, but before ESG or any type of endobariatric therapy, I bring up a Jerry Maguire movie, where you always tell the patients, help me, help you, and they get it.
That's a great line. This is the easy part. The hard part comes afterwards, and it really, the patients have to do the hard work to maintain this. Right. So that's it. This is our sleeve. You can see the stomach diameter is probably around 15 to 18 millimeters now. And this is our fundus area that I went into the fundus a little bit, but the majority of the fundus is intact. And right here I'm at the GE junction. So thank you guys for joining us. And I think we're going to go to a question and answer session now.
Yeah, beautiful job. Excellent.
Excellent. Hey, Vivek.
Hi, how are you guys?
Good,
Hi,
how
everyone.
are you?
Very good.
Hi, if we can have our speakers turn their cameras and mics on, we're going to move directly into the Q&A session. So we're very happy to have on the panel a number of superstars in our field. We have Dr. Sri Komanduri joining us. He gave the Barrett's lecture early this morning. We have Dr. Vivek Kumbhari joining us from Jacksonville. He spoke about dynamic traction. And then we should hopefully have Dr. Melissa Latour. There she is. Hi, Melissa, joining us, who gave a great talk on hemostasis. So first off, thank all of you for joining us. All of you gave excellent presentations, sort of spanning a number of different topics: Barrett's esophagus, ESD, and hemostasis. So maybe we'll start with you, Sri. Thinking about Barrett's, obviously there's a number of options that are available now, whether it's RFA, cryo, exploring hybrid APC. The best data at the moment seems to be for RFA, but can you let us in on sort of your decision process when you're approaching a patient with Barrett's in terms of your treatment algorithm?
Yeah, thanks for that. I think it's an algorithm that's evolved, right? All of us have gone through this, and I think we started with some very rudimentary techniques, and now we have sort of a multimodality approach such that anything could be utilized at any given moment. So, when we go into this, we have reclassified this as what we call endoscopic eradication therapy, which sort of sits as an umbrella above resection techniques and ablative strategies. So I think anyone treating Barrett's now needs to have both of those tools in their toolbox moving in. And so I think, and Vivek can comment on this too, the rise of ESD in this area has really made us, sort of think a little bit more. I still think, EMR is, fairly straightforward, and we've done a fairly effective job, but it's added another tool that we can, from a resective strategy, really tackle some of the more difficult cases. And I think it's really critical that physicians and patients understand the comprehensive nature and commitment to this going from resection to ablation is sort of that continuum. And whether that's, RFA or cryotherapy, and we've had some resurgence of various cryo techniques. I think having both of those tools, along with potentially, hybrid APC as that pans out as a more cost-effective potential pathway is critical. So I think, the endoscopic therapist for Barrett's in 2023 has not one tool, but 5 or 6 in their pocket.
Great response. Viv, I'll come to you next. And Sri alluded to it, but with the advent of some of these endoscopic platforms and traction devices, what impact do you think that will have on the learning curve and more widespread adoption of ESD in the States?
Yeah, thanks, Nikhil, and hi, everyone. Hearing what Sri said, we've had a couple of patients here that have had high-grade dysplasia, had undergone sort of wide-field EMR, and then you've got your little bit of early adeno found. And then there's sort of a situation where, is it all gone? What do we do next? And so on and so forth. So I get the sense that if something is a reasonable candidate for ESD, I think, my bias is that should be sought after, for obvious reasons. Now I appreciate the challenges of reimbursement, number of skilled people, and so on and so forth. But, I think that'll change very soon, and that'll change as a result of making the procedure easier. And then hopefully with reimbursement coming along. We've seen a big investment in ESD. All the major manufacturers now have ESD equipment. And so they're obviously believe in future growth there. And I think the technologies, needles, knives, which have injection capabilities that are now standard and so on, really are making this a technique that is able to be performed by many that should be coming out of, even a 1-year fellowship now. So I think traction sort of does a few things that sort of keeps your scope stable, improves the space and the visibility of submucosa, and really facilitates, more expeditious on-block resection. So I think for us, particularly in the West, I believe traction is going to play a big role in dissemination of ESD. I don't know, in Japan, been to some recent live endoscopy courses where the Japanese are particularly skilled, and they'll continue on without. So I don't know if sort of our experience here might, in fact, end up influencing their practice in some years to come.
And as a follow-up to that question, Viv, we have a question from the audience. With all of the traction options that are available, how do you decide which traction modality you're going to use?
Yeah, I think you could probably start with one and sort of try that and go from there. There are some simple, through-the-scope traction systems from, Microtech and Medtronic that if you're in the colon would make a lot of sense. The Fuji track motion system is currently limited to a double-channel gastroscope, so limitations in the colon, particularly in the right colon, are certainly present. It's probably a little bit more expensive as well than some of the other options. So I would think the simple band sort of clip system for the colon, particularly right colon, would be a reasonable start. For the esophagus, particularly the stomach, I think the track motion, and the rectum in particular, I think the track motion works particularly well.
Great, thanks for that insight. Melissa, thanks for joining us. I really enjoyed your lecture and all of the case presentations. You're a resident hemostasis expert, and as a GI hospitalist at NYU, you certainly encounter your fair share of bleeders. We have a question from the audience. In one of the videos, you showed that the Doppler probe that you use to assess for some of the vascular signals. How often are you actually using that device?
We actually use it pretty often, especially in the situations where there's a discordance between the patient's clinical presentation and the stigmata that we're seeing. So some of the cases I present are those hemodynamically unstable patients that, we go in and we find a clean base ulcer and it just doesn't make sense. And, tincture of time, the time that the patients are on PPIs can help to decrease the stigmata at hand. But I think that it's actually proven to be a really effective tool. The other scenario is when you're sitting there staring at a lesion, trying to decide, is this flat? Is this pigmented? Is it red? Is it black? Is it because the endoscopic management between a flat pigmented spot and a visible vessel can be very different and can also, lead to further complications if you err on the side of less critical and then they rebleed. So.
What are probably the 2 or 3 biggest factors that impact which modality you're going to use for hemostasis?
So the first biggest impact is whether they're on anticoagulation at that moment, and also whether they're going to need to continue that imminently following their endoscopic procedure. Because as a purist, coagulation is not preferred if a patient's going to be on any kind of antithrombotic or if they're on an antithrombotic at that moment. So thinking about that, and then also looking at the stigmata at hand and the clinical presentation. If it's a large, deeply created ulcer that's just not going to be able to be treated effectively with, standard through the scope clips, then that also helps to guide my decision making and maybe makes me a little bit more aggressive, or just, how critically ill is that patient? Some patients in the hospital, if they rebleed, that's it for them. So how important is it to prevent that rebleed, that 1 in 5 patients that rebleed following endoscopic therapy? So that also helps to determine my treatment and how aggressive I want to be with it.
Great. Viv and Shri and Isaac, I'll open up to you as well. When you have difficult bleeders, what else, are there any size factors, location that also play an impact in which devices you utilize? Because over the last few years now, we've seen a number of devices that have come to market that can assist with hemostasis.
Yeah, maybe I can kick off. I sort of have enjoyed suturing for 8 to 10 years, and so that is really very quickly my go-to. I don't do sort of on call, and so if I'm called to deal with a bleeder, it's usually someone that's failed sort of more conventional methods. So anything mechanical, I think, is really helpful. I think suturing is particularly good when it's a large ulcer, when some sort of over-the-scope clip system wouldn't be suitable. We sort of just layer normal tissue in the base of the ulcer and cause compression. It works nicely for marginal ulcers in patients with room-wide gastric bypass. They can be really troublesome. And also some difficult sort of gastric ulcers as well. So that's really my go-to. And if not, if it's sort of a Dulafoy or something more rudimentary like that, I'm actually pretty quick to go to the over-the-scope clips.
Yeah, I think the only comment I'd make is, obviously suturing is fairly advanced for a standard GI bleed that's happening at 3 a.m. But I think there are some, smaller and nicer versions. And the over the scope clip, based on the data, it just has to be part of that algorithm. And I can speak from our center, we're have been trying for quite a while to get everybody comfortable with this, and it's a challenge. And I think having training and having exposure, whether that's simulation based or otherwise, is probably pretty important, especially as we start heading into an era of many more tools, including powders and gels and things that are coming. The innovation is growing fast, so I think keeping our gastroenterologists up to date is going to be critical.
Isaac, any additional comments?
No, I agree with all of the above.
Great. I'm gonna toss a question to you, Isaac, that came in. This one is regarding treating fibrotic colon lesions with underwater EMR. What's your approach to those fibrotic lesions?
Yeah, so I do not do ESD. I do EMR or multifocal EMR, and underwater is a beautiful technique. It's nicely demonstrated by Kevin Miller from years back, and that's what I would do, and it works really most of the time, even if they are fibrotic. There's a way to raise them up. So that's what I do.
And maybe to build on that, would agree, would always try underwater first. You're remembering to move patients into positions such that the lesion submerged and floats. But I think, I've enjoyed doing a bit of hybrid full thickness resection now. So you sort of EMR what you can. You often get a bit of central fibrosis that doesn't lift. And then you sort of, at the same session, go to the Vesco full thickness resection device. The tissue is still pretty pliable, so you grab and then drop the FTID, and it seems to work pretty nicely.
Yeah, that's a great comment. And there's so much equipment that's at our disposal now for these difficult lesions. But I think the hybrid techniques are going to be coming more into vogue now. And then I think for those maybe scarred down difficult ones that may not be candidates for EMR, ESD, may not have much separation of the layers with underwater EMR. Endorotor could potentially have an impact as well. All right, so I think we're coming up on the top of the hour. So I want to thank my esteemed panel here. We're really grateful to have you give talks this morning and join us for the Q&A session. And a special thank you to Dr. Isaac Brightman joining us from Houston as well. Keep sending your comments and questions in the chat box. We'll see if we can get to some of them in the next session, but we're gonna now turn it back over to our live endoscopy cases coming from Robert Wood Johnson. So thank you all for joining us.
Thank you, everyone.
Thank you.
Hi, welcome back, everyone. So we have our next live case in room 2 with Dr. Shahid. We have a 60-year-old female. She has a history of a room-wide gastric bypass back in 2017 and also had a cholecystectomy. We ended up seeing her in clinic. She was recently hospitalized for acute pancreatitis. At the outside hospital, she had a CT and an MRI MRCP, which at that time revealed dilated intra and extrahepatic ducts up to 15 to 18 millimeters and a pancreatic duct up to 5 millimeters without any obvious focal areas of narrowing, intraluminal lesions, or mass lesions. LFTs of note were unremarkable. So for today, we are going to be doing an EDGE, an EUS-directed transgastric ERCP, and possibly an EUS as well.
Let me know when we're live, guys. Are we live? Oh, welcome, guys. As you heard the story, this patient has, essentially a double duct sign, and has normal LFTs and unclear etiology. In those situations, obviously the initial approach, if the cross-sectional imaging is not revealing, is to go forward with an EUS and possible ERCP to determine the etiology of the ductal dilatation. The concern would be, is there possibly a ampullary mass, small pancreatic mass, or even distal biliary mass in this situation? She obviously has had a room-wide gastric bypass, so The only way to really attempt an endoscopic ultrasound to evaluate the bile duct would be to do an EUS guided edge procedure where we place a lumen-opposing metal stent between the gastric pouch and the bypass stomach. So this is, a procedure that, was essentially created by Dr. Gehala and Dr. Kedia, who were here earlier during MAGIC. And it's something that's now being done pretty much throughout the United States for patients who've had Roux-en-Y gastric bypass that need an ERCP. The first thing I did before you guys came to me is I did an endoscopy. And the reason to do endoscopy first is to figure out, how big is the pouch? And, how much room do you have to do a true gastric stent placement? And interestingly, this patient's pouch is actually very small. The distance from the GE junction to the gastrojejunal anastomosis is about 2.5 centimeters, which is very small. Ideally, when doing an edge procedure, my preference is to do a gastric stent, just because I feel like if there are any issues that arise, it's much easier to deal with the stomach than it is the jejunum. But it is still possible to do a jejunogastric LAMS placement in order to perform an ERCP. So if you can see my EUS image right now, I'm actually about 1.5 centimeters or almost 2 centimeters past the GE junction. And luckily, I can see the bypass stomach. That's what you're seeing right below me. I'm going to freeze the image here and see if I can get an arrow here to show you. So this area here is the bypass stomach. It's decompressed, so you're not seeing it insufflated. And the goal here is to essentially access the bypass stomach with a access needle, which is usually we're using a 19 gauge Cook needle here, and first confirming location with contrast injection, and then insufflating the stomach, usually with saline. And that's the reason to do that is so you have a larger target when placing a lumen-opposing metal stent. In order to perform an ERCP through a lumen-opposing metal stent, usually you need to have a 20 millimeter lumen-opposing metal stent. I use a cautery-enhanced Axios in these situations, and that diameter is large enough for the ERCP scope or an EUS scope to easily traverse that area. So that's where we are right now. I do have a few other people in the room with me. Ron and Greg are my nurses here, and I have Mihailo and Dr. Sarkar in the room as well, who will be commenting. So my first step is going to be to access this, and feel free to comment, any of the moderators that are in the room or watching.
So I think this case is very interesting to begin with. If you look at the x-ray, there's multiple clips from the prior surgery, which sometimes makes edge a little bit more difficult, especially if you end up going through those clips, not only for the needle, but for the axial stent later in the course as well.
Take this out.
Right now, Dr. Shi just entered the bypass stomach, and next step will be to try to inject some contrast to confirm that.
So it looks like we're in the bypass stomach, as Mihailo mentioned. So the first step I'm going to do is inject contrast to confirm that we are truly in the stomach and that we're not outside, that we're not in the submucosa. Go ahead, start injecting of the bypass stomach. And what you're going to start to see is rugae on the fluoro. Is a fluoro image up as well? And that's what you're seeing right now. So that's enough injection. Can you flush this with some saline? And what I like to do, instead of hand injecting a lot of saline, what I'm going to actually do after I clear the needle is actually attach the foot pump to the end of my needle. So Ron is doing that now. I lock my needle in place. And now I can easily instill a large amount of saline into the stomach, and you're going to start to see that on EUS. And again, my goal is to insufflate this enough where I feel like I have a large enough window to be able to place a lumen-opposing metal stent. This is not a procedure that needs to be done in 5 minutes. Take your time. You want to avoid any particular, potential complications. As you can see, it's already starting to fill with fluid here. This is a procedure, when you're placing a lumen-opposing metal stent, you can do a wire-guided procedure, or you can do it freehand. My tendency when I'm doing an edge procedure is to do this freehand. I think that sometimes the wire does get in the way. So we're going to continue to fill this. In the meantime, I'm going to ask my staff, Greg or Ron, if you can get a 20 millimeter Axios open, and please wet the catheter itself. Because once I feel like I'm ready, I'm going to pass the Axios very quickly to ensure that the bypass stomach is still filled with fluid, and that I have a good access and window to place the lumen-opposing metal stent.
The good part about freehand also is that you can readjust your position later in the course, and based on X-ray, you can find the best, the most suitable place for you if you have to do edge step and one at the same time, so you don't lose the Axios later in the course.
Yeah, Mihaly, you bring up a good point. This patient is obviously not cholangitic right now. It's not an emergent procedure. So the question is, is there any, do you need to perform the second step of the procedure right now? And I think everyone differs in exactly how they would handle this. Some would say it's okay to go ahead and perform the second step. Others may say, why don't we defer this a little bit later, given that she's feeling okay, and just do step one, where essentially you're just placing the gastric lumen-opposing metal stent, and then bring the patient back in a few weeks to perform an EUS and ERCP through the lumen-opposing metal stent. My preference in patients where I have to place a jejunal gastric lumen-opposing metal stent is to actually bring them back and do the step two at a later time, just because I think the small bowel is a little bit less forgiving. And if the LAMS is to migrate during the procedure, it can cause significant issues. So if they're not cholangitic and there's no emergent indication, those patients I'll bring back. If I have a good window and I feel like I'll be able to access the bypass stomach readily while doing an edge, then oftentimes in those situations, I'll go ahead and do the EUS or ERCP at the same session. And a lot of that has to also do with kind of the angulation of how the Axios is placed, and whether or not you feel like it's going to be a good window for you to go through and perform the procedure. What are your thoughts on that, Mihailo?
So I agree. And most of the times I try to avoid edge step and one at the same time, except for cases usually cholangitis or bile leaks. Then I perform step one and step two at the same time. What I usually do is, again, suture the Axios stent after I deploy it. And at the end of my ERCP, I leave a long wire on through my duodenoscope in case the Axios was migrated. In the meantime, I have that wire that can salvage me, and either I deploy a new Axios or one of the covered esophageal stents to kind of salvage me in the last second. The other thing is, which is very important, is your position of placing the Axios at the beginning. And it's not as important as ERCP, but it's more important if you do end up doing US later in the course. Because sometimes I find it not useful if I place that Axios in the antrum, then I'm not able to look at the tail of the pancreas on US, which is a problem.
So do we have the Axios stent out and ready to go, guys? You can bring it over, and then we're gonna do this exchange where I take out the needle and you're going to give me the Axios stent. Can we have the pedal here as well for the cautery for the lumen-opposing metal stent?
So Dr. Shahid, if this stomach was not distending with the fluids, what were your plan B to try to distend the stomach?
Yeah, sometimes that's very difficult. I mean, if you're not able to distend the stomach, it's very hard to place the lumen-opposing metal stent. Usually you'll get some amount of distension, although you may not get significant amount. Right now, I don't know if you guys saw me measure. I measured kind of the distance that I had, or the width of this stomach now. It's about 3.5 centimeters, which I think is sufficient to be able to place a lumen-opposing metal stent. When you think about lumen-opposing metal stents and using them for their true indication, which is for pseudocyst drainage, the company states that usually you want to have a collection that's 4 centimeters in size, at least to place these lumen-opposing metal stents. And that's not obviously something that's 100% necessary. But in this situation, I think we'll be okay with the size that's going on here. Fluoro for a second. We look okay. I'm gonna fluoro one more time. Okay. We have the Axios. I'm gonna come out with the needle?
While Dr. Shahid is exchanging for the axial stent, what I find useful is sometimes giving glucagon to the patient.
Yeah.
It may or may not work with the motility, and the other option is put the patient in a Trendelenburg position just to keep the fluid as much as possible into the stomach and not allow that fluid to go into the duodenum and decrease your window.
So I'm just looking for any vessels in the gastric wall. I don't see anything. So I'm going to go ahead and pass the axios now.
And Dr. Shahid, this axios you will deploy without the wire, correct?
Yeah, I'm doing this freehand. And Mihaela, while I'm doing this, you can walk maybe the audience through how this is actually deployed.
That's correct. So there's 4 steps for deployment of the axios. First, we engage and we actually pull the cautery tip out of our US scope, and then when we are ready and we have a nice window, we hit cautery, and then the cautery tip part of this axios goes through the bypass, through the old stomach and through the new stomach, up to the point that it goes into the bypass stomach altogether.
So I have the delivery system at the gastric pouch wall. It's important not to jab this into the bypass stomach. Once you apply cautery, hold the cautery for a few, 1 or 2 seconds, and then slowly advance yourself into the bypass stomach. What I'm trying to avoid, I don't know if you see some of this hyperechoic stuff that's near the stomach wall. That's probably some of these staples. So I'm trying to avoid some of these staples so I don't have any issue with dilating this later. But I think we're good where we are. We're connected. All right, so we're going to go ahead and apply some cautery. And I'm in here. Now I'm going to push this in as far as I can. And go ahead, you can detach. And you're going to watch me place the the internal flange now is going to deploy. That's the internal flange there on EUS. The next step is actually to pull back and tent this up against the gastric bypass stomach wall. And you almost form like a football shape. At this point, I like to pass a wire. That way I maintain access if, God forbid, I was to lose access for some reason. So I'll coil a wire in the stomach at this point, which is what's happening here. His stomach looks very oddly shaped.
Yes, and it's going through the fundus.
Yeah, so which is fine, because I just need to be able to enter this. So now what we're going to do is we're going to go ahead and deploy the luminal side of the lumen-opposing metal stent. I'm going to switch us over to this live fluoro for me. I like to deploy actually into my scope initially, and it's deployed, and you don't see it right now endoscopically, but I'm going to try to push it out. And what I'm going to do is I'm going to pull back my scope a little bit and push it out a little bit more here.
So in case you do only step 1, Dr. Shahid, do you dilate up to 20 millimeters of a 20 millimeter axios, or you...
Yeah. So, there is some data showing that when you dilate fully that there's an increased risk of bleeding. So if you're not going to be doing the second step, you can probably just go ahead and place it and no need to dilate at that point, and just let it dilate itself. But if you're going to be placing or you're going to be performing the second step, then you're going to need to dilate this. And usually I'll dilate to 18, 19 millimeters. I don't usually go all the way to 20, as it's not always necessary. And I don't know if we're seeing endoscopic view. You can see the lumen-opposing metal stent has now been deployed. I still have my wire in there. And if you look at fluoroscopic view now, you see that the bypass stomach is insufflated as well, which is typically what the stomach would look like when you're performing endoscopy or ERCP under fluoroscopy. So that's where we are now. What I'm going to do now is actually do an exchange. So Ron, I'm going to pull this back, and then you're going to push wire in, okay? Hold on 1 second. Let me just lock that again. And then go ahead, start pushing wire.
Not deploying the axios, I also think that gives you a little bit more extra, safe space, just because if there's any bleeding around that axios, this radial force of the axios not being deployed actually tamponating the area and giving you a little bit more safe.
Exactly.
Safe
push more wire.
And you're gastric here, I believe.
I believe so too. Sometimes it's hard to tell, but I did keep pushing. Okay. Can I get a cap back on here once you'd remove the axios? So I'm pretty sure we're gastrogastric, although, I did mention there's only, now you see a lot of fluid coming back. This is all the fluid that I put into the stomach. When I was talking, I had my foot on the pedal the whole time to instill fluid into the bypass stomach. So there's a lot of fluid that's in there. So I expect a lot of this fluid to come back, which is a good sign. Some people may decide, to put a little methylene blue in there, so they see kind of the methylene blue come back. I don't necessarily do that in this situation.
Yeah.
I would do that, for a gastrojejunal.
How do you decide regarding the wire? Which wire do you use for edge procedures?
Yeah, my typical wire that I use is the 035 VisiGlide wire, which is made by Olympus. That's kind of my go-to wire for the most part. I know everyone kind of has the wire that they like to use. I feel like this passes very easily. It's a hydrophilic wire. I don't get any issues with stripping of the wire or anything like that. So it works really well, and that's what I like to use for all of these cases. As I mentioned previously, we use an access needle, which is a 19-gauge FNA Echo Tip Ultra needle from Cook. So I'm going to actually my wire looks okay fluoroscopically. I'm just trying to get rid of some of this fluid so I can just get a better view of what I'm doing.
And if we can look at the X-ray, I think it's a great picture. It's very important to make sure you be cognizant and aware of the landmark, especially of the G junction. We don't want to do edge above the G junction, which unfortunately sometimes it looks great on EUS that you have a great window, but you want to keep yours.
If we can look at the endoscopic view here again, so this is my lambs here in the gastric pouch, and when I rotate my arm to the right, there's your gastrojejunal anastomosis. And so I just want to show you how small this pouch is. So that's your gastrojejunal anastomosis right there. This is the lambs. I'm going to pull back about 1 centimeter, and here is your GE junction.
Yeah.
So that's the only amount of room that we had, and luckily we had a very good window. So we're going to go ahead and now advance a dilating balloon, which is the CRE dilating balloon by Boston Scientific. So this is a 18 to 20. Yes, 18 to 20 CRE balloon, wire guided. So I'm going to stop for 1 second, Flora. I'm going to have to probably pull my scope back a little bit just to be able to dilate this properly. Okay, good. And go ahead and dilate here. Go to 18.
Sometimes I find it surprising after dilation you see this flush of bleeding out of nowhere.
Yeah.
And it can be dramatic, but usually most of the time just waiting and bleeding.
It almost always stops.
Yeah,
and sometimes what you can actually do is hold your balloon open. It's usually coming from the wall of the either the bypass stomach or the gastric pouch. And if you keep your balloon insufflated for about a minute or so, you can actually stop that bleeding.
Yeah.
Stop for a second. I'm getting pulled in here, so I'm going to actually ask you to bring the balloon back down. So I don't have a lot of room, right? So I probably will need to pull back into the esophagus a little bit to be able to get this balloon to be centered within the aluminum-opposing metal stent. Obviously, I got pulled in. I'm not going to do anything right now. I'm going to wait till Ron brings the balloon down completely. I don't want to pull right now. I could potentially dislodge the axios. That's one of the worst things that you could do after placing this.
You have to be very patient in this part.
Yeah.
Just because of the contrast takes time to get out of the controlled radial expansion balloon. What are your options if the axios migrates here?
What's going to happen? So go ahead and dilate here to 18. So, if the axios migrates, this is the reason that after I gained access to the bypass stomach, I placed a wire. And having that wire is your insurance to ensure that, if you lost access or the axios was misdeployed or got pulled back, what you do now is you have access to the bypass stomach and you can pass a fully covered esophageal stent like a Tai Wung or some other fully covered stent through that area and bridge it. So you can bridge yourself and maintain a communication with the bypass stomach. Can you Flora here for a second?
Are you ever worried about the flange that stays between the two stomachs in case the axios migrates?
I'm sorry, what?
The flange that remains in between the old and the bypass stomach.
Oh, you mean if we had a misdeployed stent?
Yeah, because we're going to put a cover stent through the axios, I believe, and then...
Yeah, potentially you could get some irritation and that can lead to bleeding. And you can have granuloma formation as well. But, because you've placed a fully covered stent through it, the risk of bleeding is going to be lower because you still have that tamponade
Correct.
effect. And one of the other issues that you can sometimes see is that, when you pull out the stent, it looks pretty bad, when you pull out the bridge stent. But usually that fistula only takes about 10 to 14 days to mature. So that fistula is mature by the time you usually remove that. And even though it looks bad initially, that will eventually heal. So I'm just waiting to see this expand a bit more. You still see a little bit of a waste there, which I'm not too happy with. But the waste is probably there because I'm right adjacent to one of these surgical clips that was placed during the gut bypass surgery. So are we up to, what are we up to right now? 18. Go to 19?
So if we end up doing just step one, even having that waste at this point, I would not worry that much, and I would just stop sometimes just because I know that with the time that the axios is going to distend by itself.
Yeah.
And we're kind of in a safe zone. The flanges are open. They keep both of the stomachs together. So
that looks much better.
Do you think you'll have difficulties passing the duodenoscope when you end up doing the H2 based on this axios placement? Or
I think it's a pretty good placement. I think we're going to be able to pass it. And I actually want to pass a duodenoscope. What I'm most interested in this patient is really to look at the ampulla endoscopically. And just because I think there may be something going on at the ampulla here with the double duct sign. Or maybe there's a large duodenal diverticulum which isn't being picked up, which can sometimes cause, biliary dilation, pancreatic duct dilatation, which is benign. So I think we're pretty good here. I'm going to ask you to bring the balloon down, and I'm going to try to pass the duodenoscope through here. The people usually bring up, should you suture this?
Or not?
And that's a good question. There is some data showing that if you were to suture this in place, that the risk of migration is going to be lower. Sorry? So we're gonna, let me just take a quick look at what the axios looks like and what my trajectory is going to be. If my trajectory looks like it's going to be pretty straight, then I think it's okay. We can pass the duodenoscope. And again, once the scope is through, you have access. And if you were to have the lambs migrate during your procedure, you have access. Now, I always pass a wire before I bring my duodenoscope out, just because if that lambs gets dislodged during the procedure, I still have access. I can still place a fully covered stent. So we're gonna come out with this balloon now, which looks pretty good, and you're gonna be able to see the bypass stomach. And I'm gonna pull the wire as well, okay?
Suturing also gives you a little bit extra safety, especially for the stomach itself, but I don't think you have a safety for the bypass stomach. So
Exactly.
if the axios ends up being dislodged on the other side, I don't think we have an option how to protect that or how to.
So that's the bypass stomach there.
Perfect.
It looks great. So let's try to see whether or not we can pass the ERCP. So we do have room here to suture if we wanted to.
Yeah.
We're going to try to pass the duodenoscope through here. If I'm having any difficulty, I may come out and decide to suture this. But we have the ERCP scope here. Let me just take a quick look here again one more time so you guys can get a better view. So there. So there's a question coming in, what type of ERCP scope are you using? I don't think it really matters. It's whatever you are comfortable with. The scopes that I use for ERCP for the majority of cases are the Olympus duodenoscopes. The scopes we have are the ones with the disposable tip. And that's what I feel most comfortable with doing some of these more complex procedures. Obviously, in our unit, we do have some of the disposable duodenoscopes available as well. That's also something that could be used, and we have done that during edge procedures in the past. In this situation, I'll be using the Olympus duodenoscope, though.
Dr. Shahid, if you were to finish the procedure now, what's your take on double pigtail stents through the axial stent?
You know what? I think we placed double pigtail stents. When we had smaller axios stents for, walled-off necrosis and for other indications, I think it made sense to place these double pigtail stents. You'd think you're anchoring that stent in when it's only 10 millimeters. That's probably true. I think we place double pigtail stents through these very large lumen-opposing metal stents more to treat ourselves. I don't really know if it's anchoring anything, because honestly, a lot of times that double pigtail stent migrates.
Yeah.
Think about it, it's a 20 millimeter diameter lambs. You're placing a 7 French or 10 French pigtail. The whole pigtail can actually go through the lambs, right? It's not really hooking on. So I think we do it for ourselves because it's something that we're used to. I don't think it necessarily changes the likelihood whether or not that lambs is going to migrate.
I agree.
Yeah. So another question that came up is, what else can you do in these patients? Say you don't have the experience or you don't have the expertise at your hospital to do edge procedure. What can you offer the patient if they have something going on? So, previously the way that these were dealt with was with the lap-assisted ERCP, where you work with the surgeons in the OR and they make a gastrostomy, essentially a conduit for you to be able to pass your ERCP scope through. And oftentimes, if you're going to need to go back, they leave a large gastrostomy tube in place to keep that gastrocutaneous fistula open. And you work in conjunction with the surgeons in the operating room to perform ERCP in those situations. It can be very difficult to do that, to coordinate cases like that in the operating room, especially as we as endoscopists, we're working in endoscopy, the surgeons are working in the OR. It's not necessarily a surgery that they want to be doing. We definitely don't necessarily want to be in the operating room. So it's difficult to do that. There's also the potential to do like a balloon-assisted or enteroscopy-assisted ERCP, where you come, go down and come back up the afferent limb and reach the area of the ampulla. Those are very difficult. The likelihood of you achieving access can be relatively low. Some of the studies say, it's about 50 to 60% chance of reaching the ampulla. And then being able to perform therapy is also very difficult. Somebody who has a virgin ampulla, you're coming from underneath. You're coming from the other side. So your instruments are not usually made to perform ERCP from the other side, from below the ampulla. So that can be very difficult. So, those are both very time-consuming procedures. So give me 1 sec. Let me see if I can get into the stomach here.
Yeah.
And so I'm gingerly going into the stomach here, into the pouch, and I'm going to be asking Tom here, who's our rad tech, to fluoro every once in a while, because I want to make sure that I'm not going to hit this stent and dislodge it. I want to make sure when I'm doing, trying to pass this duodenoscope through the lambs, that I'm in line with it, and fluoro is key in these situations. Your endoscopic view sometimes is not as helpful, so I'm going to keep advancing.
It's very important to know that you do have possible alternatives for ERCP part, but if you are intending to do EUS, then probably edge is the only way to get in and look at the pancreas and some of the organs for
Fluoro
EUS.
here for me? So, I have a very difficult position here. I'm almost going to the fundus here in trying to get in. So I'm going to gingerly try to advance my scope. And what's going to happen when I pass my scope in, you're going to see the lambs actually change its position. Right now, it's facing almost towards the 2 o'clock position. Once my scope goes through and looks down, you're going to see it kind of change to the 4 o'clock position.
That's why it's important to keep checking on X-ray multiple times whether your axials are still in the same place or by any chance you have pushed it down beyond
Go right here. So we're having a little bit of difficulty advancing this. So I'm going to rotate a little bit. And again, I'm doing this very gingerly. I'm not trying to pull or push too much because I don't want to accidentally dislodge this. So I came back out for a second.
And this is the case when we really need to dial it up to 20 sometimes, just in order to have a little bit more leverage and space to pass that duodenoscope through.
So let me get the wire again. Let's dilate one more time. Okay, so I'm going to take the wire and I'm going to dilate back up to 20. Can you guys get the 2T scope in here? I think I'm a little worried about the angulation that I have here, and I think it may be better that I suture part of this stent in. I do have room on the proximal aspect here to suture it. I don't know if I'm going to have room on the distal end. depending on what it looks like. But let's dilate first.
Yeah, if you suture, Dr. Shahid, do you place 2 sutures usually, or 1, or?
Yeah, my goal is usually to place 2 sutures and on opposing ends, so 180 degrees from each other. And we're going to pass, Ron, do you mind just grabbing the end of the wire there?
Yeah, do you have any experience with using X-Tac to kind of anchor the stent itself?
You know, X-Tac is a great device. You know, I've used X-Tac a lot to close post-EMR sites and polypectomy sites, and even to close fistulas. I don't have any experience using that to fix the lumen-opposing metal stent in place. I don't know if anyone else here may have a little bit more experience with that. Fluoro? Oh, our fluoro is not in position.
Off.
I think the fluoro moved down.
Go fluoro line.
You need to come over a little bit more, just a little bit higher.
There you go.
I think I'm in, but just want to make sure. Obviously, I have an ERCP scope right now, so it's not as easy to tell. But
yeah, as long as you have a good fluoro, just like Dr. Shahid, and you know where the wire is, I think we're still safe here and can keep dilating. The other problem with lap-assisted ERCP is you end up placing stent, and then you think you're done with the ERCP. You pull the stent out, they close, and then there's a complications like either a stricture, where it causes cholangitis, or bleeding that you have to fix. Then you have to go back with lap-assisted, open the patient again. So the edge procedure gives you the opportunity to do as many ERCPs as you need to, and when you're safely done, you can pull out the axial stent and close the opening. Dr. Shahid, what do you think about just getting a straight view EGD scope and taking a look on the stomach first?
Yeah, we could definitely do that if you want to just go into the stomach. I had a case of a patient that had recurrent GI bleeding of unclear etiology, who had a very thorough workup with, it was Roux-en-Y gastric bypass, and had endoscopies and colonoscopies and enteroscopies and capsule studies, and everything was negative, CTAs, bleeding scans, but would have melena, would drop hemoglobin, would require blood transfusions. And the only area that had not been evaluated really was the bypass stomach. And, one of the options to reach the bypass stomach in those situations is to, again, try enteroscopy, balloon-assisted enteroscopy to reach that, which can, again, be difficult. Oftentimes you need double balloon enteroscopy. We don't actually do double balloon enteroscopy here. We have single balloon. So I ended up actually talking to her about doing an edge procedure, and not for ERCP, just to gain access to the bypass stomach. And we did that, and we found a bleeding AVM in the stomach, which was very surprising, to be honest with you. But that was a different indication for doing that type of procedure.
Yeah, and I found cancers in the old stomach, in the bypass stomach, just by, which I don't think would be diagnosed on time if we didn't do the edge. So I think it's a very useful procedure to have and to learn for most of you.
Laura, for a second. Can you pull this wire for me for a second? I think there's something caught on the end of my ERCP scope, so I'm going to come out for a second because I'm having a hard time pushing anything.
Then we can probably take a look with the straight view scope as well.
Yeah, I don't know if we have a straight view scope here ready, do we? You can give me the straight view scope.
I think it's
and then we can dilate with the straight view scope, and then we can take a look at the bypass stomach in the meantime.
It's important to share. I had an interesting case that I had to do EUS, and the stomach was not insufflating. I don't know whether, Dr. Shahid, you've done this, but I ended up doing single balloon enteroscopy, leaving a wire, putting a CRE balloon from the bottom of the duodenum, and inflating the entire bypass stomach, just for me to have a window for
that's an amazing case. I have never encountered that situation. I'm going to knock on wood that I don't ever encounter that situation, because I can imagine that being very difficult. When you don't get good insufflation of the bypass stomach, it's very hard to gain access.
Yeah, and especially you need it for EUS. ERCP, you have, just like you said, the alternative ways, but sometimes you just have to find another way, I guess.
Yeah, I think in those situations, one of the other things that you could potentially do, you need a lot of space for the lumen opposing metal stent. You may not necessarily need as much space to place some other type of stent. So, if you can access it with a needle pass a wire and then almost, create a fistula with either something like a cystotome or a needle knife, and then place a small biliary stent temporarily, and then, bring them back and then place an Axios through that same tract in a week or two. Obviously, there would be risk that stent could migrate. You could try to suture it, but just something else to think about. What else can you do? You may not need as much room to be able to do that as opposed to placing a lumen-opposing metal stent.
If you guys look at the X-ray, the Axios is in between those clips. So Dr. Shahid, when you do the Axios itself with a hot cautery, do you find it sometimes hard to push that catheter through if you're in between clips?
Yeah, I've had that happen before where you step on cautery and it just won't go through.
What do you do then?
So you have to find another window. You're not going to be able to go through some metal clips. I don't have CO2.
Yeah. And that's the good part, I guess, not going over wire. You insufflate the stomach, and then you can readjust your EUS. If you don't like it, you can readjust again and find the best window that will fit for a nice placement of a lumen-opposing stent.
Yeah. I'm still not getting CO2, guys.
Any comments from the public or from the audience regarding their experience with edge procedure?
I'm going to go down and show you what the bypass stomach looks like while we ask that question.
Yeah, so it's a great demonstration so far, guys. Thank you so much. What's your plan now? Are you just taking a EGD scope to survey the area and possibly dilate with your EGD scope?
Yeah, I'm going to dilate with my EGD scope. I'm going to try to pass my EGD scope through, which I did here. Flora, show the Axios. And, I'm going towards the fundus here if I look up. So that's not where I want to be. I want to be down towards the body antrum area, which is here. And, it does change the orientation of the Axios. I am putting a little bit of pressure on the Axios. There's a lot of gastritis in the stomach. That's what we see, Flora. And I'm still putting, I think my Axios is okay, Flora. I think a lot of the pressure is actually on the bypass stomach more than the actual Axios.
Yeah.
So we're going to try to advance a little bit more if we can. Yeah, I'm getting a lot of resistance here, so I think let's dilate, and then I think I want to suture this before I attempt anything else significant to try to prevent migration.
So Dr. Shahid, if you end up doing step 1 and step 2 at the same time, do you dilate the pylorus at all? Because sometimes I find it almost atrophied and hard for me to pass the duodenoscope through the pylorus.
I had that happen once where I did have to dilate. Usually the EGD scope will pass through.
Yeah.
But you're right, the ERCP scope might not. So it can be difficult. So dilating in that situation is fine. Okay, so give me 1 second. So let's get the dilation balloon, and then we're gonna suture, and then we'll try again. I think, I like to be relatively safe with these procedures. I don't want to be overly aggressive right now, given the fact that this is not an emergency. Obviously, she's been dealing with having a dilated duct for a while. I think if we were to not be able to do step 2 of the procedure, it's not going to be that much of an issue. Hold on 1 second.
Is there any chance that you could use your EGD scope to take a look at the ampulla?
Yeah, potentially. Guys, I need another balloon. This balloon is... yeah, you can. You can try to pass the EGD scope there. I don't know, Avik, if you saw, what was happening. I was getting a lot of pressure on the wall of the bypass stomach. In order to advance my scope further, I could feel it rubbing up against the Axios. And that's why I paused a little bit and decided to come back and want to suture this in. And then I'll pass the EGD scope again to try to take a look. If it's much easier to do it then, I could potentially try to pass an ERCP scope. But I think at this point, if things don't pass very easily, I would probably decide to bring her back for step 2, doing the EUS and possible ERCP. What are your thoughts on that, Avik and Mihailo?
I think suturing is a great idea in this situation, and I tend to actually suture all my single session edge procedures, but in this case particularly, I think suturing is very important. And I think, when I encounter these situations where I get some resistance on the lambs, I find that using some silicone spray on my scope kind of eases up on that tension a little bit.
Yeah, that was literally what I was going to ask Ron to do when I come out with after I suture. Hold on one sec. Give me a little bit more negative on the wire. Good. A little bit more. More. Good stuff.
It's very important to work with coordination with your tech, just because, or your nurse, just because having that negative to kind of angle your balloon downwards.
We're going to try to go up all the way to 20 this time.
And also, when you suture, Dr. Shahid, are you worried that you may take distant bites from the stent, that when you deploy, you can just pull the axials out of the...
Yeah, you need to be very careful. I try to take bites from the proximal end of the stent as proximal as I can, and the area of the gastric pouch that's the closest to it, and try to cinch those together. And then I try to do the same thing on the opposite end, 180 degrees from where I placed it. That maybe is not always possible. You have a gastric pouch that's relatively small. I mean, if you see where my scope is, I'm above the GE junction right now, right at it, and I have my balloon, only, a centimeter away from me. So, we don't have a lot of distance. We may not have a lot of space with the suturing device, but I think in this situation, I would feel more comfortable suturing the stent in place. So we're up to 20 millimeters, right? We can put the balloon down. And we're going to go ahead and suture, so you guys can get the 2T scope ready to suture. We had an excellent demonstration of suturing by Dr. Sarkar just earlier with the sleeve gastroplasty. Obviously, the suturing device can be used for a lot of things. When I was training, I learned most of my suturing by suturing esophageal stents to the esophagus, and that's how I became proficient. And that's why I think, when we were discussing earlier about, what's needed in order to be able to perform endoscopic sleeve gastroplasty, it's important to have a lot of experience with the device in a variety of situations, not only just doing sleeves, but closing fistulas and suturing stents and things like that, just so you can troubleshoot. So can you put the balloon is still up a little bit?
Suturing in tight spaces is obviously difficult with the double channel scope. There is a single channel version of the overstitch. And it may be easier to suture with that in some tight spaces, but there is also a little bit of learning curve using the single channel overstitch device.
Yeah, I agree, 100%.
What are your thoughts on the importance of using a helix for suturing stents? Do you think it's necessary, or do you think going without a helix is okay?
You know what? I tend not to use a helix when I'm suturing stents in place. In the stomach, it probably is fine. But when you talk about suturing like esophageal stents in place, I worry a little bit more about turning the helix too far and causing a perforation. In the stomach, it might be okay. Even when I place a LAMS, and again, a lot of cases when I do an edge, I don't actually end up suturing unless I'm having difficulty passing the scope. But if I do decide to suture, I usually do not use a helix. Avik, what is your experience with that? Or Mihailo, if you
I think just for edge procedure, I don't think it matters using helix versus not, because even if you do submucosal bites, the whole point is to keep that stent stable for maybe 2 weeks. After that, you have the tract matured already, so it's not a big problem even if the stent migrates in your next procedure. It's more important to get muscularis propria for long-term stents like the esophageal stents, but just for the edge procedure itself, I think we're fine even if we take submucosal bites, which you can easily take without the helix.
Yeah, I agree with Mihailo completely. I think, you just want to kind of keep this LAMS secure for your procedure right now. It's not as essential to kind of keep this secured long term because, as the fistula forms within the next 7 to 10 days, even if that stent migrates, it's okay. We want to make sure that migration doesn't happen during your procedure, and I think the suturing, just getting it through the submucosal layer should be enough for the procedure today.
If you look at the X-ray right now, at least the last X-ray we have with the wire, that will be the trajectory of the scope going down to the duodenum. And unfortunately, I find this very difficult, especially when I have to do EUS. Sometimes that will be my EUS scope, even on the later phases, and I just cannot get a complete evaluation of the pancreas or whatever you need to do, especially the tail body area, just as because of the scope needs to have that almost 180 loop there to get to the stomach itself. For the ERCP, I don't find it as a big problem. Just you'll be able to pass it somehow, but for the US, it's sometimes a difficulty, unfortunately.
So I'm just loading the first suture on outside of the body before I enter. Guys, can I just get buttons? Greg, do you have the button? Thank you.
The only real emergency, Dr. Shahid, I believe, is ascending cholangitis. Even for bile leak, technically they can wait a little bit if you have to do the step 2 procedure, but I think cholangitis, you just have to.
I think the majority of times where I've done this in an emergent setting, EDGE Part 1, Part 2, is for cholangitis. You know, someone who has a bile leak and does not have a JP drain or something like that in can be a problem. That would be a potential reason that you may want to do it sooner, but they can always place a drain. Can you cover this for me for a second? Just hold it, just a white balance there. Good, thank you. So that's potentially one of the reasons. Can I go help with the head? So you always close this before you pass it down.
How many bites do you usually take when you suture the axial stent?
Yeah, when I do the axios, I really only take one bite from the axios and one bite from the stomach. And cinch those together, and I do the same on the opposite end. So it's not multiple bites necessarily. You can do multiple bites. I don't tend to because I worry that when I take multiple bites, it's going to cinch the axios.
Correct.
So I'd rather keep both sutures kind of next, on top of each other. One grabbing stomach and the other one grabbing the stent.
And what about your esophageal stents when you want to anchor them?
Yeah, those I tend to do a mucosa, stent mucosa. And the mucosa bite that I do, the 2 bites for the mucosa are relatively close together. Again, you don't want them to be too far apart because you may cinch the stent closed or make it more narrow than it should be. So we're going to go into the stomach here. And then hopefully get some amount of visualization to be able to do this. Now this can be difficult. As we mentioned, we don't have a lot of space.
Yeah, you really have a small pouch here.
Yeah.
And it's great though, you protected your G junction, the jejunum is protected as well.
Yeah, we were able to accomplish that, and I'm happy with that as well. I'm getting caught up on this tissue here a little bit. There you go. So this tissue is a little bit in my way. Flora, for a sec. Just show me where I am. I just want to grab the top of the stent and then grab the mucosa above it. But I am having a little bit of difficulty. There you go. There you go. Okay, so hold on one second. So the first bite, I'm going to actually pass through the axios here. And now it's open, so I have one bite through the axios. And I'm going to try to place the second bite right above where I grab the axios here. So I want to give myself a little bit of...
Fortunately, we're not getting the best insufflation here.
Yeah.
Yeah.
It happens. You have to kind of... I need to make sure I pull this back and reload the suture.
And when the suturing device is open, sometimes that notch on top, gives us more difficulty. So sometimes I ask my tech to half close the device, just to have a better view on the actual.
So you can see that's where I grab the axios up there. I'm going to try to torque my scope a little bit so I can grab the stomach on this side here. Hold on 1 second.
I think this suturing demonstration is excellent because it shows how much you have to maneuver and torque your scope in certain cases to really get adequate bites with the overstitch device.
Get down here.
And similar to the sleeve gastroplasty, where we're constantly moving to make sure we're getting good bites. In the same way, you're demonstrating you really have to move your scope well to be able to get the appropriate bites.
And I don't know whether the audience can see, but Dr. Shahid is using suction to kind of increase the...
Torque my scope a little bit more.
Or to get the mucosa closer to his suturing device and to get deeper bite.
Exactly. And then also, turning your body is very helpful as well. So, I took one bite through the axial stent, one bite through the stomach. There's not a lot of room. I'm going to cinch these two together. So I'm going to go ahead and deploy. And let me get you can let go of the scope. I'll take the suturing device, the cinch.
Do you ever ask your techs to actually close and suture for you, just because sometimes we're locked with both of our hands getting a good position?
Yeah, sometimes, your one hand is on the scope, turning it, and your other hand is kind of grabbing the shaft of the scope and giving significant torque, and you don't have a third hand. That's where your tech or nurse are very helpful. They can help close that, the needle and help kind of with the suturing.
And what about when you're done with the edge altogether? Do you suture the fistula at that point, or do you let it close by itself?
Yeah, that's a good question, and I think there's differing opinions regarding that. My tendency when I remove the axios at the end when I bring them back the second time is to actually suture it closed. There is some data showing that these fistulas will close, or even if the fistula remains present, it's relatively small. It does decrease in size. It doesn't remain 2 centimeters in size. So the likelihood that it's of any real clinical significance ends up being relatively small. Obviously, one of the things we talk about with all these patients is that they had the Roux-en-Y gastric bypass for weight loss. There's a theoretical risk of gaining weight if that fistula remains open. So that's my reason for going in and suturing that closed. Do you tend to suture it closed as well?
I used to. But now more and more I see that most of my fistulas that I left open actually close by themselves.
Yeah.
I deliberately left 2 fistulas open with patients with pancreatic cancer that I found after the edge and they did the US, just for them to get better nutrition going through the process of chemotherapy. And both of the patients actually fistulas closed spontaneously, unfortunately.
So Haroon and Mihailo, thank you so much for the demonstration so far. We're going to have you guys continue working. We're going to move over to room 1 now for a few minutes. I'm going to toss it over to Arslan to present the case, and then over to Dr. Tyberg in room 1.
Thank you.
Thank you.
All right, everyone. So back in room 1, we have a 37 years old male patient with a history of alcohol use disorder in the past and necrotizing pancreatitis with distal biliary stricture. Previously, CBD stent was placed. He was discharged, and then he was seen in an outside hospital recently with worsening abdominal pain and fevers. And an outside hospital CT scan actually revealed extensive pancreatitis with large peripancreatic loculated fluid collections. Unfortunately, we did not have images to review that. So today we are planning to do a EUS and a possible cyst gastrostomy. And I'm going to go to room 1 and give it over to Dr. Tyberg.
Okay, hi everybody. I think hopefully you can see my EUS image. So I think this is a great learning case actually. So this patient has pretty impressive pancreatitis and his last CAT scan showed a lot of peripancreatic fluid. I always tell patients when it's disorganized, it's really going to go one of 2 directions. Either with time, it's going to resorb and get better, or it's going to start to wall off and become symptomatic, in which case it will require drainage. So in this patient, he initially got a little bit better after his initial hospitalization. And then when I saw him in the outpatient world after being discharged, he was having a lot of recurrent symptoms, including some fevers, which raised concern that actually all this fluid was starting to wall itself off. So we were able to get a CAT scan, and it looked a little bit questionable, like it might be walled off enough that it could be drained. So I brought him for EUS, which is really, I think, the best way to look and see if there is a formed enough wall for a collection to be drained. And I just want to show here the EUS image. You can kind of see there's a lot of peripancreatic edema and inflammation here, but there's really no wall around the collection. It looks really disorganized. It doesn't look formed or walled off. He is looking like he's infected, so I did actually put a needle in there and try to aspirate a little bit to see if I could get pus or any other purulent material, anything, but it's really just disorganized inflammation at this point. So I don't think that this is actually amenable to drainage. So what we're going to do is just give him a little more time. We're going to treat him with antibiotics. We're actually going to put a NJ tube deep into his small bowel beyond the ligament of Treitz and give him enteral feeding just to let the pancreas cool off a little bit and heal. And again, I think it's going to go one of 2 directions, either with time and bowel rest, it's gonna resorb and get better, or it's gonna wall itself off enough that at that point it will become organized enough to drain. So I'm sorry you don't get to see a cyst gastrostomy today and have lots of purulent material pour out at us, but I think it's a good example of how you can use EUS to really help you guide therapy and make sure that we're doing the best treatment for our patients. So I will send you back over to room 2 unless there's any questions.
Absolutely, Amy. We're gonna go over to room 2, but we did have a question. What would make you drain this before it was formed?
I think infection is really the one instance where even if something's not formed, you might want to put a drainage stent in. But this is so disorganized and unformed, and his fevers have really been responding to antibiotics. So in this case, I think we can treat him conservatively, give him some bowel rest, and just wait a little bit to see if this will form a little more so we can more safely drain it.
What would be the next steps for you in terms of following him up? Would you check an image again at some point?
Yeah, I mean, I think, he's admitted to the hospital now, so he's going to get IV antibiotics. We're going to put the NJ feeding tube in and start him on tube feeds, and then probably we're going to re-image him in a couple days and get a sense of what's happening with his pancreas. Also watch him clinically. If his pain starts to get significantly better, that might be a clue that it's starting to resorb. If his pain continues to worsen and he's very symptomatic, we're definitely going to repeat imaging and see if when this walls off, try to drain it.
Great. Thank you so much, Dr. Tyberg. We're going to go back to room 2 with Dr. Shahid, and I think he's finishing up suturing this stent.
Should we work on transferring him elsewhere where we can maintain lines of communication?
We're live.
No. What do you mean transfer? Can you go ahead and deploy the suture?
Haroon, we are back with you now. How's it going with the suturing?
I sutured the top end of the lumen-opposing metal stent and the bottom portion now, so it's 180 degrees apart from each other. So I'm going to try to pass an EGD scope through there to look at the bypass stomach and advance it into the small intestine. There is still a lot of, the angulation is a little difficult. So again, given the fact that this is not an emergent case, if I feel that there's going to be a lot of pressure on that lumen-opposing metal stent, there's no need to, push anything. We can always bring the patient back in 2 weeks once that fistula is a bit more mature, and then perform an EUS through there and an ERCP if it's necessary. But So we're going to try to pass the gastroscope through this lumen-opposing metal stent now. We're just changing scopes, so.
And Dr. Shahid does a great job checking at her patient's abdomen during the procedure to make sure we don't have tension, pneumoperitoneum, something like that. There will be some air. If you do imaging immediately after this procedure, there will be some free air just because of manipulating the cavity itself and while we were trying to place the stent. So we are not worried about that. I always say it's almost like a peg tube principle with the air here. As long as the patient is not having distended abdomen, vitals are good, I would not do anything else.
Yeah, I agree with you. So here we are now, entering, can you show Flora one more time? Sorry, I'm like losing my voice a little bit here. Flora? So I'm going to try to advance a little bit more now that I've sutured it. Now it's important to know that suturing the stent doesn't mean that it's not going to migrate, right?
Yeah.
It's still possible that the stent could migrate, and you need to be aware of that, and you need to be prepared to deal with that if it was to happen. Flora again.
And just by pushing on the bypass stomach, you can actually push the stomach away from the distal flange of the stent, which is not sutured in this case, and we cannot suture that part.
So we're in the duodenum here. There was a decent amount of resistance pushing that scope. I advanced it very gently forward, and I was able to get this into the small intestine. But there is some resistance, so it does give me a little bit of pause about trying to pass an ERCP scope through there, which is obviously is a larger diameter. So the ampulla is there on my left-hand side, and actually looks pretty normal here.
Yeah.
I don't see. So we actually got a decent view of the ampulla, which is obviously not always the case with a forward-viewing gastroscope. So we were a little lucky there. There it is again down there.
You will still do EUS in 4 weeks from now.
Oh yeah,
correct.
yeah. I think that makes sense at this point.
Tom,
Yeah.
can you give us fluoro here? As you can see, the axial itself, it changes its position a
Yeah.
little bit just from our pressure, but as long as we know it's in between or it's around that area where certainly it hasn't migrated.
Yeah. So, I mean, I think the ampulla looks okay. I don't see an obvious duodenal diverticulum. The ampulla, doesn't look like it's adenomatous, at least from this view. So, this is if you look at the left-hand side of the screen there, if I was to, oh, sorry, I was trying to pause it, put NBI on, that's your intraduodenal segment, which looks like it's bulging a little bit. Is it possible that there's a stone or something there? Definitely possible. But I think this is a good examination.
Yeah.
Obviously, the best examination is going to be with a side viewing scope and then with an EUS scope as well. So I think we're gonna leave it at that, just because of the pressure that's on that lambs. I'm gonna take some biopsies of the stomach just because there's pretty significant inflammation here, just for H. pylori biopsies.
Are you going to be putting any pigtails through the axios?
Yeah, so normally I do, and again, I think I mentioned earlier, we do it more for ourselves because I think the lumen-opposing metal stent usually will pass by itself. The pigtails will oftentimes pass by themselves. Yeah. In this case, I'm not going to because I'm so close to the GE junction, like literally a centimeter away. I don't have any room. Pigtail stent is probably going to protrude into the esophagus, and I don't really want that to happen because that may cause some discomfort and irritation. So we're going to go ahead and just close.
And I've had this issue as well. Like Dr. Shahid said, most of the time they pass, and then you get this panicky phone call in the middle of midnight, and the patient says, "Oh, I see a stent into my stool," which happened to me. So then we had to rush her, get a CT, X-ray to make sure it's not the axial that passed through.
So I think, Avik, obviously I would have loved to do the EUS through here, but I think it's going to be difficult, and I think we're gonna have some issues with it. So rather than risking dislodging this stent, I think we're gonna end the case there, and I can send it back to you if there's no other questions.
I agree with you. I think this was a great demonstration, and as we've heard many times, there's always a brain behind the scope, and you really have to think about what you're doing before you do it. And in this case, it's not an emergency. I think you've accomplished a great thing by gaining the access, and we can wait for this fistula to mature and then come back and do the EUS exam. So thank you guys for this case. We are going to send it over now to our last set of lectures. And following that will be a question and answer session.
Hi, I'm Avik Sarkar. I'm the Director of Bariatric Endoscopy at Rutgers Robert Wood Johnson Medical School. I'll be discussing updates in bariatric endoscopy and obesity medicine. I'll be discussing the goals of endoscopic bariatric and metabolic therapies, the current treatment gap in obesity management, updates in intragastric balloons, updates in endoscopic sleeve gastroplasty, updates in POSE, duodenal mucosal resurfacing, and updates in weight loss medications. In order to improve metabolic disease in our patients, we need to help them lose just 10% of their total body weight. And this can improve things like obstructive sleep apnea, hypertension, type 2 diabetes, osteoarthritis, fatty liver disease. Weight loss of greater than 10% was associated with the doubling of the likelihood of remission at 5 years in type 2 diabetes. According to the CDC, the disease of obesity affects about 93 million Americans, and the American Society of Metabolic and Bariatric Surgery estimates that about 24 million have severe or morbid obesity. Patients who cannot achieve clinically meaningful weight loss with medications or with diet and lifestyle therapy, and who do not undergo bariatric surgery fall into a treatment gap. And we can see that demonstrated here, where you have about 250,000 surgeries, bariatric surgeries that are done every year, whereas you have about 24 million patients that are eligible to have the bariatric surgery, but don't have it either because they don't meet eligibility criteria, they're not surgical candidates, or they choose not to. So you can see that only about 1% or less of patients who are eligible to have a surgery are actually having that surgery. And this is what we call our obesity treatment gap, where patients are not being adequately managed. Endoscopic bariatric therapies are minimally invasive and anatomy preserving. They're less costly, they're done on an outpatient basis, they're repeatable and reversible potentially, and they have multiple purposes. Some are done for cosmesis, some are done for a treatment for metabolic disease, some can be done as a bridge to another surgery. The first device we'll talk about is the intragastric balloon. This is a space-occupying device. The balloons can be air-filled, fluid-filled, sometimes they can be swallowed, sometimes they have to be placed endoscopically, but the mainstay of their efficacy is their space-occupying nature and giving patients early satiety. The intragastric balloon was FDA approved in 2015. Initially, the approval was for two balloons in particular, the Orbera balloon, which is still on the market today, and the reshaped Duo balloon, which is no longer on the market. We can see that the weight loss from these balloons from the current studies have shown anywhere from a 6 to 10% total body weight loss at 6 months from implantation. The balloons traditionally are placed for about 6 months and then they have to be removed. The first two balloons on this list are endoscopically placed and endoscopically removed. The last balloon on the list, Obalon, is a 3-balloon system, and it's actually swallowed for its placement without endoscopic needs, but on removal, it does have to be removed with endoscopy. We've learned that intragastric balloons are much more than space-occupying devices. We've learned that they also delay gastric emptying, and this is also part of the weight loss that it induces. In addition, gastric accommodation is altered with intragastric balloon placement, and we've also seen certain studies showing changes in gut neurohormones such as ghrelin after intragastric balloon placement. The most common adverse events noted after intragastric balloon placement are known as accommodative symptoms seen in the first week after placement. And these include pain, nausea, acid reflux. After the first week, the body tends to adjust to the placement of the balloon and those symptoms diminish. There are other more rare complications with balloon placement, including gastric ulcerations and erosions, migration of the balloon, spontaneous deflations, perforations, and certain times early removal of the balloon is required. One of the newest updates in intragastric balloons is the adjustable intragastric balloon. This is a silicone-filled balloon with saline and usually a blue dye. It has a unique capability to endoscopically increase the intragastric balloon volume to augment treatment effect, and it can also be decreased in volume to mitigate intolerance, and it's thought to enhance efficacy and prolong therapy duration. There was a prospective, open-label, multi-center randomized clinical trial conducted on the adjustable intragastric balloon at 7 sites in the United States. The inclusion criteria included patients aged 22 to 65 with a BMI of 30 or greater and less than 40. Major exclusion criteria included prior gastrointestinal surgery, inflammatory conditions of the GI tract, hiatal hernia greater than 2 centimeters, and gastroparesis. Patients were randomly assigned to receive the adjustable intragastric balloon plus dietary and exercise counseling, or dietary and exercise counseling alone for 32 weeks. The adjustable intragastric balloon was implanted at an initial volume of 400 milliliters to 550 milliliters, depending on the patient's height and presence of GERD symptoms at baseline. All patients followed a 1,000 to 1,200 calorie a day diet during the study. At the end of 32 weeks, the adjustable intragastric balloon was removed and the patients were followed up for another 24 weeks. The adjustable intragastric balloon volume was adjusted according to 3 different scenarios. Volume could be increased by 250 milliliters if within the first 2 weeks the patient did not show a treatment effect. It could be decreased by 100 to 150 milliliters for symptoms of intolerance. And then at 18 weeks, patients meeting pre-specified criteria could undergo additional endoscopic adjustment procedures to induce greater weight loss. Between 2016 and 2018, 288 patients were randomly assigned to either the adjustable intragastric balloon or the control group. Patients in the intragastric balloon group had a mean baseline age of 44 years. 87% were female, and the mean BMI of this group was 35.8. 83% of patients in the adjustable intragastric balloon group completed the full 32 weeks of device implantation. 17% required early device removal. 80% of the patients in the adjustable intragastric balloon group completed the 6-month follow-up phase after device removal. The adjustable intragastric balloon, in conjunction with diet and exercise, achieved 15% total body weight loss at 32 weeks, with a substantial margin over diet and exercise alone, which at 32 weeks achieved 3.3% total body weight loss. Response rate exceeded 90% at 32 weeks, with 74% of patients in the adjustable intragastric balloon group maintaining weight loss at 14 months. As we can see from the figure, 70% of patients in the adjustable intragastric balloon group underwent upward adjustment or upward and downward adjustment. Upward adjustments delivered in this study at 18 weeks afforded these patients an additional 5.2% of total body weight loss by month 8 of implantation, and overall a 3.1% greater total body weight loss than those patients who did not undergo any adjustments. No patient deaths were reported. There were no balloon deflations with migration into the small intestine, obstructions, pancreatitis, or perforations. One balloon was found deflated within the stomach at 32 weeks at the time of device removal. The most commonly reported non-serious adverse events were nausea, dyspepsia, vomiting, and abdominal pain. Most of these symptoms were restricted to the first few days after balloon placement, and they were managed successfully with medication or downward adjustable intragastric balloon adjustment. The next procedure we'll talk about is the endoscopic sleeve gastroplasty done with the Apollo overstitch system. ESG is done with the use of a commercially available full-thickness endoscopic suturing device, and as I mentioned, the Apollo overstitch system. This is approved by the U.S. Food and Drug Administration, and using this device, you can imbricate the majority of the stomach by serial interrupted sutures placed from the incisura to the cardia. There are several studies looking at safety, efficacy, and outcomes of this procedure. In particular, this meta-analysis evaluated 8 original studies from 2016 to 2019, including 1,772 patients. The mean age of the patients was 38 years old. The BMI was between 33 and 43. And at 6 months post-procedure, the mean total body weight loss achieved in this group was 15.1%. At 12 months, 16.5%. And between 8 and 24 months, 17.2%. The longest follow-up we currently have is 5 years, and this is from a single center study involving 203 patients. They were able to show 5 years from the procedure, a 15% total body weight loss can be maintained. The endoscopic sleeve gastroplasty is a very safe procedure. In this study of 1,607 cases, serious adverse events were noted to occur at a rate of 1.1%. There were no deaths. There were 7 intra-abdominal collections, 6 cases of hemorrhage requiring transfusion or endoscopic intervention, 3 cases of refractory symptoms requiring ESG reversal, 1 pulmonary embolism, and 1 pneumoperitoneum and pneumothorax. Similar to the intragastric balloon, we've learned that ESG is not just a restrictive procedure. In this study from the Mayo Clinic group, we've learned that ESG causes a delay in gastric emptying and accommodation, and this is partly also the reason we see the weight loss from this procedure. We've also learned from the Mayo Clinic group that active fasting and postprandial ghrelin levels decreased by about 30% 3 months after the ESG procedure. In addition, we see significant improvements in insulin sensitivity. The newest and most exciting news about the endoscopic sleeve gastroplasty is the publication of the MERIT study. This was the multi-center ESG randomized interventional trial conducted between 2017 and 2019 at 9 U.S. academic and community centers. Participants were randomly assigned to ESG or control group. The ESG group had 88% women. Baseline age was a mean of 47 years with a mean BMI of 35. In the ESG group, 68 patients completed 1-year follow-up. 1 patient did request ESG reversal during the study period due to intolerance, which was successfully done. In the control group, 89 patients completed 52 weeks of follow-up, and 72 participants in the control group crossed over to the ESG group and completed an additional 52 weeks of follow-up. As we can see from the figure, the mean percentage of total body weight loss at 52 weeks was 13.6% for the ESG group compared to 0.8% for the control group. Participants in the primary ESG group maintained 83% of the reached excess weight loss at 104 weeks, which is equivalent to an 11.4% total body weight loss maintenance. Diabetes improved clinically in 93% of patients in the ESG group compared to only 15% of patients in the control group. Hypertension improved in 60% of patients in the ESG group compared with 40% of patients in the control group. The ESG group had HDL increase, triglyceride decrease, and improvement in waist to hip ratio compared with participants in the control group. Metabolic syndrome significantly improved in 83% of patients in the ESG group compared with 35% of patients in the control group. Because of the great results of the MERIT study, the FDA has granted authorization for Apollo Endosurgery to market its Apollo endoscopic system for the treatment of patients with obesity. This will increase awareness of the procedures amongst patients and referring doctors and help us start to make an impact on the obesity treatment gap. The next procedure I'll talk about is primary obesity surgery endoluminal, the POSE procedure. POSE utilizes an incisionless operating platform system to create full thickness plications in the gastric fundus and body, which was the original POSE study. And this leads to reduced gastric accommodation and delayed gastric emptying. POSE 2 is the maturation of the POSE procedure, and it's also known as distal POSE. In the initial study, the anchors were placed mostly in the stomach body as well as in the fundus. We've learned that focusing on the gastric body has a more significant effect on gastric motility and consequently leads to a higher weight loss. So in the POSE 2 study, placement of anchors were solely focused on the gastric body and the fundus was spared. This picture on the left here is a representation of the POSE procedure and what the stomach would look like after the POSE procedure. The video playing on the right here, you can see the device in action and the full thickness plications being placed. A study looking at distal POSE included 75 patients with a mean BMI of 38. 46 patients reached 1 year. Percent total body weight loss at 1 year was 17.8%. 15 patients returned at 1 year for a repeat endoscopy, and in this group there was an average total body weight loss of 19%. Plications were intact in all patients. The gastric length was significantly reduced compared to the pre-procedure gastric length, and the tubular shape of the stomach was maintained. The next procedure we'll talk about is duodenal mucosal resurfacing. And in this procedure, hot water is instilled in a balloon, and this ablates the mucosa of the duodenum. It applies a superficial ablation to approximately 10 centimeters of the duodenal mucosa distal to the ampulla. You can see here on the video the design of the catheter. The premise of the procedure is that we've seen that limiting nutrient exposure or contact to the duodenum exerts powerful metabolic effects. Duodenal mucosal resurfacing targets the specific biology with the assumption that the duodenal surface is in some way mediating an abnormal signal that emanates to endogenous insulin-sensitive tissues. Resurfacing through hydrothermal ablation allows a restoration of a normal mucosal interface that corrects this abnormal signal. This therapeutic strategy aims to decrease anti-incretin role in the proximal small bowel and serves as a possible therapy for patients with poorly controlled type 2 diabetes. You can see here the balloon applies some suction, which allows the needle to be inserted into the mucosa, and then an injection to be placed into the submucosal layer to lift the submucosal layer off of the muscularis propria. Subsequently, an ablation is performed, and that submucosal cushion prevents deeper tissue injury, but allows duodenal mucosal ablation with eventual resurfacing occurring. The first in-human study was conducted in 2019, and in this study you can see the weight loss is very modest. This procedure is not designed to have a great weight loss. It's more designed at metabolic effects, specifically with improvements in diabetes. And you can see in this study, after 24 weeks from the procedure, hemoglobin A1C dropped about 1.3 points. A larger 46-patient study was conducted for patients with a BMI between 24 and 40 with type 2 diabetes and a hemoglobin A1C between 7.5 and 10 on stable oral glucose-lowering medications. 24 patients had at least one adverse event related to the duodenal mucosal resurfacing, and 81% of those were mild. 24 weeks post the resurfacing, hemoglobin A1C dropped about 1 point and insulin resistance improved. Weight was modestly reduced and hepatic transaminase levels decreased. The effects were shown to be sustainable for 12 months. A systemic review and meta-analysis was conducted on 4 studies with 127 patients and showed similar results with hemoglobin A1C reduction by about 1 point after 6 months from the procedure. The fasting plasma glucose also decreased, and improvements were noted in AST and ALT. There are several candidates for endoscopic bariatric and metabolic therapies. These include patients with a BMI of 30 to 40 who have failed attempts at diet and lifestyle modification, patients with a BMI greater than 40 who do not want surgery or do not qualify for surgery, patients looking to treat metabolic disease, patients looking for a bridge to another surgery, such as organ transplant, joint replacement, or a bariatric surgery in the future for a super obese patient. Ultimately, it's important to understand the patient's weight loss goal and direct them to the best endoscopic, bariatric, or metabolic therapy. I'll end today's discussion by briefly touching on some of the newer weight loss medications. Newer treatments using GLP-1 agonists or in combination with other agents such as amylin analogs have shown promise in inducing weight loss in conjunction with lifestyle modification. However, when the drug is discontinued, weight regain can occur, necessitating long-term drug dependence and cost. GLP-1 receptor agonists are a class of anti-diabetic medications that have shown promise in encouraging glycemic control and promoting weight loss in patients with or without type 2 diabetes. Wegovy, or semaglutide, was shown to be very effective in the STEP 1 trial. This was a double-blind trial of 1,961 adults with a BMI of 30 or greater, or 27 or greater in persons with one or more weight-related coexisting condition. None of these patients had diabetes. Patients were randomly assigned in a 2-to-1 ratio to 68 weeks of treatment with once-weekly subcutaneous semaglutide at a dose of 2.4 milligrams or placebo plus lifestyle intervention. The mean BMI of the patient population was 37. The mean change in body weight from baseline to week 68 was about 15% in the semaglutide group, compared to about 2.4% with the placebo group. Nausea and diarrhea were the most common adverse events with semaglutide, and they were typically transient and mild to moderate in severity and subsided with time. Semaglutide is not recommended if there's a family history or personal history of medullary thyroid cancer. The last drug I'll mention is tirzepatide, and specifically the SURMOUNT-1 study. This was a phase 3 double-blind randomized controlled trial. Tirzepatide is the first dual GIP and GLP-1 receptor agonist. In the study, 2,539 adults with a BMI of 30 or more, or 27 or more, and at least one weight-related complication excluding diabetes. Patients were randomized to receive once-weekly subcutaneous tirzepatide, either 5 milligrams, 10 milligrams, or 15 milligrams, or placebo for 72 weeks. The mean BMI was 38 for the group, and about 95% of participants had a BMI of 30 or higher. The mean percentage change in weight loss at week 72 was about 15% weight loss with 5 milligram weekly dose of tirzepatide, about a 20% total body weight loss with the 10 milligram dose, and about a 21% total body weight loss with the 15 milligram dose. And this was compared to just a 3% weight loss with placebo. In conclusion, a full spectrum of care is essential to optimally treat obesity. As we have seen, endoscopic innovation continues, and endoscopic therapy will be essential to make a dent in the obesity treatment gap. Medicines also, as we've seen, are rapidly improving and becoming very effective with minimal side effects, and will also play a very important role moving forward.
Greetings, Manuel Galvão Neto, and it's a pleasure and honor to be with you among another MAGIC course. And I wanted to thank you very much, Dr. Michel Calais, for the invitation. And my topic today will be to discuss with you about endoscopic solutions to bariatric surgery complications. And this is my disclosures that have nothing to do with this specific presentation. And bariatric endoscopy is being mature in the last 20 years. As you can see, at least in Brazil, this is be growing, and we have lots of books written in Portuguese, Spanish, and English. And endoscopic treatment of complications expanded a lot, and it is such a big matters that we have to concentrate on the specific ones. And also to let you know that bariatric surgery is as safe as a lab chole, but we're going to discuss complications, so don't get into the mind that this surgery has lots of complications, because just we'll discuss this. So let's focus on sleeve gastrectomy leaks. Why? Because it's a very peculiar type of complication, the complications of sleeve gastrectomy, the leaks and the stenosis. And it involves all the therapeutic options that we have. So we choose to focus on that specific one. So by doing that, we can advance more on the topic. They'll just touch on that. So what is the sleeve leak? So it's have to be a very simple operation. So the surgeon will put a bougie inside, will take down the vessels and the nerves of the greater curvature and use this bougie to very anatomically to staple from bottom to top with this bougie that serves as a ruler. So what can be wrong? What can be wrong is that on the beginning, there was no really knowledge of what the physiological changes that is involved in this operation. So let's start with the vascular supply. You can see here that the stomach has a very good vascular supply, 5 arterial branches. You can see it cover basically everything besides the His angle. Also, the His angles have 3 layers of muscle, and when they do a gastrectomy, they take the greater curvature. There's nothing to block if you have a leak. So by obligation, this leak will be have a long, tortuous, and complex pathway getting out. Also, it's so high that it's under the negative pressure from the thorax. And very long, staple line with intersections that can lead to local ischemia on that. The stomach wall also varies a lot on its thickness from the entrance into to the fundus. And the sleeve stenosis is very tricky because the dogma that we have in endoscopy that if my scope doesn't pass through, we have stenosis, doesn't apply here because your scope will pass through that. And then what matters the most is axis deviation and tortuosity on that sleeve. So as you can just state, that can be very tricky, and I will just anticipate how important it is in terms of pressure. So how is the sleeve endoscopy anatomy? So it's a tube after a tube. So it's a tube after the esophagus. So your scope have to slide very like smooth to the smaller curvature, and you can identify the esophageal junction, the body, the tubular shape, so you can see what is the analog greater curvature at 9 o'clock, the smaller curvature at 3 o'clock, 12 o'clock anterior wall, and 6 o'clock posterior wall. Have to be like this until you get to the incisura. So incisura is very well defined, and you should see ahead of the incisura. If you don't see ahead of the incisura, like it blocked, possibly you have some issue on that. And if you have to put in your scope the wheel on an up more than 15 degrees, and you have to turn to the right in more than 15 degrees as well, possibly you have an axis deviation that you have to report. Getting to the antrum, you have to identify if the surgeon had done anthrectomy partially or not, or just didn't touch the antrum, and you can measure from the pylorus to where the staple line starts, like around 6 o'clock. You can see the distance that and you can have to report the distance from the pylorus that he started the staple line. So look at the screen. What nobody expected is all about pressure. A regular stomach is a low pressure, high compliance system. And when the surgeon builds the sleeve gastrectomy, they change it to a high pressure, low compliance system. And that's what's so true nobody was really expecting that. When it begins, 2005, the first report of those leaks becoming chronic, ending up on total gastrectomy, as you can see here in one of our papers on that. And leading even and waking up this monster that is the gastrobronchial fistula that was dormant before the sleeve gastrectomy. It was only happened on mediastinal operations or anastomosis. And then we see this report, like our paper in 2011, that we report 15 cases that very, very like aggressive and leaks to the lung. To note and to prove to you what we just said that about pressure. So you see this paper from bioengineers from Italy, that they build bench models of regular stomach, adjustable gastric band, sleeve gastrectomy, and sleeve gastroplasty. And you can see on the upper part, they are not pressurized. On the inferior part, you can see when they pressurize it. If you see L1 and L2, the sleeve gastrectomy, you can see how you increase the pressure. And if you see the gastroplasty models, this pressure is distributed alongside on that. So really, it is a high pressure system that is created by the surgeons. And also we demonstrate that with papers from high resolution manometer. You can see here in the inferior color bar, the stomach is pressurized from pre to post, left to right. You can clearly see here. Plenty of publications identify that, and even ourselves in our services from our own service, you can see here that below the inferior esophageal sphincter, you see a pressurized zone that it refers to sleeve gastrectomy on that. Also, it induced reflux. So there's a lot of papers and a lot of evidence saying that the sleeve gastrectomy is refluxogenic, as you can clearly see here in this impedance on the left side of the reflux that can really be long and can be go up to the upper part of the esophagus. What are the surgical options that we have? The first one is that we have to be interested in that is how they deal with initial leak. So those leaks tend to happen late, around the second week when the patient is home and eating. They feel a shoulder pain, and it becomes with fever or tachycardia. And then when the surgeons call the patient back, intervene, they find the leak or the abscess. The first thing they have to do, they have to clean it, they have to watch it, they have to drain that by laparotomy, laparoscopy, or even percutaneously. And chronically, it can be converted to a Roux-en-Y gastric bypass. So you have a sleeve leak, you have a bypass leak if you do that chronically, or you can do a very efficient ways and very complicated and complex operations like esophagojejunostomy and total gastrectomy. So let's see this literature review coming from France. So what they offer on that, you can see here how they select the papers, but important are the options. So you can see here from left to right, the conversion to gastric bypass, the esophagojejunostomy, preserving the stomach, and the total gastrectomy. But if you go down to the left, look at that. The conversion rate can be high, and the leak rate after those procedures can be high. So we, if possible, we should avoid that with our endoscopic treatments on that. And endoscopic treatments, there are plenty of. So very good news to all that are watching us is that we have a lot of options. And a not that good news is that we have a lot of options. And each one of the authors that do one kind of the modalities that you can see on the screen, pigtails, stents, chalazion balloon dilation, suturing, occluders, sponge, over-the-scope clips, septotomies, each one defends his own technique, and there is a bias on all the articles published up to now, and it's hard to find an unbiased algorithm, so we have to work on that. But let's show you what's that. So the classification of the leaks, most of the papers published use this classification coming from this international sleeve gastrectomy expert panel consensus that up to now and since 2011 have almost 1,000 reference on literature about this paper. And it divides in 4: acute, early, late, and chronic. or you can put together acute, early, late, and chronic because they kind of behave the same in the outcomes. The first treatment we see in the literature is stents. So you can see here that stent can occlude the hole and can pass through the incisura, releasing the pressure. So it's one of the most used and the oldest therapeutic that is efficient in terms of this. So let's take a look on this meta-analysis specific to sleeve leaks from 2018 from São Paulo University that have become very specialized in analyzing other people's work. So they did this very good meta-analysis, 24 studies, 187 patients. And if you use any kind of stent, you're going to have 72.8% of healing rate. So the leak side, as we anticipate, is upper part. That is the his angle. You can see here, approximately 94% of those leaks. And the timing to intervene with a stent is more from acute and early. You can see if you put together, it's almost 90%. And as time passes, the efficacy of the stent decreases on treating those leaks. And also, you will see here that the stents per patient is 1.4. So it's anticipated that you must need to do more than one intervention with the stent for those patients with sleeve leaks. And the diagnosis for intervene is very early, 3.3 days. And the duration of the stent in place is around 1 month, 48 days. The Achilles tendon of this technique is the migration rate that can rate that can goes up to 30%. So as a meta-analysis, you don't get case reports, so there's no data on fistula size, no report of perforations, and just 2 bleedings requiring additional procedures, no death report that we know that can happen with the stents. If you use specific stent, meaning the bariatric one, so look at this paper that was published by our group in Brazil by Dr. Luis Bezerra, his master degree series, and you can go up to 100% success rate, but please read the small letters. All the patients have lots of symptoms, nausea, vomiting, thoracic pain, up to 5 days. You have to take care of these. You have to survey your patient each other week to see if the stent in place, but with that specific stent, we got almost a half of migration rate on that. What happened? If you go from tertiary center dedicated to bariatric endoscopy to general centers that do bariatric endoscopy also and not dedicated to that. So you can see here using much more sophisticated stent that you have at that time of the previous publication, more people involved. And you can see here that the treatment is very effective on that. We reach 82% of healing rate, but at the price. So those big stents, they'll have to be surveyed. So letter A is a perforation on the thorax. You can see here the mediastinum. Letter B is the stent on the bow. Letter C is the stent removed by surgery. Letter D is a contained perforation. Letter E is a distal ulcer. Letter F is a submucosal abscess drained by endosonography. So this is a downside of using the stents. And even this very scary publication coming from France with patients that poor follow-up that can lead to aortic injuries with those kind of big stents. So these patients can have to be surveyed after the implantation on that. So that's main message for this, but it's highly effective. Also coming from French, there's a very nice option that's a double pigtails, very easy to implant, very easy. Most of the therapeutic senses can do that. You can use 5 French, 7 French, 10 French, as much or more that it calls. You can see the radiological picture. It calls internal drainage. Why? Because you have one tail on the abscess and the other tail on the lumen, so equalize the pressure and have a high success rate on that. So look at this literature review, and you can see here most of the papers come from France, as you can see here, 681 patients with just 13.73% of complications, and the complications are not as severe as we can see on stents, and you see 84.42% success rate on that. Another option that is newer is the EVAC that is taking kind of the world on that, and is very effective for, as we can see here, those disasters, the septic disaster mediastinals on the inferior rector with descensor anastomosis. They're very, very effective. And this it's coming on first studies, specifically from the esophagus. And this one is the very first that is applied to bariatric surgery in 2013 in a Roux-en-Y gastric bypass that successful used the sponge. The downside of this is that you have to remove the sponge, you have to exchange the sponge from time to time, and maybe it's in an overkill for sleeve leaks that don't have those septic disasters, most of them. As you can see here, like this paper, with 100% success rate, but 10 procedures per patient, 50 days of treatment, and even on the evolution of the sponge that they use, like 4x4 gauzes, plastic dressing, multi-perforated on that. You don't need to exchange every 3 days or exchange every 7 days. It had begun in Brazil, but you can see here, good success rate, 87%, less changing of the system, but still 19 days in the hospital with that. And this is original paper coming from Dr. Flaubert from Brazil that was presented in DDW and also published, that the use of this kind of 4x4 gauze and plastics to cover that. But still, the vacuum can have complications. That's all the procedures that you can see here with those bleeding episodes reported. The septotomy was developed in Brazil by our group and Dr. Josenbeck Campos. And basically, you're going to cut the septum when it is for chronic leaks. You cut the septum and you aggressive dilate with pneumatic balloon dilation. And you reroute the path of the flow, the food, and also you take down the pressure on that. And as our first publication showed, it's a very effective model that was reproduced all over the world, also in US. You can see for chronic leaks and the success rate in 5 patients on that. And also that those are the reports on literature from that. And the suturing is very appealing. Why not suture? Because it's not going to work. If it doesn't work, the laparoscopic suture, wide endoscopic suture will work. But that said, you can use the endosuture or clips or whatever to fix the stents in place. So you take the Achilles tendon, that is migration rates from the stents. It's a very effective technique. You suture the stents in place. Also, you can use over the scope clip that was like hyper well evaluated on the first papers, but look at this in you when the hype comes down and it comes the reality. So look at this paper that 26 leaks, the over the scope clips were used and up in 11 total gastrectomies or esophageal because this clip actually occupies space, increase the pressure, and it's not easy to apply that on a tangential target. It was designed to be applied on a perpendicular fashion, and it can be used, but more for chronic leaks, and the efficacy is on jeopardy right now, so it's challenging. Those occluders come from cardiac surgery. They seem to be very effective, especially for chronic leak and sleeve leaks on this paper. They're very expensive and they're cumbersome to both by endoscopy, but they prove that can help. So the idea is take down the pressure also. So you have this auxiliary method that is the aggressive pneumatic dilation that we described for the first time in 2010 with this specific achalasia balloon up to 20 psi. And you open up the balloon and you break the fibers and you take down the pressures. As you can see here, the balloon will break. You can see here the waist of the stenosis very efficient, in a very efficient way. So we can measure that by the end of flip, how successful it is. So you can see here, we have all of those methods to the sleeve leaks. And on the subject comparison of those, for acute and early, stents, pigtail, evac, later chronic leaks, septotomy, pigtails, occluder, evac, high technology, higher price, stents and occluder, low tech, lower price, pigtails, septums, and evac. So easier for the patient, they do the procedure, patients go home, pigtail occluder septotomy, harder for the patient are the stents and the evac. Brief of stop stay, pigtails, stents, occluder, septotomy, and longer stay for sure evac. And I'll end with this message that the treatment of sleeve leak, the treatments, they are complementary, they are not competitive. There's no such thing of the best one, and sleeve leaks are always complex. Look for strictures and kinks, and there's a clear need for an unbiased algorithm. So thank you for the opportunity, and I hope it can be at help.
Hi, everyone. Welcome back. Thank you for joining us for our last Q&A session. We just finished the bariatric and obesity medicine lectures. I'd like to welcome Dr. Manuel Galvao Neto. Thank you for joining us. Thank you for that wonderful lecture. We have a few questions that have come in. I will start with the first question here. What's your algorithm for chronic gastric sleeve leaks? What do you go to first?
Yeah, possibly, as you can understand from my presentation, there is not a clear, unbiased algorithm available. So it means that each one who do the technique they say that's the best. So I'll tell you, and my algorithm, but possibly it is biased by myself. So in acute leaks, I still use stents. I use the bariatric stents, acknowledging that they are tough for the patient. They lead to a lot of symptoms. They lead to a lot of, it's a labor-intense follow-up, not to allow it to dislodge. Those big ones, suturing on the proximal part eventually cannot prevent it to dislodge, but a good follow-up will. So we have around 18% of dislodgement, but you can correct that. So after that, and you go entering in the third week, I go for pigtails. Okay. If they come to me later or chronic, I will do septotomy plus pigtails and aggressive achalasia balloon dilation. I personally think that the EVAC is overkill and should be left for services with not that amount of skill set and not where technology is not available, and that can stay, it can hold the patient in the hospital for quite some days, much more to the other techniques. I don't believe in Ovesco. I don't believe in any other those clips. I don't believe in suturing directly the hole, because when you do that in sleeve leaks, you don't observe the treatment of the root cause of this, that is the hyperpressure system. Very chronic leaks like the gastrobronchial leaks, if we cannot address with that, I'll try, go to an occlusion method, eventually an occluder or synthetic mesh that you can pass percutaneously with the scope and things like that. So this is my algorithm on that. Always try to address the root cause, that is twisting, that is increase of pressure on that.
That's a great method, and thank you for sharing that. And yeah, to your point, we've had success with using something here. We have a vascular plug, and we've used that very well for some of these chronic, like gastrobronchial fistulas. What's your opinion on external drains being placed in these leak cavities?
They should be placed. They should be placed if you do not have access to someone that could immediately go for internal drainage. Or remember, if you go to a stent, you need external drainage, a self-spendable stent. All others, internal drainage and EVAC, it is an internal drainage. All of them demand that if there is external drain, it have to be removed. So we have to remind that the first responders for a leak not going to be us. The patient going to get into the hospital with sepsis, and the standard of care is to drain that and control the sepsis. So that's when we're going to see the patient. If for any instance, or if you have an integrated service that can act like now, so I have done quite some interventions without external drain, but the timing have to be exactly.
When you get a patient who has an external drain, do you favor converting that over to an internal drainage, and then do you remove the external drain?
Indeed. Depending on the patient, I can remove right away the drain on the same procedure. So like if I see the drain, by endoscopy, this drain will come out. If I don't see the drain, or there is a tragic, it can go like 1 or 2 days just adjusting the removal of the drain in few or sessions or days.
Great.
But if you don't do that, your internal drainage is not going to work.
Right. In your talk, you mentioned a lot about angulation and also stenosis. How aggressive are you with the pneumatic dilation? How high do you take the pneumatic dilation?
Yeah, that's a fantastic question. I am very aggressive up to 35. 40, you're asking for trouble. All the perforations come 35 and over. And if it doesn't respond to 30, it will not respond to 40. So go up to 3 sessions. See if the patient gets better to each session. If the patient gets better, so you're progressing, keep going. But like you do one and everything comes back. You do the second, everything comes back. You do the third. I don't think that maybe at 35 can be, but 40 they are very aggressive, and all the perforations, complications that I have saw is with 40. And personally, I think you have to put a limit to what you're doing. So not just being aggressive, and think that's going to work. It's not going to work. So I will stop on 35. And most of my treatments, they can be done with 30s. Safe side.
We have a couple of more questions here. So in patients who do not respond to pneumatic dilation, do you prefer stenting, or do you prefer possibly like a stricturoplasty or kind of tunneling procedure?
It will really depend on how biased you are. So you are isolated. Your system, your services, gastrointestinal is isolated. You do not have integration with surgery. Keep going. But if you think in the patient, don't do that. Go for surgery. Ego should not become on the front of patient safety. If it's not responding to 3 pneumatic dilation, what are the benefits of leaving a stent? Stent is okay, because you put below the esophagus, patient don't feel that much, it's worth a try. But stricturoplasty, to me, is too much. And if you have an integrated service that this should be a multidisciplinary team, that's the time you call for surgery. I will go for stricturoplasty if the patient don't have a surgical option.
Great. And one last question that we'll give you before we close is, what do you think is the future of endoscopic bariatrics? What do we have to look forward to down the pipeline?
If with two answers on the same basket. So in terms of endoscopic treatment or endoscopic solutions for bariatric surgery complications, we are the mainstream. We are the mainstream. If our scope reach, we are the mainstream. And then if we eventually fail to go for surgery, all this should come first. In terms of endobariatric therapies, we are gathering momentum. I think that we are on a spark or even close to the same inflection point that we saw with endovascular therapy in cardiology. So in cardiology, open heart surgery was once the mainstream and now it's not. It's the endovascular plus drugs. And we are proving with some of our randomized trial that at least for endoscopic sleeve gastroscopy, adding drugs like GLP-1 analogs, liraglutide, semaglutide, we reach surgical results. So what we have to understand as a group and as people trying to treat obesity is that we don't have to be better. We don't have to be as good. Cardiology show us that you have to be just good enough, because endovascular procedures are not better than surgery. They're not even as good. They're just good enough. And that will be where we're gonna get scale, the same scale of endovascular. And if we don't mess it up, I think that we might be near to this inflection point.
That's a great point and very, very well said. Thank you so much for joining us, Dr. Galvão Neto. Thank you for your talk. And thank you everyone for joining us for this
Magic Conference. We're going to send it over now for some closing remarks.
Thank you very much.
Hello, everyone. It is the sweet and sour moment now to, unfortunately, close this fantastic course, Magic 2022. I want to obviously thank our fantastic live faculty, Amy, Haroon, and Avik for doing an amazing job. Our hands-on faculty to run all those 19 stations. Our moderation faculty, Nikhil Kumta and Prashant Kedia, who were just fantastic in moderating and supervising all those live cases. We really owe it to you to have those fantastic discussions. Our advanced instructor preparing the cases, presenting them, our nurses, our X-ray tech, all the nurses and nurse practitioners behind the field, obviously our industry friends. Those courses wouldn't be possible without your support and your funding. AV support was crucial. I want to thank Elisa and her team for all the tremendous work in giving us fantastic image with beautiful connection and streaming. And I want to give a shout out to Dylan, arranging seating and admission at the Hyatt. We also have to acknowledge Monica, who's been working behind the field in making this conference feasible. Thank you all for joining us, and I'm looking forward to see you very soon for Magic 2023. Have a fantastic weekend.
It's a kind of magic, a kind of magic. One dream.